Good morning. We're ready to get started. My name is Dr. Rola El-Serag. I'm the director for the Center for Health and Biosciences here at the Baker Institute. We welcome you to the Baker Institute for Public Policy and to our second annual event, Preventing Firearm Injury in the Greater Houston Area Through Purpose and Policy. Today is National Gun Violence Awareness Day. Today we pause to remember the millions who have lost their lives to a firearm tragedy and work collaboratively to raise awareness on the efforts of many who are working diligently to reduce the number of people who are impacted by firearm injury and death. Firearms are the leading cause of death in children, surpassing motor vehicles, and we need to consider this as a public health crisis as we work to address not only how to stop the injury and deaths from firearms, but the impact on the lives of all who have been touched by firearm violence. Those who have lost a loved one to firearm suicide or experienced a threat from a firearm from a domestic partner, or even had a child in a school that was on lockdown due to a threat. These are real incidences that impact many of us, and we must look to actionable solutions. Today, we are honored to bring you an exciting day filled with experts in their field to help promote conversations to discover what is currently being done in our communities and where action and collaboration can occur for the future. Our sessions are panel style, with each session having a moderator that will guide the conversation to learn about how we can act and collaborate. At the end of the panel, there will be opportunities for questions, and question cards are available on the tables. Following each panel, we want to promote continued conversations and collaborations, and we will ask that each table spend a few moments discussing what resources and actions they need in order to address the points brought up in the panel. These will be the stepping stones for future collaborations with our Firearm Injury Prevention and Safety Center within the Baker Institute. Our focus is to generate collaboration and community through conversations. For a few housekeeping points, we will have 2 scheduled breaks as well as a lunch. During breaks, we will be displaying electronic posters from a variety of our partners who are engaged in firearm injury prevention work. And these will also be available on our website. I want to extend a sincere thank you to our sponsors for this year's symposium. UTMB Center for Violence Prevention and Memorial Hermann Hospital are both our silver level supporters, and UT Health Houston and Baylor College of Medicine are our bronze level supporters. It is because of the support and investment of our partners that we are able to continue to bring leaders together to address this critical topic. I would like to thank our many speakers, moderators, and staff who have worked diligently to assist in the planning of this event. I would also like to thank our planning committee, led by our own Drs. Sandy McKay and Bindi Nayak, who have thoughtfully worked to develop a program that I believe is truly fantastic, capturing the depth and breadth of firearm violence in our region. We hope to inspire collaboration and change. Thank you, and now I would like to turn it over to Dr. Nayak, who is one of our fellows in firearm injury prevention and safety. She is chief of pediatric surgery at UTMB, a pediatric trauma surgeon, and we look forward to a day filled with some exciting and very thoughtful discussions. Thank you.
Good morning. Thank you so much for being here this morning. You may notice a lot of us are wearing orange today because today's the official Wear Orange Day to raise awareness about gun violence, which we know is such a big problem in our country and city. It is my distinct pleasure to introduce our keynote speaker, Dr. Rochelle Dicker. Dr. Dicker is professor in residence of surgery and anesthesia at UCSF. She started today, I think, is her first day. She just moved from UCLA, where she was she co-chaired the UCLA Health Equity and Translational Social Science theme for the School of Medicine and was co-director of the program for the advancement of surgical equity. She's a trauma surgeon and a personal friend and someone that's inspired me for many years. In 2003, she founded the Wraparound Project at San Francisco General Hospital, which is one of the first hospital-based violence intervention programs based on integrating credible messengers and addressing the social determinants of health. This was one of the 7 startup programs that founded the National Network of Hospital-Based Violence Intervention Programs, or the HAVI, now called the Health Alliance for Violence Intervention, or the HAVI. This organization is now home to over 60 full and startup programs. Dr. Dicker is the advisory board chair of the HAVI. And it is our distinct pleasure to have her here today, visiting us all the way from San Francisco, to talk about the importance of HAVIs and HVIPs and how we can also do the same here in Houston. Thank you.
Good morning, fine people from Houston. I've already had an opportunity to meet some really lovely people who already understand that violence really is a public health issue. And I know many of you are already very engaged in this work. And whenever I get the real honor to be at a place like this, I always, as I said last night to Bindi, I always learn a lot more than I can give. So thank you already for your incredible hospitality. And I'm so happy to see many of you wearing orange. So I'm going to talk to you about hospital-based violence intervention programs. But I'm going to also give you a few other ideas around what was already said about collaboration and community, because the one thing that I can tell you is that this work is incredibly humbling. And if you go into it thinking that you're going to be a hero, you're going to be mistaken. It takes a village. There is no question about that. So we'll go through some of this really hard work today. We'll talk about characteristics of risk, because it's really important to understand, and we know this as trauma surgeons, that if you're just working at the bottom of the waterfall, you're not going to solve solutions. You're not going to come up with a lot of solutions. So we'll talk about risk to understand how to get upstream, to talk about real solutions. And then some of the strategies. I'll touch on trauma-informed care, which really is part of hospital-based violence intervention. And we'll talk about social care and the community violence intervention, or CVI, that you hear a lot about, even at the federal level at this point. And investment in community, which is so essential for all of us, especially coming from a huge city like this in Houston. And then advocacy. And they're all tied together. So first, many of you in this audience already know that the impact of the social determinants of health cannot be overstated. In Los Angeles County right now, it's thought that the social determinants of health, whether it's a positive or a negative, impacts about 70% of our overall well-being or lack thereof. 70%. And here it shows as 40, but this study was done Los Angeles County-wide, and in many large cities, that's also the case. And physical environments, so just a lack of green space, also leads to worse health outcomes. So we learn a lot in medical school and nursing school, different health sciences, about genetics. But really, if we were going to be commensurate about how much we should know about the social determinants, we're not even close in teaching our medical students and our nursing students. And many of us that have worked in the field a long time understand this, and we see that only about 20% of physicians right now are confident in our ability to address unmet social needs. But that's when it comes into play that we are not responsible, or do we have the know-how to be able to meet these unmet needs. We have to leave the walls of the hospital and the clinics to partner with our communities who know how to do it best. So I'm going to go back in history in the United States, because this is part of what we need to understand the risks and move upstream. Race versus racism is a question that is really haunting us today in our country. And if you look at the Human Genome Project that was done in the 90s, 99.9% of us, our makeup is the same. So what is the difference? And the difference becomes that social construct, or the social determinants. And if we go back, we know that emancipation happened in 1865, but look through time and we can see how things like Jim Crow laws, racial bias in our justice system, concentrated poverty, and social determinants of health, and you roll that down. And this particular example that you see here is about cardiovascular disease and stroke. But I use this example on purpose, that it's not violence, because it impacts different generations in each community these upstream impacts of what has happened through our history. And we all have to grapple with this in order to really change the narrative in our country. So you can see, based on what I just showed you, that race and class really do intercede on this Venn diagram. And if you look at the lateral side of that, you can see, again, social determinants of health and the huge impact that structural racism and discrimination plays on our overall well-being or lack thereof. So it's important to frame it this way so that we understand where we're coming from when we attack violence. And then if you think about the impact of these things on our communities, and this in particular is the adverse childhood experiences, think about, and I like this particular illustration because it really does show the roots, such as poor housing, food insecurity. All these things play into the fact that there's violence and there are other chronic diseases that occur in the same communities. There's so much overlap. And people carry this pain with them from the time of their childhoods along through into life. And it can create things like toxic stress, which is a prolonged activation of body's stress response without the balance of supportive relationships. Negative impacts such as learning, behavior, brain development can occur. And we see this manifested in our trauma bays with an inability really to manage and cope with a particular event that's happening. And we need to understand where this is coming from when we're treating our patient more holistically than just the physical wounds. And this is a good illustration. This was a patient that I had who was shot in the shoulder when I was in San Francisco last time when I worked there. And he was unable to use his right arm because he was shot in the nerves around that shoulder. And in our hospital-based violence intervention program, he learned how to paint from a volunteer painter that we had. And he learned how to paint this with his non-dominant arm. And if you look at this painting and the depth of it and the eyes here, you know that this isn't just about the bullet hole in his right shoulder. This goes deep. This is ACEs, this is toxic stress. There's a lot to Junior's experience in this one painting of self-portrait that he did. So let's look at communities more broadly now. How does violence and chronic disease look in our cities? And I'll give you the Los Angeles example. So here's redlining, which was meant to stimulate the economy during the Depression in the 1930s. And areas were tagged as red if they were places where mortgages were not available. And typically these were black and brown populations or impoverished populations, and mortgages were not offered in these areas. And we know intergenerationally, wealth is passed down in this country mostly through home ownership. And so there was a lack thereof in these communities, and this is Los Angeles County, just to give you that illustration. But now if you look where power plants are in Los Angeles County, it's that same area, and where homicide occurs at a broader rate, it's that same area. And now this is in 2020. You look where unemployment is, and it overlaps again with that map from the 1930s, as does homicide right next to it. And diabetic amputations, in other words, poor access to health care, leading to mismanaged diabetes. And this occurs roughly in the same areas, again, where those redlining maps were and where homicide is today. Poverty, same story. And then I didn't black out any of the Trader Joe's markets here. I just put a big white donut there just to show you that there aren't any Trader Joe's in that area where homicide occurs, so these are food deserts. So it crosses over many different portions of our overall wellness or lack thereof and overall health care. And we saw the same sort of thing when we looked in San Francisco. So redlining maps here are overlapped with chronic disease. We did this with the Department of Public Health and looked at where homicide occurs and other illnesses and where people have lower life expectancy. And there's a whole other section of San Francisco that perhaps you've visited that has nothing to do with this area where all this redlining happens. And the difference in life expectancy between these places is more than 20 years. And that's the Houston map of redlining, and you can see roughly also where poverty is today in your city and where redlining occurred. So similar things, and if you go to the map, you can dig in deeper into where the homicide rates are in Houston as well and see the same sort of thing. So when you start feeling that sense and you're living in these communities, hope is hard to find, and this is the man on your right is Václav Havel. He used to be the president of the Czech Republic, and he was a poet before that. And he said that hope is an orientation of the spirit, an orientation of the heart. And then you meet people like Mike Texada, and Mike is the supervising violence prevention professional of the HFIP in San Francisco. He's the most extraordinary human I have ever met in my life. He's overcome violence. He's been in a federal penitentiary, and somehow this man bleeds hope to others. And it's extraordinary when you find people like this, they will really change people's life courses. But for those of us who didn't know Mike before and now do, you start feeling like you're standing at the bottom of a waterfall before you find incredible, credible messengers. So then you start digging in and figuring out, well, what can I do? And really the biggest impact isn't what I do when I'm taking call. It really is looking at those socioeconomic factors. So let's flip into actionable solutions. We have to move upstream. It's really essential that I recognize as a trauma surgeon, from my vantage point, that just fixing someone's intestine is certainly not enough. It's certainly not enough. We need to not only get somebody out of the hospital, but we need to figure out how to work with our community to change people's life courses. So if you go way upstream, you start looking at things like laws, policies, and regulations that can finally change that graph that we have in our country. If you look midstream, you have this incredible opportunity to change individuals' life courses, and that then rolls into the entire community when you start doing that in a significant, broad way. So we came up with strategies for trauma centers to address the root causes of violence, but I know that I'm not just talking about people to people who are sitting in trauma centers all day. So think about how your particular vantage point and institution can implement some of these actionable things. First is to develop a nimble curriculum for trauma-informed care. So just like I was asked this morning already, well, what can I do with my little bit of time that I have and my little bit of money? You can become trauma-informed if you're not already. To integrate social care into the trauma system, that absolutely takes collaboration and community. Creating a roadmap for investment in disenfranchised communities, and characterizing the trauma center's role or other institutions' role in advocacy around social determinants and equity. So at the American College of Surgeons, we created this trauma-informed care curriculum, but this is done in different cities. Perhaps you have some in your schools. It's an exciting opportunity to really treat people more holistically and not create more trauma as we do it. So we want to understand trauma in the broader sense. I was told trauma during my fellowship was a physical injury, but of course it's much more than that. And to identify core components of trauma-informed care, to bring the practice of trauma-informed care to the bedside or to the schoolroom or to the church, to integrate social care and mental health into medical and surgical care. So trauma itself actually is a very difficult or unpleasant experience that causes someone to have mental or emotional struggles over time. That ACEs chart, the toxic stress, that whole graph that I showed you of our history of our country. And the 4 R's are to realize the widespread nature of trauma, to respond by fully integrating trauma into practices, including hospital policy. I love that you talked this morning about mental health care. It's so essential. Recognizes the signs and symptoms of trauma, and then resist the act of re-traumatizing people by having that stigma in the trauma bay or in the schoolroom, and understanding that if a young child is in the classroom and has his or her head on the desk because they're tired, it's not because of some reason that they're lazy or something like that. think about what they may have gone through the night before and how many gunshots they heard in their community before just saying, you need to just go to the principal's office. It's really important for us to think about in depth the history and the background of people. And then the principles of trauma-informed care include safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and looking at cultural, historical, and gender issues and being aware of these. And this gets into hospital-based violence intervention because this is the foundation of it. To be trauma-informed helps to create these hospital-based programs. And different institutions, whether it's a trauma center or a school, is comprehensively trauma-informed when personnel practice this notion that Martin Luther King had of the beloved community. It's not they, them, those, it's us. We are one community here in Houston. We are one community in Los Angeles. Trauma-informed care is integrated into hospital policy and physical layout. So for us, for our waiting rooms, are there tissues there? Is there water? Is there a clean place to sit as families wait for somebody to come out of the operating room? And then trauma-informed care is woven into the practices of all, including clerks, security, and administrators. And when I would go and deliver any kind of news to a family, there was a credible messenger there with the family already to create that bond. And then social care, we've heard the principles of community violence intervention, or CVI, and the CDC now refers to CVI a lot. Credible messenger, really the backbone, and delivers the services. Under-invested communities are the drivers of interventions. And there's a focus on the highest risk individuals. Data has to come from multiple sources and vetted for bias. So for example, if you look at the medical chart, and we've worked hard to change this in LA and San Francisco, you'll see things like combative or aggressive. And those are things in the medical chart that can reduce the chance of someone going to proper rehabilitation. Oh, they're aggressive, they're gonna fight in rehab. So we have to be very careful about our language and trauma-informed about our language, because they probably wouldn't characterize me, and we looked at this in our medical record, me as a white woman would be characterized more like agitated. And that won't necessarily reduce my chance of getting into rehab if I'm just agitated and not aggressive. And then the approaches that we have for CVI are grounded in equity. And even the National Academies of Science wrote in 2019 how to integrate social care into the delivery of healthcare. And this is a really nice comprehensive guide, and it can give you some ideas if you're not in a trauma center also as to how to integrate social care into a citywide effort. Our mandate really for us is to leave the hospital. We need to go out to community-based organizations and sit in the back of the room and listen and understand and let people understand why you're there as the helper and not the one dictating what needs to be done. It's different to be an ally than to be an accomplice. An accomplice is an active state, and it implies that you are a partner in this instead of just allowing something to happen that you know needs to happen. So being active is really important. And any kind of research or evaluation, the community needs to be prominent, leading the way in understanding even how to characterize value of a lot of the programs. And research has to have these three principles, really: humility, humanity, and relevance. And then measuring value really does have to come from the community. So a hospital-based violence intervention program, typically what we have is injury, hospital care, and recovery, with incredible efforts from our social workers to be able to provide links to things like victim of crime. But a hospital-based violence intervention program has initial trauma care and then an assessment right at the bedside. So they're part of the fabric of the trauma center by a violence prevention professional. And this VPP is in the taxonomy of Medicaid now. There are 6 states in the country that will reimburse for the services of violence prevention professionals, and that gets into advocacy in a little while. And then high-risk individuals, which we still haven't figured out a way to really think of a checkbox to figure out who's high risk. Credible messengers know this, though. they know their communities. And so they're enrolled in the HVIPs. Or if they're low risk, they're referred to appropriate resources such as victim of crime. And so what we found long ago when we first started measuring this is that the most important pieces of this for the population in San Francisco that was a little bit older than a typical population of violently injured individuals. I say that because they didn't need education as much because they had already finished school, so they were really looking for employment. So mental health was number one, absolutely essential to be able to get to a point to go to an interview and get a job. But these employment opportunities came through the credible messengers. So the credible messengers themselves were really the link. They were able to get people to risk reduction resources that already existed. And that's really important to understand, that this isn't all about creating a program that provides employment and provides housing. You have to be able to work in the community and know what resources exist and create memorandums of understanding and partnerships. It can't happen in isolation. An amazing program run by a hero, Thea James, who's an emergency medicine physician in Boston, is the VIAP program, or Violence Intervention Advocacy Program. And they talk about challenges and opportunities for client engagement. And in this particular manuscript, they talked a lot about how it just can't happen without the credible messenger or the violence prevention professional. And for San Francisco, we used to go each year to meet with the mayor, and here were the violence prevention professionals a couple of years ago, or about 4 years ago, at City Hall. And we found that we called them case managers at that time. We found that their exposure to the clients were a key to success in these programs. And in the beginning, the first 3 months of the program, so they stay with them for about 6 months, sometimes longer. The key was the amount of time that they spent with the particular client. So again, this is like, whoa, well, where am I going to get the funding? But there may already be community-based organizations that have resources, that have case managers or violence prevention professionals for you to work with. And that's from a city standpoint too. You may already have that in your community. So we chose to have ours with our violence prevention professionals wear pagers. They know when trauma is happening, and that's one particular model, but it has to work for your particular community. What we do know, just like the VIAP program showed in San Francisco, was that we did this qualitative analysis of clients, and the clients felt that the case managers understood and could relate to client socioeconomic contexts, that case managers could navigate in-hospital teachable moments, and that they were role models. So many advantages to having credible messengers as part of the program, as really the heart of the program. So critical is the credible messenger or the violence prevention professional, and being able to shepherd people to risk reduction resources that already exist in the community, and long-term case management. This is a long-term commitment for people. And really, mental health has to be upfront. There needs to be some bridge to mental health care. And the stigma is greatly reduced if you do have credible messengers. So as Bindi had mentioned, the hospital, or the Health Alliance for Violence Intervention, was born as NNHVIP a million years ago, or 2009 really. And we now are over 50 or 60 programs in the country, either starting or solid. We have an amazing executive director, Fatima Dreyer, who has led us in such an extraordinary way. And we're basically a network of these programs, and we have an annual conference. It's happening in September. I can tell you more about it, or you can go to the website. It's an amazing place where there are frontline workers, mental health professionals, trauma surgeons, emergency medicine physicians, city officials, university officials, researchers, who are all in the same space. It's quite an extraordinary and unique place. This year it's happening in Chicago, and fortunately it's not virtual this year. And so the history of the HAVI Youth Alive in Oakland started over 20 years ago, and then Project Ujima in Milwaukee happened. These were the two first HVIPs. And then the third was the University of Maryland Medical Center, or Shock Trauma, started in Baltimore. And in 2009, about 30 of us came together in Oakland and formed this national network. And then we created this publication, Violence is Preventable. We used like a best practices or promising practices guide, and that helped some people get going. And then we hired our first executive director, who's now still there, in 2018. And the network grew in 2020 to over 40 members. And now we have over 50 programs, 30 plus emerging programs. I know the HAVI's been to Houston. And we still have a lot to learn, and we're still growing, but Fatima is extraordinary and has hired now over 36 staff, and we continue to build our different resources. We actually have a mission to heal communities affected by violence. The HAVI fosters hospital and community collaborations, works with cities to advance equitable, trauma-informed care and violence intervention and prevention programs. And our vision is that a system of healthcare that mobilizes hospitals and communities to end violence together. And this includes cities. We offer training and technical assistance, so building that vital infrastructure. And we support communities of practice. So say there's a hospital-based violence intervention that slipped a little bit during the pandemic and needs to rebuild. So we have peer support or faculty that come out and provide some help and resources there. We develop and advocate for health-focused policy. That's Fatima that you can see there in that picture. So changing the narrative, she's an extraordinary speaker. And so we support narratives that violence is a public health issue. This isn't about owning firearms. This is not about the Second Amendment. This is about people's wellness or lack thereof. And that trauma is at the root, which I showed you in the beginning. And then we convene researchers. We have advanced, cutting-edge, equitable research, and we have working groups across the country that meet on a regular basis in multidisciplinary or multi-institutional studies to generate and continue to learn about best practices. And these are the different groups. So Fatima is up there at the top, and you can see the different ways it's broken up: capacity building, policy and communications, communities of practice, and all of these have a place at the conference. Really exciting to hear from each of them. And I just took one snippet here, one piece of it, and that's policy and communications. So we do federal advocacy, working with a coalition of partners and the CDC. The HAVI signed onto several letters of support for different federal funding and continued to support for the re-release of bipartisan solutions to Cyclical Violence Act. This is truly a bipartisan effort that's happening right now, is still alive in the Senate. So we're hoping for passage. And it is really exciting that our policymakers are seeing violence as a public health issue. This will put more funds into hospital-based violence intervention programs and the research to generate best practices. And then I mentioned earlier, now there are 6 states that have Medicaid paying bills for the work that violence prevention professionals do. To lift it up, just like if I do an appendectomy, the University of California gets funding for that. Well, Medicaid should also pay for the work that the violence prevention professional does at that bedside. And the team is in the process of likely being funded to provide technical assistance to assist in drafting a Medicaid state plan amendment right now in Pennsylvania. And I believe there are a couple other states that are about to take off with this as well. So you can see that the HAVI is engaged in this. And again, it's not about one person or even one institution. We work with cities and communities across the country for this type of work. And then we came up with standards and indicators, and you can download this from the HAVI.org. Now I sound like I'm marketing, but it's a really good guide to understand the details. We spent about a year and a half writing this up. And it's a little overwhelming at first to look at it because there's a lot in there, and you don't have to have every standard and every indicator to get started, but it starts giving you ideas of where you can get the resources in your community, and a lot of CBOs would be so keen to work with institutions, with state legislatures, with city legislators on this type of work. So I would encourage you to look at that. The core elements of HVIPs are in there, including hospital commitment, credible messengers, community leadership, safety, and that wraparound type of service, wraparound care. And it's all rooted in equity, advocacy, and healing. And these are just the different chapters of it, so different standards and indicators in these key particular areas. So again, it is really quite comprehensive and isn't meant to scare anybody, but you can kind of get an idea of what it takes to really build it from the ground up. And now I'm going to switch gears for the last little piece of my talk about health and wealth and how they're interwoven. And we saw a lot of that just from the maps that I showed originally. There's still a wide and persistent wealth gap in this country between Black and white American families. So $171,000 versus $17,000 by median family wealth by race here in this graphic. And if you look at who is underbanked or unbanked, you can see that nearly half of Black households fit into that category. So you look at the differences here, and you can see how many Black households are unbanked or underbanked. And then the bottom part of this slide happened during the pandemic. So if you look at the Black Americans who are overrepresented, it's 9 of the 10 lowest wage jobs. And for me as a trauma surgeon, the people who are represented here are people I work shoulder to shoulder with every day. So it was scary to think that my people, our people, are the ones who are at highest risk for us losing them. I can't do my job. None of us can really be consistent with our own health care without the help of individuals here. So advocacy for proper finances is so essential. And that just really struck me during the pandemic time. I would encourage you to look at a couple of different books if you have the opportunity. So Welfare, Alleviating Poverty or Subsidizing Affluence. This book came out, I believe last year, Poverty by America by Matthew Desmond. 38 million Americans live in poverty, and in Los Angeles School District, over 80% of kids live below the poverty line. So when there was a strike, it really impacted, and I was watching what was happening down my street in an elementary school in LA, and just talking to people who would come to the doors, just checking to see, even though they knew there was a strike, I don't know what to do with my child, I'm gonna lose my job. And also what was really striking about this particular book was that they found that the top 5th of households in terms of household income garner 30% more government subsidies than people below the poverty line. So things like your ability to get a rebate as a result of having a mortgage. So we actually have the 2nd largest welfare state in the world, but a significant amount of that welfare goes towards the top 5th of households in the United States. So I would encourage you to take a look at this book. And then, is the pie a finite size? So Camara Jones and Heather McGee wrote The Sum of Us, and that's also another extraordinary book that I would consider taking a look at. It talked a lot about this zero-sum game, this idea that we don't expand, and where in our whole economic evolution in this country did we not continue to expand except for a couple blips in time with recessions. This idea that we can't share the pie, that the pie is finite, is simply not true if you look at the evolution of our country. So it talks a lot about that in Heather McGee's book, The Sum of Us. So I'd encourage you to take a look at that as well. And then prioritizing survival over health is a lot of what our communities do. And so we ask people, please, come back to clinic and I want to take care of your wound. And that means another day off of work or another day where they're not taking care of their child. And that's just not how you think when you're trying to prioritize just survival of your family. It's really essential for us to understand that. And in the New England Journal of Medicine, which is the top journal in our country, there was, in September of last year, there was a piece that was written by one of the editors, Building Black Wealth, the Role of Health Systems in Closing the Gap. And even if you don't work in the health system, I would encourage you to take a look at this. It's really quite striking and draws that health wealth thing very closely together. And in many communities, hospitals are part of a healthcare anchor network that sets institutional priorities to improve community health and well-being by leveraging assets, including hiring, purchasing, and investment. And many of us can just join the healthcare anchor network. As a result of it, you can see, where does UCLA get its tomatoes for the cafeteria? Do they go to the fancy place in Beverly Hills? Or are they looking at the mom and pop place in Compton? So making those sorts of choices is really important in our institutions, not just in our healthcare systems. And the Healthcare Anchor Network, you can see where it is right now. There are lots of opportunities and has really created purchasing of over $50 billion annually in disenfranchised communities. So it's making a big difference. Just those decisions about where to invest from our vantage point is really important. And then finally, I'll end with advocacy. I already talked a little bit about it because this is the one theme of these different ideas, these different actionable items that really is woven into the rest of them. So they support the other themes. And then to deepen the integration of surgical personnel in this particular idea through the American College of Surgeons, but all of us in community collaborations, to heighten our presence in educational venues, city halls, state initiatives. We can have a tremendous voice, but we can also sit back and listen, and that's probably the most important part of this. And then policy advocacy for CVI ecosystem, the HVIP models, research initiatives, investment, and then value-based care models. So there's a $1 billion executive order from a couple of years ago that went towards community violence intervention. There's the Bipartisan Solution Act that I mentioned. $25 million now goes to the CDC and the NIH each. So there is a lot that's going on, and I know probably a few of you have applied for CDC funding under the title of violence prevention because of the public health side. This is not about firearms, this is about bullet holes. And then state Medicaid bills to fund the work of violence prevention professionals, as I mentioned before. So we want to move beyond equality, certainly. Equality looks like this. Everybody gets the same thing, but not everybody needs the same thing. And some of us need more than others to create equity. And equity is that everyone's given different support to provide access and to fill gaps. That's kind of midway up that stream or that waterfall that I showed. True equity is when all have access without supports needed. We're a ways away from that, but understanding the root causes of violence and other chronic diseases in our communities across the country is really an essential to be able to start to unfold some of these actionable items and to be deliberate about it and to be an accomplice, not just an ally. So this is structural barriers are actually removed. And you can find this is something that's online if you look this up. I'm also happy to share any of my slides. So with that, I thank you, all of you from Houston, for the hospitality and the invitation to be here.
Thank you. Wow, that was simply amazing. I know there's probably a million questions in the crowd, but we're going to move on to the panel discussion, which Dr. Dicker is also going to be part of, and then we will ask questions in the 15 minutes after that. I think that you should be able to write questions down. Is that how we're doing it? Write questions down on those notepads, and then we will, yes, on those index cards, and each table in turn will pick the questions up and give them to us, and so that we can compile all the questions for the end. So can I please have my panel members, please? Dr. Dicker, Councilwoman Abby Kameen, I think she's in the back. Dr. Berry, Deputy Inspector Crystal, thank you. And sorry, we still got your name spelled wrong. My apologies. And Chief Satterwhite from HPD. Yes. Fantastic. Yay. Thank you so much for being here this morning. What an honor and pleasure it is to have you all here. Could we please go to my, there, yeah. So as Rola pointed out, we have decided to split the day into panels. Gun violence is multifaceted, right? It's not just one thing. You can't just prevent it by giving everyone helmets or bulletproof vests, okay? I wish it was that easy. There's many, many different types of gun violence. There's community gun violence, which is what we're going to be talking about in the first panel. There's suicide, there's unintentional or accidental injury, there's school violence, there's domestic violence. It is multifaceted, and it needs multifaceted solutions and a multifaceted panel like this. So the first one we're going to talk about is community violence. I'm just going to give a little overview on some of the research that we've done here in Houston and how this relates to community violence. So the true definition of community violence is interpersonal gun violence between individuals that are not intimately related, sometimes called assault, usually occurs outside the home in a public setting, takes place in under-resourced city neighborhoods, and as you heard so nicely from Dr. Dicker, this has a lot to do with structural racism. It's often sparked by a dispute, often impacts Black or Hispanic or Latino young men, and is sometimes referred to as urban violence or group violence. This is the most common type of violence here in Houston. This is a really interesting map made by Dr. Levine, who I think is here. Yes, thank you, Ned. Who's you'll hear from later, but he's an excellent criminal researcher who works closely with me. And this shows that, although Houston is really violent right now, we forget that in the 90s it was way more violent. And then there was a nice period where maybe we felt a little bit safer in the last decade. And now you can see the sharp rise again, and hopefully we don't get to the levels that we had in the 90s. So these are some of the numbers here in Houston. For the last 3 years, we've been collecting data on our pediatric and adult cases, and these are combined from the level 1 trauma centers and the medical examiner's office, so by no way is this comprehensive, but it's as comprehensive as we have. This includes both deaths and non-deaths, and you can see that there's been huge increases in both pediatric and adult trauma due to firearm in 3 years, and this ended in 2020. Since 2020, it's even higher than that. Interestingly, in Harris County, it's a little bit different from the national data. So when you just look at deaths for adults, nationally, suicide is about 60%, and homicide is about 36%. Where here in Houston, it's the opposite, and this holds true every year. This is data from all 4 police jurisdictions involving any crimes with a firearm. And you can see that in the 3-year period that we looked at, there was 1,800 firearm deaths and 8,600 firearm injuries. I don't know if anyone realized it was that bad, because a lot of the numbers that we hear on the news just talk about the deaths. There's a lot more people that got shot and don't die and can have severe injuries, not to mention the trauma that goes along with that. This is put together also by Dr. Levine. He calculated the firearm risk. The darker areas are higher areas of risk, and you can see that this basically goes really well with those economically distressed zip codes that you can see on the left, and this is data from the Rice Kinder Institute. And then this is some kind of cool data that we recently put together showing the differences in where these different types of injuries and deaths are occurring. So the bystander and assault, this community violence, a panel we're about to have here, are more in the central part of the city, whereas the accidental ones are kind of all over the place, and then the suicides are located more in the suburbs. And so when you look for vulnerable populations, if you want to have community violence programs or injury prevention programs, you only have a limited number of resources, right? So you need to target them well. And so these are some of the vulnerable populations that we've identified regarding community violence. And then these are some of the locations where firearm crimes occur. You can see a lot of them occur in sidewalks and parking lots, and 29% of them occurred within 300 feet of an alcohol serving establishment. So there are some evidence-based strategies to decreasing community gun violence. These are some examples from other cities that work really well. The Cure Violence program in Chicago, New York, and Philadelphia, which our One Safe program in Houston is modeled after. The street outreach programs for high-risk individuals. I don't know if is Victor here? Victor Gonzalez? He's coming. I think he's on the Mayor's Anti-Gang Coalition, and he does a lot of this work along with our credible messengers. The hospital-based violence interruption programs, which we heard about, which we're just starting here in Houston, the credible messenger programs, changing environmental design, such as cleaning and greening vacant lots, fixing abandoned buildings, improving street lighting, and again, we're doing some of this work here in Houston, and the community violence intervention in conjunction with law enforcement, such as the ceasefire program in Oakland. So now we're going to hear a little bit about what's going on here in Houston from our panel. So I'm going to ask each of you to introduce yourselves and tell us a little bit about the gun violence prevention or safety work that you have done or are doing here in Houston. We'll start with you, Dr. Berry.
Okay, good morning. Cherie Berry, I am a native Houstonian. I'm a trauma surgeon. I'm the trauma medical director at Houston Northwest Medical Center, which is a HCA facility, and then I'm the regional trauma medical director for the Gulf Coast for HCA for their trauma centers. And in line with what Mindy and Dr. Dicker mentioned, we were noticing an increase in the rate of recidivism with some of our patients that are survivors of trauma. So upwards to 2 to 4 times we were having the same patients return due to violent acts. And so as a community stakeholder, and especially since I live in the same community, we decided that we wanted to do our part from a hospital standpoint to decrease what I consider a disease. And you mentioned it as a public health crisis, and I definitely agree. So in November of last year, we started one of the first hospital-linked violence intervention programs. We partnered with the Harris County Public Safety Department, and so it hasn't been a complete year, but we've already offered the program to upwards of 90 patients. The surprising part of that is the age of the patients. So initially, when we put together our protocols, it was for 18 to 65, but we've had to extend that, and the health department or the public safety department has been very flexible. We're having patients as young as 15. And so it's, we haven't done formal data yet, but anecdotally, we've prevented retaliation efforts because of this program, and we've definitely received positive feedback, not just from patients, but also their families, because as we know, the violent injuries just doesn't impact the patient, it really impacts everyone around them.
Thank you so much. Dr. Dicker, we might skip you if that's okay, because we already heard from you. Councilwoman Abby Kameen.
Good morning, everyone. I'm Abby Kamen, and I chair Houston's Public Safety and Homeland Security Committee for the city. I will say it's great to see so many people in orange, and I know we also have some Moms Demand folks in the audience as well as community partners from other offices, state representatives, and partners. So I say that because from my perspective and where I'm sitting, it really does take all of us. And as a council member, what I've been trying to do is amplify the voices and the work that's already being done, whether it's like the work that Chief Satterwhite's going to talk about and partnering with HPD or Inspector General Okorafor, or partnering with Rice and Bindi. I hope we'll be able to talk a little bit more about what we hope to accomplish in the future. But from what the city has been doing, in light of the rise in violent crime post-pandemic, there has been, I think, an opportunity to have conversations, including uncomfortable conversations, whether it's about criminal justice reform, but also about the issue when we're talking about homicides, the nexus is firearms. And one of the things I've been trying to encourage folks is to normalize those conversations. So we've been going into schools, meeting with PTOs and bringing community partners and HPD with us, and I've allocated upwards of $75,000 to an initiative actually that Chief Satterwhite and I worked on together to talk about safe storage, locking up our firearms. The conversations with parents are actually being really well received in a way that they have not been received historically. We're giving away free gun locks, but we're also giving materials out through partners. How do parents talk about conversations with other parents? When you go to take a child to a friend's home, are you asking those parents, hey, do you have a firearm in the home? Is it stored safely? And stored safely doesn't mean keeping it out of reach. When we look at the firearm injury data and what's happening in our trauma centers, and especially those accidentals, those are kids getting a hold of guns that should not have access to them. And when we talk about safe storage, we're also really trying to amplify messages around vehicular security, because as we see auto theft and break-ins going up, and I talk about that nexus with crime, right, that you see headlines about, a lot of those car break-ins are people looking for a quick swipe of a firearm. And over, I believe, Chief, correct me if I'm wrong, 12 guns a day last year reported stolen out of vehicles in the Houston area, and that's just what's been reported. So we have way too many guns, both from people that shouldn't have them, whether that's children or criminals that should not have access to them. But we're also doing things like partnering with our domestic violence partners. I've really tried to hit home the nexus with firearms and domestic violence. As homicide rates are going down, the rate that is doubled, according to, I think it's a UH study, domestic violence homicides have doubled while other homicides are going down. And when a firearm is in a home, it's 5 times more likely that it's a lethal situation for a victim, and I say victim because they often don't survive when there's a firearm in that home. So the city's contributed $15 million to help Houston Area Women's Center expand to their new campus, because right now the capacity and the need is there's not enough safe refuge for women and their families when they are calling for help. So getting those extra services, those wraparound services, things like that. So I'm barely touching on and skimming the surface, but I know we have a lot to cover, but I think it's a whole spectrum of giving people a voice and amplifying and normalizing these types of conversations. So I really appreciate the panel today and all the work that you all are doing, and it's the addressing the root cause of these problems, which is access to firearms and people that shouldn't have them.
Thank you, and we really appreciate your support from the mayor's office. Deputy Inspector Crystal Okorafor.
Thank you. Good morning, everyone. My name is Crystal Okorafor, and I'm the Deputy Inspector General of the Office of Policing Reform and Accountability. I was appointed by Mayor Turner in 2021 when he created the office in the wake of George Floyd's murder. What my office does is we oversee the One Safe Houston, which is the comprehensive violence prevention program. It's got $77 million allocated right now. We also work with the police department on all of the mayor's violence prevention programs and any kind of violent stuff like that. We also oversee accountability and if there's any kind of misconduct within the police department. Thanks.
Thank you. Yes, Chief Satterwhite.
All right. Hey, good morning. Larry Satterwhite. I'm the Executive Assistant Chief over Patrol Operations for the Houston Police Department. As your partner in police department, we're doing everything we can to reduce violence and improve the quality of life for everybody in the community. We rely heavily on partnerships. Thank you for having this forum. This is a part of our partnership. The council member has already talked about, and of course, Ms. Okorafor. We're working very closely with both of them. They're partners. I helped write the One Safe Houston initiative, and we're having a lot of success with that. We're very proud of that. we just have a long ways to go. We're doing work with mental health. We're doing work with messaging, lots of PSAs. So I think there's some questions coming that way, so I'll hold for
Okay.
now and pass that to you.
Sounds great. Okay, thank you so much. Yes, let's start with some questions. So I want to start with you, Dr. Dicker. So how do you compare community gun violence in Houston versus Los Angeles and San Francisco, the two cities where you worked on this the most?
Yeah, thank you for that. And I appreciate hearing about the efforts that are happening here. It's really wonderful. Just doing my homework before this, I have to say, so the wraparound project in San Francisco is a tiny community. It really is. It's very small. Houston's very big. We only have one level 1 trauma center in San Francisco. So in some ways it was a great sort of think tank to figure out on a small scale how to do it. It took all the partnerships that I see in the room, including law enforcement, to do it in one small city, one small county. It's the same there geographically. In Los Angeles, couldn't replicate it in the same way. So Los Angeles has 14 level 1 and 2 trauma centers, has 10 million people in the county. So we needed to draw on the same principles of collaboration and data sharing. It's still happening. It's very difficult, but the Department of Health Services there is kind of the convener with city and county representatives, law enforcement, trauma centers, and community-based organizations. We're creating hubs of hospital-based and hospital-linked violence intervention programs. And the hubs, each of these hubs around Los Angeles County are CBOs, but they're linked to different precincts, and they're linked to different trauma centers, and linked to different city elements, which is in Los Angeles called spas. There are different spas in Los Angeles, which is different council people. So creating those, and then spokes from there to employment services, tattoo removal, education opportunities, mental health services. So it's still a community-based program with community health workers, credible messengers. But for a huge place like Houston, where there are different pockets of violence and other chronic diseases happening, that might be something to consider, where you have different hubs in different communities. And the credible messengers truly do have to come from those particular communities that are impacted. Those are the people that know the most. So it's really important for them to be at the hub.
Yes, thank you. We do have a strong credible messenger program. It's, from my understanding, there's two. There's the Harris County Public Health program, and then there's the City of Houston program. And they are from a few zip codes that we know have been traditionally dangerous in Houston. I guess the question is how to expand that, and how do you capture more of the population, and are those zip codes still the dangerous zip codes? And then we have started HVIPs, which we'll hear a little bit about, which we heard a little bit about from Dr. Berry, and they're currently in one hospital, and starting at Ben Taub as well. Would there be an opportunity or would you suggest a more centralized system where all the trauma centers could tap into the same resources that we have with our community violence programs that are already in place, instead of having to reinvent an HVIP at each trauma center separately?
Yeah, there's a trauma hospital advisory committee in Los Angeles, and it meets monthly. That's a nice neutral hub. It's run again by the Department of Health Services, so that there still is that important presence, but there's one overall, the coalition of hospital-based violence intervention programs that's developing in Los Angeles right now. It is difficult to do this, because data sharing, all these things are just tricky. But I think if we can get people to understand how critical it is to have community at the center of it, and then to have that umbrella organization like a Department of Health Services, that I think is something that's happening in other communities too. There's some data around it in Indianapolis that it's quite successful in that particular city.
Okay, thank you. Dr. Berry, can you describe your early experience starting an HVIP at Houston Northwest Trauma Center, what the challenges have been, and how you've overcome them?
Yes, so surprisingly, it's been quite smooth, I would say. So we were lucky in the fact that we were able to partner with the county. So working with them, they've been very flexible. I had a trauma educator at the time who had set up a previous HVIP in California, Southern California. So she came with experience. The process thus far has been smooth. The most important part are those community partnerships. And so that's an interesting concept that you bring up, making a more centralized HVIP hub. I think that would be helpful because, like I said, we're doing this at where I'm the trauma medical director, but I also oversee other level 2s. And for Houston being so large, although we have 2 level 1 trauma centers, Houston is very spread out. It's the 4th largest city. Everyone can't come downtown for care. So these level 2 hospitals are seeing a large portion of these patients. And so it's important for all of the hospitals really to have access to that. But as you mentioned, the data sharing is one thing, and then just the logistics. But that's something I'll be interested in talking to some of our partners about. I think the surprises that we've run into, like I mentioned, are the age of the victims, being so young, as young as 15, as old as 68, and the ease of acquisition of guns. So, I mean, this is just 3 weeks ago, 18-year-old patient, this is his second time being shot. Of course, he's worried, is he gonna be able to get out of the hospital in time for graduation? But also his younger brother in middle school has already been shot as well. So this blows my mind because this is not my lifestyle, but the ease in talking to the patient, the ease of him knowing where to get a gun is just mind-boggling. And so I think, Abby, what you were mentioning is like having these conversations and the importance of something you said at one of your last slides, bringing the surgical personnel more integrated into the community, because we see the devastation of these injuries. And then as a surgeon, I'm able to have these conversations with patients, and that's been an interesting part of this HVIP because, you know, I operate on the patient, I see them every day. Our surgeons and APPs, PAs, are normally the ones to convince them to join the program, which I think is a little different than some other programs, but I just think it's the way it was formulated and because of lack of resources. So that would be my plug to, we do need more resources in order to study the benefits and how we can make it more successful.
So the trauma centers are a good place to identify the individuals at risk, right? And then it's about connecting them with people who are already doing this work in the community.
Correct.
So for example, so the Credible Messengers, these programs are small. There's no way you can cover all of Houston. Mm-hmm. Victor's Gonzalez, I don't know if he's here, his Anti-Gang Coalition, I believe, has 9 people in a city of 6 million. So you know, maximizing our resources or increasing our resources, and that's my question for you, Councilwoman, is where do you see the greatest need for resource allocation or even policy change here in Houston so that we can meet this need?
Yeah, so I'll start general and then get very specific, right, as we go from different levels of government. Policy changes, elephant in the room is we're in the state of Texas. And I'll use the example of Heights High School in my district, a video that went viral with actually Chief Satterwhite, and he can't, look, that was just a call, that was just a threat, right? But law enforcement is being forced to respond to those in schools. And at Heights, they did I don't want to say beautiful job because it's such an ugly situation, but just keeping those kids or trying to keep those kids calm as you were trying to respond to a threat and how you handled that. But what you're left with is the trauma that our children are being exposed to even when they're not shot. Mm-hmm. Right. So you have millions of children and just civilians witnessing gun violence That's trauma. But then the fear of it as a mother of a 2-year-old, I mean, every parent in this room has thought about, do we take our kids to school? And how safe is the school? That's trauma. So let's just talk about mental health in that respect. I do think it's important when I say mental health, we have a problem blaming mental health, especially when it comes to mass shootings, when mental health data shows is only, can only be correlated with, I think, 4%. 4%. Now that's, I think, apart from suicide-related issues. But I say that because we need resources for mental health and support, but we also need resources for law enforcement when it comes to data. I'll give one example, our records management system in the city of Houston. It's the system through which, right, if you call in or you see police filing a report right on their computer, that's the data system that they track all investigations. It's so outdated that we cannot manipulate the data to pull things, pull specific categories that we may need to meet the challenges of the time. So we're trying to fund that right now, but that's millions and millions of dollars. Federal funding has helped and we're starting to fill that gap, but that's about to end. So there's technology needs just from data tracking at the most basic level. There's mental health resource needs. But as it relates to policy, we are all trying to be reactionary to absolutely insane laws right now. How do you, as a law enforcement agent or a civilian, when you see somebody open carrying, know what's a threat and not a threat? And we're having to react to that. Permitless carry, when you don't have safety requirements anymore. So we are going the wrong way. And then as one policy issue that we don't talk about enough is what's happening in the courts, especially when it comes to domestic violence and red flag laws. Our red flag laws are one of those only tools when we know that somebody can be a threat to themselves or somebody else, that a court, through the proper channels, can remove that firearm from a dangerous situation, from that person. The Fifth Circuit has ruled that that is no longer the case necessarily in domestic violence situations, that a known abuser has a Second Amendment right to keep their gun. And we are taking those steps back. So I say resources in terms of funding and the issues that we need to be proactive about, but there's all of these policies that the city and our community is trying to be reactive to and do stopgap measures, like the hundreds of millions of dollars that we're funding for One Safe Houston and things like that, but we're going the wrong way.
Thank you. So speaking of One Safe Houston, Deputy Inspector Okorafor, of all the programs that have been initiated, which one has been the most successful so far in your opinion? And how can we expand this project to reach more of the vulnerable population to community gun violence based on some of the data that I presented earlier?
Okay, thank you very much. One Safe Houston, I don't think you can single out one exact point and say this is what's caused the decrease in gun violence or in violence throughout the city. It's a comprehensive approach, and I think a lot of it is that we are taking some of the things that we've asked police officers to do, and we're giving it back to the people that can actually do it. So we've given over $20 million towards mental health, and that's all going to the Harris Health Department so that they can have clinicians coming out to these calls instead of when there's not a violent situation. So if someone calls and someone's having a mental health episode, Chief Satterwhite can't send patrol all the time. They're sending now clinicians out there. And so then when a clinician comes out there, they're able to assist more. And so that's diverting calls. They've got crisis call diversion. And then also, as Councilmember Kamen mentioned, we've got a lot of domestic violence money going towards that to increase HAWK, to give assistance to the community. There's a lot of initiatives, and also the overtime, it's completely depleted staff. There's also a gun buyback happening on June 10th. This is our third gun buyback through the city. It's in partnership with Commissioner Ellis in Precinct 1. We've got a great relationship with the county and the city working together right now, and I hope that continues moving forward. But on June 10th, no questions asked, gun buyback. And it'll be Chief Satterwhite and all of HPD will be there, and the council member came in. We've got lots of people participating and benefiting from this event. We've collected over 2,000 guns so far. And again, it's no questions asked. But I think in order for us to really get to the populations we really want, it's got to be everyone working together. It's got to be the medical professionals, it's got to be the HPD and the police departments, it's got to be the elected officials. But if we can't get the community to know what we're doing, then what we're doing is pointless. And so I think we've all said something about the community, because that's who we're trying to reach, but we're not in the community that we're trying to help. You know, as you mentioned earlier, you're like, I see what's happening, it's in my community, but it's not in your neighborhood. And so unless we can get the people that are actually being affected by it to buy in on what we're trying to sell, it's pointless.
Great. And then finally, Chief Satterwhite, you see the violence on the streets in our communities firsthand. In the past few years, what type of gun violence or crimes with guns have you noted the largest increase in? Have the traditionally dangerous neighborhoods changed or expanded? Do we have enough law enforcement capacity to safeguard all of the hotspot communities? I know the answer to that one already. And where are the largest needs from your perspective?
Well, okay, those are 4 questions. And I could probably take the whole panel for each one.
I know, sorry, we only have 5 minutes left.
So we have seen an increase in gun violence in the last few years. It's really spiked during the pandemic, and it's just really kind of taken off. Thankfully, we're seeing a little bit of a pullback, and that's good. I think that's a lot of that is because of our efforts, the One Safe Houston initiative. Thank you, Crystal, council member, the mayor, and everybody for funding that. I think it's making a big difference. But the things that have gone up, we've seen a lot more shootings. I think it was already talked about. I think the doctor talked about that. We have seen a significant increase in shootings, not just homicides. Like I said, this year we're seeing a bit of a pullback, which is great, but it's way too much. The shootings are happening with handguns and they're happening with rifles. Both incidents are up in the city of Houston and probably across the nation. I'm very confident in that in terms of shootings. We're seeing more firearms that are being modified with technology that allows them to shoot fully automatic. And we're making arrests where we have people printing these out through 3D printers. It makes it very dangerous for law enforcement too, as you might imagine, the kind of what we're up against in the field now, as opposed to maybe in years past. We're up against individuals with modified weapons, modified equipment. We see more of all those things, and they seem to be more committed to doing crime and harm and being resistant. So these are and hence we have more dangerous encounters in there, it seems like ever before. And I've been in this job for 33 years. I started brand new in early 1990, so I witnessed a lot of change in the city. But that's one of the things. You talked about the neighborhoods. Traditionally, we still have a lot of the same neighborhoods that are experiencing problems, and there's a lot of factors that go into that. Mere population alone, really neighborhoods that are really heavily packed with people, in significant population per square mile, and a lot of those are neighborhoods that are less affluent, and a lot of people, not just from here in the United States, but also around the world, and of course there are real challenges there. But also we have other crime expanding to other neighborhoods not as traditional. Gentrification does play in a role. You see some neighborhoods improving, and that's great, and a lot of investment. We have our complete communities. There's a lot of good stuff going on out there. But we also still have crime and the mobility of crime. I mean, in Houston, I think it's been said several times, we're a really large city in terms of geographic area, probably the largest or one of the largest in the country at 670 square miles. So if you can imagine that amount of space that we have to cover with a police department force that's about 5,000, 5,200 right now. This is a quick comparison. We take our sister city of Chicago, which is about the same population. They have about 240 square miles to cover, and they have 13,000 police officers. Oh, wow. So, I mean, there's a stark difference. I mean, our officers are great, and they do a phenomenal job. And because of that, and the public that we serve, which I think our public is the best in the world, we have the most support of any other police department in the world, and I proudly say all those things, and I travel the world and do that often. I think that's some of the reasons that we're able to hold the line where we are. We're way out of line in terms of violence, but think about how much worse it could be if we didn't have such a great public and a great police department, young men and women out there doing the job. And some old too, like me. And then I think one of the things that we talked about in terms of do we have enough resources, I think I just kind of talked about that. Now, thankfully, we have one safe, and we have the overtime money that's come our way that's helped a lot in terms of covering the gap. We still are short, but thankfully for that, we're able to offer that, and oftentimes order that, and it does fill the gap. But here's the problem: these officers have lives too, and let's not just say officers. There are civilians on our team that are working all the time. Our dispatch is short, incredibly short. I think 20%, 30%. So all those other people that are involved in as public safety responders and every level, we're short, but we're covering it with that. But short of those things, we would really be in dire circumstances. So we need more people. And by the way, we are recruiting right now. If anybody wants a job, we'll take you. The things that can be done, we'll start internally. It's no secret. We need more police officers, and we need more support around that. Like I said, the dispatchers and all the other civilian support. Simple fact is, 25 years ago, we had 300 more police officers and we had 1,000 more civilians than we do today. That's just the reality. The city's grown by 700,000 people, and we've remained stagnant. Now, again, I will say, the mayor has done an awesome job and council's done an awesome job. They always have been in support with us. They've always supported our growth and understood the crisis that we're in. And we are better today than we were simply because at that time, so many more officers were eligible for retirement. And now that number, that pendulum has swung a little bit. So what we should start seeing is growth. I want to remain positive here. We should start seeing a lot of growth in the coming years in terms of our force. But we need more officers. Community involvement. Like I said, we have a fantastic community and everybody's involved, but we need more involvement. I've heard credible messages several times. That's incredibly important. We need formal and informal stakeholders in the neighborhood. Any way possible, we need constant communication, and we're trying to improve our technology and our outreach. We do a lot of public service announcements for different things, but those are the kinds of things that we need. One case in point is brought up several times: access to firearms. Mm-hmm. We have a real problem in our city, and that is, I'm a Second Amendment person. I believe in the Constitution. But when you do go purchase a firearm legally, great. But you've got to be, and we are asking the public to be as careful with that as possible. Last year we had over 4,000 guns stolen from cars. Jeez. By definition, that's a criminal armed now, because they stole that firearm. So we're doing things like safe storage. I mean, Lock It Up Safe is a campaign the council member and I started last year. We are now offering gun safes that you can lock in your car. We're asking that if you're going to carry a firearm, I'm not going to go into those places. I'm just going to say that if you are going to carry a firearm, be responsible with it. Do not let it fall into the hands of a criminal or, God forbid, a child. Okay, so this is what comes with that ownership and possession of that. So we ask that, but we do those PSAs. We can do more of those. We can partner with the public. Mental health. We have increased our crisis intervention response teams by 6 teams through One Safe Houston. We have a huge partnership with the Harris Center, like Deputy Director Okorafor just talked about, and we can reach. They're reaching out. In those instances where it's just a professional and not law enforcement is necessary, that's great, because we are stretched thin and we are going everywhere. And of course, that might be the better response anyway. But we as a city, we as a state and a nation need to invest more heavily in mental health and those services and those places that we can take people who are in crisis. I know I heard the stat of 4%. That is what we call probably not a real representation. We know it's a lot higher. I know it's a lot higher. Anecdotally, I'm going to so many more scenes where we have people in crisis that there's no way that 4% is accurate. And I'll debate that with anybody. We are really dealing with a mental health crisis in our country, And we need more resources spent towards that to get people the proper care and the longer term to be within that proper care, because right now, if we do an emergency detention order on somebody, the likelihood is they're going to be in and out of that medical facility within just a couple of days. Does anybody in this room think that that really has helped that person for the long term, or did it possibly just get them where they need to be stable-wise right then? I understand the demands on our healthcare system. That's why we have to invest more in those things to truly make the positive impact and protect not just that person, but that person's family and everybody else that is in that person's orbit. So we need to do that. And then I think I'll stop with this last one, which is a huge one to us in law enforcement, which is our criminal court backlog right now. Our police department is doing, we are out there, we are engaging, when people do things that they have to be taken into custody and taken before a magistrate and taken to jail, we're doing those things. The problem is that we have over 40,000 felony cases in court backlog right now. And simply put, we have people that have been charged with murder that are out in the streets. We have violent criminals that are out in the streets, back out on bond. And it's no secret to anybody because it's been reported on many times. We have to figure out a way to resolve this backlog. The individuals, I mean, sometimes people are waiting 4 or 5 years, maybe never sees the inside of a courtroom after they're getting initially charged. Well, here's the problem with that. That person's got the charge. They deserve their day in court, whether they're guilty or innocent. They deserve their day in court before a panel of jurors and a judge. That doesn't happen. The victims that were hurt and their families deserve their day in court. And by doing so, we can get the persons that are going to continue to commit crime and violence in our public off the streets for an extended period of time, which will bring relief to their families, bring relief to the outside public and all those things. That doesn't happen if we don't have case trials. So we need the court backlog to be resolved. We have partners in the district attorney's office and partners in the courts, and everybody's struggling, but that is a huge one that I think will make a huge difference if we can solve that problem in our city and our state. I'll stop there.
Oh, that's great. Thank you so much. Do we have questions from each table? Okay, if we can start bringing them up here. I just wanted to make a clarification, Chief. You said 5,000 police officers. That's an HPD?
Okay, so let's say the actual number right now, I think today, is more like 5,150. I said just over. So about 5,150. I want to make sure I don't take every one of them is incredibly important. Okay, I will count every one.
But Harris County Sheriff's Office is separate from that.
Yeah, the county. So our county is about within the county, I think maybe 4.5 million people, 5 million, not the 10 million that LA County has.
Yeah.
In Los Angeles, the city of, I think, has more than 1 million people more than us. So they are much larger in terms of population. Still don't patrol as many miles, though, by the way. But yeah, there's Harris County, and then there are 8 constabularies, constables' offices that help cover the county. But when it comes to the city of Houston and our jurisdiction, we're the primary go-to. We have a lot of other law enforcement agencies. We have one right here in the room. Chief here is from Rice. But I mean, that all are partners, and we count on everybody. Mm-hmm. I am not ashamed to ask help from anybody and everybody. Like I said, we're recruiting. We'll take it.
Well, thank you for all you do and for literally putting yourselves in the line of fire. I can't even imagine how hard that is.
Thank you.
Okay, so I'm going to take a few questions from the audience. How much time do we have? Can we take 15 minutes? Okay, sounds good. We'll try to get through as many as we can. I should have worn my glasses. Just kidding. Okay. Both the firearm violence maps and the high accident sites on the Vision Zero maps strongly correlate to dramatic overlighting with high blue LED lighting, which blinds and interferes. Can the police educate differently on the use of light for security?
Sure. I mean, so in general, we like well-lit areas. That's pretty intuitive to everybody, I presume, in terms of safety. So in public spaces, we do appreciate, good lighting. But quality of life is really important too. And sometimes you can have lighting placed in ways that are affecting people's quality of life in terms of, maybe it's shot into bedrooms and all those things. Am I on the right path here? I mean, I'm not.
Talking about grades of light.
Grades of light. So yeah, so there's different kinds, and I probably would need to do a little bit more research internally. But yes, what I think the idea would be, whatever lighting gives us great visibility in those areas, but does not impact quality of life. The most effective, I think you said blue lighting is the problem. So I think I've seen a study on this. I just apologize, I'm not
No, that's okay.
well versed on that specifically.
Yeah, that's okay. I think that it has been shown, and I know we have an expert here in the audience. Unfortunately, sorry, we don't have time to address this in detail right now, but that there's the different levels of lighting, and we definitely need more lighting, I think, in our parking lots and high-risk areas that we've already identified. But maybe it should not be the super bright lights, because those disrupt sleep and
Right.
help the process. So some of those areas, I know that we're fighting against, the wall of federal and state laws, but some of those things in our city, seem like low-hanging fruit that we could potentially, if we're not already addressing, could address here. Okay, let's move on from that. It says, here in Texas, we advocated this legislative session for CBI, community violence intervention. I assume that means funding in the state budget, but it was not successful, unfortunately. What recommendations do you have for getting more support from leaders?
You want me to take-
Councilwoman, I'll let you take that one.
Okay, so I'll start just personally from my experience, and that's what I can speak to. And I'll give the example of what Inspector General Okorafor had brought up, even with the gun buyback program. I'm actually the one that had drafted the proposal to submit to the mayor, who accepted the proposal, included it in One Safe Houston. He's been such an amazing partner. And I have not even been that vocal in terms of the work on it. I've been standing there, but it hasn't been I helped work on this, and I'll tell you why. I was nervous about even just a gun buyback, how controversial that would be. And again, gun buybacks are, like you said, voluntary. They're for people that may have a firearm lying around that they don't want anymore. Maybe you're older, you now have grandkids, you don't want to sell it to a pawn shop, right? That's one of the most dangerous ways, in my opinion, that folks can get guns that maybe shouldn't have them right now. This is a safe and secure way to dispose of it, where it goes through evidence testing, is securely destroyed by HPD. It's done the right way. And I was nervous. And I think for those that know me in the room know, I'm pretty loud when it comes to gun safety and gun safety reforms, period. And so when I share that anecdote, only because I think there's a lot of you in the room that are doing a great job giving support to elected officials, but it's still really challenging for us. And that's okay, that's what we signed up for, but having that cover and mobilizing that support to say, hey, thank you for speaking out on this. It's okay to say that you don't think we should have the assault rifles that we should have on the streets right now. And that but that is scary as an elected official to say. And so just building that support goes a long way and gives, I don't want to say cover, because we should be leading, we should be out front, but it's hard. And building those coalitions is really important. So I'll talk about the media for a second. We're working right now on efforts, I don't know how successful we're being, to make sure that the media is a good partner in this. When you see a headline about a child that got a hold of a firearm from mom's bedside table and shot their little sister, there should be best practices included in that coverage. Or, hey folks, please remember to safely store your firearm. If you need to learn more, go here. Just like around the holidays, it's, hey folks, please don't drink and drive and buckle up. Normalizing those types of conversations through mainstream media, but also through each of you, is helpful. But without more ability of elected officials to take a stand in Texas or at the federal level, it's going to be very difficult. And that tide is changing. It is changing, but we're not fully there yet.
Yeah, thank you. In addition to the accidental, the minute I turn on the TV, all we see is someone's shot, assault, homicide. I mean, that's what we're seeing the most of. That's what's the most in our city. So, what guidance can we do
I mean,
for that?
well, right, and just to add to that, a lot of times when media is covering a scene, it's a murder-suicide. Oftentimes that's indicative of a domestic violence situation.
Yeah.
And oftentimes the crimes that we see, and you all can speak much more to this than I can, but it's, there's a nexus between the aggressor and the victim. It's not random. Now, Chief, you will see a lot more random too than I will know. But again, that education is critical because we are just seeing headlines, and what bleeds leads, but we have to be responsible with that. And the news is grappling with this, and I give them a lot of media, a lot of, not grace, but they're struggling too. Whether it's the trauma from covering so much, but it's also how short-staffed. Journalists don't have a beat anymore. They can't gain that expertise. They're covering 25 things in a day. So we have to do a better job of making those resources and information more accessible for them.
So along the lines of community violence, and we only have 2 minutes left and a lot of excellent questions. I might hand these out to each of you, and then if you can jot something down in the back, we'll try to get them back to the people asking the questions. But there's a few questions about the funding being stripped for community violence intervention programs, which of course we've heard so much about this morning, and the value of that. Is that something that we can sustain, at least in our city, even if there's no state support for it? Because it seems super important. I mean, all of this goes back to the root causes of violence, which is what Dr. Dicker talked about. If we had enough support, maybe we could even have a hotline or something like that. Right now, we don't have the support, or we have it, but we're going to lose it. And so, how can we, despite the state laws, how can we maintain that level of support or increase it in our city? Is that even possible? I don't know, maybe Deputy Inspector, if you could take that.
Oh, yeah, a little bit. So we have the ARPA funding right now, which is the American Rescue Plan funding, and that's going for a couple of years now. And we've been working in collaboration, especially with the credible messengers and things like that, with the county, with Lupe, who's here this morning, to make sure that the city and the county are diverting resources in different areas, because we have a lot of overlap, but you don't want everyone going to the same zip code. So there's lots of collaborations between the two. It's all going to depend on, I think that right now we have great elected officials, and I think that everyone is kind of really trying to push, at least here locally, with what what everyone in this room is pushing for. But, it's election time, and so our local government is going to change with the new mayor in January of next year. So do your research and make sure that the issues that you're pushing for align with the candidates, because that's the only way you're going to get the money allocated, is if you don't vote for the right people. And then you're like, oh, well, they told you they didn't care about gun violence, and now you're like, oh my gosh, why are they not giving money to gun violence? You know what I mean? And so if you don't get out and become informed voters and tell your friends to become informed voters, there's not going to be an allocation of money to the resources that you want, because you didn't vote for the people that were doing that.
And Dr. Bindi, I'm so sorry. I feel like I've dominated Q&A, but underlying the challenges in the city of Houston, I think it's important for everyone to understand, is a revenue cap that no other major city in the United States has to face. So we not only have a statewide revenue cap that limits how much you can increase taxes annually, that's fine, but we also have a voter-imposed revenue cap. And I'm all for saving money. I get it, and that is fine. But when we need more resources for these types of things that everyone is pretty much aligned on, we have to talk about what's creating these challenges, what's creating the challenges with law enforcement, what's creating the challenges with the ability to fund credible messengers. I'm fighting tooth and nail right now with Dr. Bindi and several others at Rice in our health department. Our budget's coming up next week, over 6.2, I think it's up to $6.4 billion. And the largest portion of that is for public safety. And that funding is not going down. We are not taking a penny away from the initiatives that we have started or are continuing to do. But for example, when you talk about the importance of the data and bringing our trauma centers together, I'm putting forward an amendment just to fund the first 2 years of that data portal that will live at the City of Houston that Dr. Bindi has been working on.
Yeah, what she's talking about is something I proposed through the Houston Health Department, which is a dashboard of gun violence, kind of like the COVID dashboard, to so that we can keep up with it and identify risk factors. We need to move on. Thank you so much for everyone. I wanted to give Dr. Dicker a last chance to have a few thoughts based on, help us, Dr. Dicker, help Houston. Any last minute thoughts?
I am really encouraged just to have the diversity of where people are coming from here in this audience and on this panel, and the true commitment to the community. This idea of coalition building, it starts in this room, and the biggest suggestion I have is to figure out a way after this conference, because a lot of times people come, totally energized out of these conferences. What's next? Figure out something you can lean on as to what's next to keep that energy that's happening in this room and that's along this panel of people who are truly committed to the community. How do you move forward with each other from here? A lot of conferences just kind of stop and you're like, okay, now what? So if you can come up with a next step, that's a huge win for Houston. And I think there are lots of really tangible actions already out there that I can see from this panel.
Thank you for that transition. Do we have time? No, sorry. So we wanted to leave a few minutes for table work for each of you to have these kinds of discussions at your table to think about next steps. But there will be time after some of the other panels, and even though they're different panels, as you can see, there are probably going to be some intersection. So think about some of your questions and discuss with your partners at your table. Also, during the breaks, there'll be some posters, some e-posters streaming up there. A lot of those highlight some of the excellent community violence programs that we have here in the city, and this is for networking and collaboration, so we're not all working on our own here. There's also a little bit of research from the academic institutions regarding gun violence. Those posters will also be on the website after the conference, so that you can all access them and hopefully improve networking collaboration. Thank you so much to our panel.
Dr. Dicker, thank you.
All right, everybody. Why don't we get ready to get back to our seats to keep on time here. I don't want to go over into lunch and have you guys too hungry, so. Okay, well, good morning. My name is Chad Wilson. I am a trauma surgeon at Bentop Hospital. This is the second year I've been able to be involved with this wonderful meeting, and I just want to thank everybody for their participation. I know that what we're talking about today is sobering, and these are difficult conversations. And this session, of course, is about the intersection of domestic violence and firearms. Obviously, a very tough topic, a very difficult topic. There's not one person in this room who doesn't have something painful that has happened to them or a close loved one or a friend related to this topic. And today can be tough, and we do need to understand the problem. But I do also want to recognize how important this meeting has been for me, because this is a room of people who are relatively optimistic that these problems can be addressed, that we're here to be very intentional about treating, firearm prevention and domestic violence in this case as a disease. And every disease has epidemiology, and every disease has a way to be treated and controlled. So with that, I'm going to introduce my esteemed panelists here, and then we'll start this panel and keep this conversation going. So we'll start here with, on my left is Christy Graves. So Christy Graves has been a nationally recognized community health paramedic for 28 years. Mrs. Graves is also a certified critical care paramedic through the University of Maryland, Baltimore CCEMT program, a former home health wound care provider. Mrs. Graves has currently held the position as the Director of Operations for Harris County ESD 5 in Crosby, Texas for 19 years. Mrs. Graves was also employed as an adjunct faculty member for San Jacinto College for 9 years. She has been elected Harris County Emergency Service District Number 4 Board Commissioner for 5 elected terms, and started her work as a hyperbaric medicine team member for 3 years before transferring to the Level 1 Trauma Center at Herman, next door to my hospital. Where she was for 4 years. She holds current certifications in the Texas Department of State of Health as an EMS instructor and ACLS instructor, PALS, traumatic brain injury instructor, BLS, AMLS instructor, and PHTLS. Also National Traffic and Highway Administration car seat inspector and advanced burn life support. In addition to this, she is a member of CETRAC EMTF 6 disaster response team, Cambridge member of Professional Women in Leadership, member of the International Association of Women in Fire and Emergency Services, and a National Association of EMS Physicians professional member. So thank you, Christy, for being here. And then to her left is Amy Smith. And Amy Smith Amy Smith has spent her career as a victim advocate in Harris County, Texas, having worked in the City of Houston's Health Department Sexual Assault Program and the Harris County District Attorney's Office Victim Witness Division, Crime Stoppers of Houston, and now she serves as the Senior Director of Operations and Communications with the Harris County Domestic Violence Coordinating Council. She has been involved on several local and statewide committees focusing on all types of victim-related issues. She has done trainings and presentations at the local, state, and national level on all topics related to crime victimization. She is also a senior fellow with the American Leadership Forum, and in 2019 she received the Vivian R. Miles Lifetime Achievement Award from the Texas Association Against Sexual Assault. And then finally, our third panelist is Amy Turney. Amy is a former president of the League of Women Voters of Houston in the gun safety and is the gun safety issue chair for the League of Women Voters in Texas. She's also served as a commissioner on the City of Houston Mayor's Commission Against Gun Violence, as well as the board of directors of NAMI Texas. She presently works as the district director for Texas House District 137. And Amy told me I could share this. Amy is also herself a survivor of domestic violence. So thank you all for being here. And with that, why don't we go ahead and start getting into some questions? Is that okay? You guys ready?
Yes.
All right. So I think I'm going to actually start with Amy Smith. I think, in your role, I'm sure you review a lot of data, state level data and Harris County level data regarding domestic violence incidents, and specifically those that lead to homicide, which obviously those are usually captured. A lot of the incidents are not captured for various reasons. In our community here in Harris County, or even in Texas at large, with the prevalence of gun ownership, what do the data suggest is the relationship in our community between firearms and domestic violence?
Thank you so much for having me here today. Intimate partner violence is what we basically refer to as domestic violence or family violence. Family violence and domestic violence are more broad term. Intimate partner violence is when one intimate partner causes violence to another person. But IVP is the leading cause of homicide deaths for women, and most are done by guns. According to the Texas Council on Family Violence in 2021, which is the last year of the total numbers, total complete numbers, 204 Texans were killed by their intimate partner. Of those, 75% were killed by a gun. In Harris County, in the same time frame, we had 46 people killed. 74% of those people killed by intimate partner were killed by a firearm. In the UTMB Center for Violence Prevention and the Harris County Domestic Violence Coordinating Council study that we commissioned during to study the pandemic impacts on the intimate partner survivors during COVID. 12% of survivors experienced threats with a gun in the first year of COVID alone. While there are a lot of where a lot of research has been done about intimate partner homicide risk factors, more research is needed on interventions and partners using violence on strategies to reduce risk for IPV homicides and violence prevention programs. We have a lot of programs that the Coordinating Council is a part of. We have a high-risk team which looks at high-risk cases that are going through the court systems. We also have an adult violent death review team which reviews domestic violence homicides. And we have a lot of recommendations that came out of those two entities. And one of them is, and I think Chief Satterwhite mentioned it earlier, is the fact that all these guns are stolen. Well, what we need is that we need to report that your guns are stolen. What we have also realized and recognized is that a lot of times these guns can't be traced, and we don't know how they're getting guns. So it's really important that if your gun is stolen, to please report it, so that we can kind of help keep track and try to keep track of where these guns are going.
Thank you so much. I think for the next question here, we'll go to Amy Turney. I want to talk to you a little bit about your work with the League of Women Voters and organizations such like the League of Women Voters. What is the role of organizations like LWV in speaking for survivors of domestic violence?
So the League of Women Voters, we're 103 years old, and we advocate for issues that are important to us, and we have since the very beginning. When we secured the right to vote, our advocacy work began with prison reform because we'd all been in jail for mayhem before that. And so we knew what the circumstances were we knew what the conditions were within the prison system. And again, grassroots here, the local leagues of women voters pick the topics of interest to them, and that usually just comes from someone like me coming forward and saying, I would like to work on gun violence prevention. And then in the League of Women Voters, we study an issue for a year or two, and we use fact-based evidence from journals, of peer-reviewed journals, and then we also may interview different government agencies or organizations relevant to that topic. And so it's a good place, I would say, that if you really want to be involved in advocacy and not be directed from an organization that gives information from the top down, it's a very good place to be. And so I, over the years, have testified for 3 sessions. This year I could not because I work full-time for Representative Wu, and that would be a conflict, but I still, in my spare time, helped behind the scenes, and we did have advocates who testified for a few bills. One of the things that we did that I think was very important in the state of Texas after Uvalde was we had a webinar. And in that webinar, we had Dr. McKay, Dr. Jeff Temple, who was a speaker here last year, and Chief Acevedo. And if you watch our webinar, it's on YouTube. It's on the crude side because it's very obvious that it's in-house and not professionally done. We don't have millions of dollars behind us. But it's very informative. And I noticed when I was one of the people behind the scenes on that webinar that there were some state representatives that were watching. And one of those representatives, and a few more, on the very first day of filing, filed raise the age bills. And what a raise the age bill is that in Texas, was a bill that would raise the age to purchase an AR-style weapon from 18 to 21. The shooter in Uvalde he purchased that weapon on his birthday. So that was exciting that happened, and then the bill got a hearing. And then in addition to that, it was voted out of committee. That's a historical precedent in Texas. A bill like that to get voted out of committee, but it was a realistic bill. To try to have a bill, knowing the tone in Texas, to outlaw ARs or high-capacity magazines, not so realistic, but this one was realistic. 2 Republicans voted for that bill to get out of committee, and a Republican chair allowed that bill to be voted out of committee. And in the past, you would think this would all happen along partisan lines. The Republicans are going to vote this way and the Democrats are going to vote this way. But when people look at the League of Women Voters, they know that we have an impeccable reputation for impartiality and fairness. When I was president of the board of directors, I had an equal number of independents, Republicans, and Democrats on the board of directors with me. And so they look to us and they respect us, and they don't see us as an organization who may just be raising money to run people against somebody. So I'm very happy to be a part of this organization and here today.
Thank you so much, and thank you for you led into my second question, which was the value of organizations to sort of provide that nonpartisan voice and input for our legislators and our policymakers. Why don't we move on to Christy? Christy, I have a question just about some of the things you've obviously seen in your career in EMS, and I know you have an extensive experience as a leader and personally providing that frontline care. And in the sterile environment of the hospital, we see bad things, but we always recognize that what is seen out in the field is so much more difficult. And I'm sure you've come to recognize patterns in some of which just from your personal experience as an EMS provider and also from reviewing data that maybe foreshadow the lead up to intimate partner violence or domestic violence becoming then gun violence. Can you comment on this for us?
Thank you, Dr. Wilson. I first want to say it's an honor to be on a panel with these 2 ladies, so thank you for allowing that. And you're correct. Oftentimes, as EMS providers, we go into these homes with multiple providers. If it's a large system, you may not get the same provider at every response, and it's often a false flag when we show up. They're not going to always be telling us that they are in a domestic violence circumstance. These false flags will come in as falls, they'll come in as abdominal pains, head injuries. Oftentimes the abuser will still be in the home and there will not be a law enforcement presence. We have to train the paramedics to not only to be aware of those patterns and sympathetic of it, but it's you guys at the end user point who receive those patients that continue to do those programs like Dr. Dicker said. And I can't agree with her more. It takes a village. It starts reducing of trauma and feeling safe. And if you have a program or policy at your facility to ask the question, are you safe at home? Do you feel safe at home? Asking that question just one time in the ED may not be enough. You may have to repeat that question. If the injury pattern does not fit the story, it's okay to over-advocate or triage and ask again in multiple facets, especially if you can get them away from their possible assaulter. The other part of that is data is key. And the data she's talking about, we view it as currency. In our field, we're now starting to say, hey, should we be keeping these injury patterns by EMS providers so we can now identify frequent callers, frequent users who may not be coming in with law enforcement presence as a person that is being routinely abused, and it may not even be physical. This could be psychological, this could be food deprivation, And this could even be economical, where they're not getting different needs met. And let me be as clear as I can be. When we lead up to our gun violence, you do not have to be shot by a gun to be injured by one. We often see our victims pistol whipped and hit by that weapon just prior to them being shot and killed by it in our next response. So let that be an indicator if you see, we call those lead ups.
Thank you very much. And again, very sobering to think about what is seen out in our front lines every day. And I can really relate. We have that same responsibility in the hospital, in the emergency department, when we're evaluating patients who come in with a story that is not necessarily labeled as intimate partner violence, but something doesn't fit right. I have a system where I put sticky notes on any patient I've seen, and I've been in the same hospital so long that I've started to have trauma patients, and this is the third time I've seen them. And that's not a coincidence ever, right? So thank you for sharing that. Earlier, we had a comment about sort of bipartisan interest in work to limit or to improve gun violence prevention and also related to domestic violence. I have a question. I think it would make sense that a bipartisan issue would be the costs associated with domestic violence. There's a financial cost and a financial burden to society at large, and even someone who maybe is not their politics don't lean towards protecting a vulnerable population, that's its own issue. Can any of you speak to either any of you that with data that you have about the economic impact of domestic violence in our community?
Well, if you think about a domestic violence situation, you think about all the people that are involved. You think about the cost of your EMTs responding. You think the hospital costs that are associated with it. You think of the cost of the time off from work. You think of childcare issues. Domestic violence is a huge financial burden on our society. And when you look at some of the things that are taking place right now, you have, as we heard earlier, that the city is investing in One Safe Houston. The Harris County Commissioners Court has graciously funded through ARPA funds the Domestic Violence Assistance Fund, which is helping domestic violence survivors with services that they normally would not receive. The thing about Harris County and the greater Houston area is that we have amazing resources. We have amazing resources for everything. We just don't have enough of them. And when we were talking about, when Chief Satterwhite was talking about how many police officers there are, there's only a little over 300 shelter beds for domestic violence survivors in Harris County. And if you look at that, we have a 70% turnaway rate for those trying to seek shelter. So we're trying to look for some alternate ways to help domestic violence survivors. The Domestic Violence Coordinating Council also has a housing program that does rapid rehousing for domestic violence survivors, where they can have their rent paid for up to 2 years and their utilities while they can try to get back on their feet. Again, there's not enough of those. I mean, as much money as the federal government is putting into Harris County for that, we still don't have enough. So when you look at it, you look at where it's being spent. To kind of follow up the court backlog, the district attorney's office needs more prosecutors. Cases continue to go. People are out on bond, out on multiple bonds, especially in domestic violence cases. We have some folks that are out on 6, 7, 8 domestic violence bonds. What is that telling that abuser? oh, you know what, you can abuse, you can get out on a dollar bond. We've had people out on a dollar bond. We've had people out on a $100 bond. They continue to commit these crimes, and they're not being held accountable. And that's what we really need to do, is as a community, we need to start holding these abusers accountable for their actions, because it won't stop until the abuse stops. And there's so many different factors. I mean, you know, Dr. Dickerson talked about it earlier this morning, about how many, there's the socioeconomic factors, just how much is behind leading up to it. It's you know, it's race, it's poverty, it's socioeconomic status. There's just so much that needs to be addressed. And when you look at the cost, I mean, even if you look at, I mean, the cost of a hospital bill, and I think what really got me this morning was how many gunshots injuries there are. And think about those hospital bills. How many are those how much is that hospital bill? And who's paying for those bills? Most of our survivors don't have insurance. And even if you have insurance, it's not going to cover a majority of that bill at all.
And I have to agree with Amy. We have resources very limited. Oftentimes in the ambulance, it lends to us having to determine severity versus necessity. Examples would be, I've had nurses having to barter domestic abuse victims on who gets to go and who doesn't, based on whether or not they had children or other things associated. And when they began to feel burdensome, at some point I remember saying to a PA, you know, this one was just slapped and the other one punched. Where's your compassion level if she'd been stabbed or choked? Does it change your, you know? And then I realized I was being too harsh on a nurse who was doing her best as well. And so oftentimes, even in EMS, we are the only people that they see healthcare-wise. We oftentimes are in and out of these homes. And when I looked at the screen earlier and you put up the red level, my district was the blackest and darkest of the most shootings. Because we call ourselves the Dirty East Side. We have the petrochemical on the east side of Harris County, and we probably are the most socioeconomically challenged. And these types of stressors tend to cause family dynamics, not only between partners, but siblings as well, become very aggressive and violent. And so when parents become afraid of their children, there are no shelters for them to retract to. So I again agree with Dr. Dicker when she said that we must address these issues very early on with childhood development, childhood programs, but the key is going to be consistency. We have to maintain those programs and be consistent throughout their childhood education in order to make real impact.
I'd like to also say, as a domestic violence survivor, knowing the reality of what's available to a survivor is very demoralizing. And many of us do not report until it's almost too late, or it is too late. I knew that when I reported my ex-boyfriend, who'd gotten an apartment in Austin where I'd moved to get away from him just as a stalking base, I knew that if he were arrested and fully charged and convicted, at the time, domestic violence was a misdemeanor. It's a felony now, but at that time, it was only a $10,000 fine and maybe up to a year in prison, which would just give him a year to plot his revenge. So, in my conversations with the domestic violence agencies, they have to be very careful when they talk about gun violence prevention, because you have people in these positions of powers that aren't the victims of domestic violence, and they'll yank their funding. And so this is where the other organizations are very important to be the advocates where the domestic violence organizations cannot speak up on gun violence prevention.
Thank you all. And so, you know, one of the things I'm hearing is that, you know, a dollar spent on resources a shelter bed, for instance, is a very well spent dollar. If you can prevent and this is not just because it may prevent an event, it's a well spent dollar financially because of the downstream costs when we do not stop these things. So thank you all for sharing that. I have probably one last question to raise for me before before I open it up to anyone here in the audience. And anyone can answer this. I just wanted to know if you had any data or just personal experience around around pregnancy. My understanding is that pregnancy itself, ironically, increases the intensity of events in terms of intimate partner violence, and which is mind-boggling that would, when you're most vulnerable, is when the events escalate. Any personal experience or data to share from any of our panelists about that issue?
Well, what we do know is that pregnancy is one of the stressors that could cause, that possibly exasperates an already difficult situation. Pregnant women are at a higher risk for domestic violence. We can have a whole nother topic on maternal and child health, which is another topic, another committee that I'm on with the March of Dimes. The abuser's losing control. They're losing sole control of the person that they're abusing when she becomes pregnant, because someone is taking away. And so, but to look for signs of abuse, and it could be little signs. It could be when or if she goes for prenatal care. I mean, a lot of times they're not allowed to go to prenatal care, but if they do, look for signs, pinch marks behind the arms, strangulation is one of the most highest risk factors for lethality, meaning that if a person is going to strangle someone, then that is a very high risk that they are going to commit domestic violence, homicide. So if you think about it, if you look at the stats, pregnant women are at a higher risk only because of the losing control. And I also wanted just to touch on on one other thing too, that when we're talking about domestic violence, one of the things that we have discovered with our adult violent death review team is a lot of our domestic violence domestic violence victims, because they obviously did not survive if we're reviewing their case, did not realize they were in a domestic violence situation because they felt that was normal. So what we like to do, and what we have liked to talk to our advocates and our community partners about, is talking about healthy relationships. Because how can you know you're in a domestic violence situation if you don't know what a healthy relationship is? So it's really important to talk about healthy relationships. It's also really important for those that are working with domestic violence victims to have really difficult and frank conversations about what is the outcome of this domestic violence relationship. Could it be your death? Could it be the death of the offender? Could it be you being charged with a crime? Could it be you being charged with a homicide, you being charged with an assault? Because that's a very real possibility as well. So to have some really frank conversations about what does it mean to stay in that relationship, and how can you safeguard yourself and your kids and your families from that as well.
I can't speak to a pregnancy, but I can say alcohol and drugs are a high mitigating factor from the EMS view, for sure.
Absolutely. I think now we can open it up to any members of the audience if you have any questions or comments that you'd like to raise. I'm sorry, it looks like one has been written down. All right, so this question says, bills proposed in the legislature to improve firearm surrenders for abusers who are prohibited from ownership have previously failed. What local initiatives do you know of that are striving to improve surrender protocols for domestic violence perpetrators?
Harris County has a gun surrender program out of the 280th District Court, which is the protective order court. It is a program that until recently was very active and working really well. And I believe, as Councilmember Kamen noted, there was a Fifth Court of Appeals decision that gave the right of someone that has a protective order, gave them the right back to have a gun. So our gun surrender program was out of the 280th District Court. We tried to get funding for that. We did not get funding for that. Sheriff Ed Gonzalez said this is an important enough issue that I'm going to go ahead and fund this gun surrender program. So when a person had a protective order in the past, before the Rahimi decision, which was out of the Fifth Circuit Court of Appeals, they could not have a gun. They could not possess a gun. The gun surrender program allowed them to have an avenue to follow the law, which would be they could surrender their gun to the sheriff's office during the length of their protective order. After that time, if they followed all the laws, there was no convictions, they could get their gun back once that protective order expired. What the Rahimi decision did was take that away. So right now, we are waiting because the Supreme Court, the Department of Justice has appealed it up to the Supreme Court, and several states' attorneys generals have signed on to the Department of Justice to try to get an opinion. The Supreme Court gave Rahimi's response was supposed to be till May 23rd, and they extended it to the end of May. So we're just waiting to see what the Supreme Court can do. That is going to put in jeopardy a lot of the gun surrenders only around protective orders. Now, Texas has a lot of laws about felons that cannot possess firearms. So there's a lot of laws. We just have to kind of rework some of our Texas laws around our reaction to this particular thing. We've missed this legislative session. There were several laws that were filed around gun surrenders, gun ownerships, that did not go anywhere.
There was one bill, and Nicole maybe can address this later. I can't remember the bill number, but Nicole and I witnessed it, and we were pinching ourselves at one time that it looked like there was going to be some bipartisan agreement and even some agreement from the NRA, but it didn't go anywhere.
The next question, this question was to Christy. It says, do you see a lot of cases where people have been threatened by gun violence but delayed reporting the incident due to a stigma associated with it?
Absolutely, nearly every time. In fact, there's a lot of psychology and psychological damages that go along with physical. And in fact, I see often the psychological damages start before the physical violence in a grooming type pattern. And it doesn't have to always be a female. A male can be also abused by a female. So we see both sides. It can be same sex partners, etc. Either way, once the person is in the situation, they love that person, and their definition of between love and how that other person is caring for them, because they go through different phases, including psychological, physical assault, and then the honeymoon phase. This continuous cycle causes them to take them back, go back into the situation. So even though we're getting them help or putting them in a shelter, we will show back up to the address and be like, what are you doing here? Why are we back here? And so we have to be very careful in how we approach them, because if we talk to them any particular way or in an authoritative way, they're going to reject us. And so we have to allow the police officers to do the legal conversation, and then we train the paramedics to do more of a health advocacy conversation. That includes exactly what she says, and that is, this could lead to you being the one going to jail. The last time I was in a circumstance, we had a female that shot and killed the male. We had 3 children between the ages of 6 and 9 in the home that we had to cross over the body of the dad, and someone was suggesting we take them out the window, and I said, absolutely not. You want to confuse and traumatize 3 little girls, carry them out a window, right, of their home. So we decided to get 1 police officer each to cover their heads and we held them to our chest, and then we stepped over the body. But they had to witness this, and this entire situation could have been prevented because there was a lead up until the death. He had been hitting and beating her for the last 6 years of the youngest child's life. When we got into the back of the ambulance, I wanted to sequester the girls at some point because the two older girls were bullying the younger girl. The younger girl was on the mother's side, and the two older girls were on the father's side. And now you're becoming in conflict with young children who are now in a very traumatic situation. That is the time that we need social workers and police advocacy to start intervention immediately. And again, those types of funding, I'm so happy to hear that the city of Houston is staying on track with that and has not decreased that in their budget. The same for Harris County. There's just no way possible that you can with a city this large.
That is so heartbreaking to hear about that story, but it highlights what we were saying before, that at that event, I mean, the emotional and downstream financial costs of what that family has now endured, if that event is prevented, that family doesn't get torn in half, those sisters don't come into conflict. Right. That's horrible to hear about. It looks like we're out of time.
Can I say one last thing? I weathered 4 hurricanes in this community, and my last one was Harvey in my 30 years as a paramedic, and I've seen the most incredible people come to peace and help each other. It was the most amazing and beautiful thing, and it renewed my faith. Please do not give up hope. Each and every one of you in this room are here for a great reason, and just know that it can be done. It was done in that moment. Yes, we were under tragedy and stress, but if it can be done and everybody come quiet and take care of each other during one of the most disastrous things that we've all witnessed and went through, then we can do it in our everyday lives. So I just want to give you all hope. It's not all negativity out there.
Amen.
Yeah.
All right. So at this time, I think we will now have discussions at our tables about what we've all learned and heard, and I'll let you guys do that. Thank you so much.
All right. I'm hoping that we've stimulated lots of great conversation at the table, and I'm going to bring us back now to our next panel on unintentional injury. My name is Sandy McKay. I am a general pediatrician and the Huffington Fellow here at Baker Institute for Public Policy. I'm also an associate professor with the University of Texas Health Science Center at Houston, and I am not Dr. Seeger, who is on your agenda today. I am filling in for her, and so I hope to be able to fill her shoes today. For our panel for unintentional injury, wanted to really quickly frame up why we wanted to include unintentional injury today for our discussion. And as you can see here, when we think about firearms, there are lots of different causes behind there, and we really think about it in 3 epidemics. We think about unintentional injury, suicide, and homicide. But mass shootings we talk about the most because they dominate the media and the discussions. But we don't want to miss or not think about the unintentional injury in the discussions here. And when we think about unintentional injuries, they comprise 9% of firearm deaths around the world, and is 4 times more common in the United States than any other high-income country, and it's higher than so many of the other countries combined. And when we look at the NVDRS data between 2005 and 2015, it showed a total of 1,260 unintentional firearm deaths during this decade. So that's more than 1 a day of unintentional firearm deaths in the United States. Something for us to be talking about. Highest rate is for males between the ages of 10 and 29, which kind of surprises me because I think everyone classically thinks about the 3-year-old getting into the nightstand, but that's really not the most common one. But the circumstances are playing with guns, thinking that the gun is unloaded, or hunting accidents. And alcohol is involved in nearly 1/4 of those deaths. So this is an area that we should be thinking about because when I think of unintentional injury, those are 100% preventable, and those are areas that we can make an impact, and we have an esteemed panel here today to think about how we can make a difference in firearm injury prevention. And so I am going to allow our panelists here today to go down the row and introduce themselves and to let us know a little bit about the role that they play in their organization and their efforts in firearm injury prevention, and then we'll get to our questions. So I'm going to let us get started off with Sarah Beth Abbott.
Thank you, Dr. McKay, and thank you again for the invite to be here today. I am the Injury Prevention and Outreach Education Coordinator for Children's Memorial Hermann Hospital, which is a Level 1 trauma center for pediatrics. It is housed with our Texas Medical Center campus, which is our adult Level 1 trauma center. I have a Bachelor's of Science in Health Education from the University of Houston, right down the road, and I have several years of program planning using evidence-informed prevention practices. I am an active member of the Harris County Child Fatality Review Team, and also am members of the Southeast Texas Regional Advisory Council, which may be a fantastic venue to get all of our trauma centers together to discuss opportunities. And then I'm also the program coordinator for our Injury Free Coalition for Kids team with UT Health and Children's Memorial Hermann Hospital. Nicole?
Hi, I'm Nicole Golden, and I am the Executive Director of Texas Gun Sense. I live in Austin, and we are a nonpartisan, nonprofit organization statewide that seeks to prevent gun violence and other gun tragedies through education, partnerships, and policy change. I started out in this work actually as one of the first leaders with Moms Demand Action right after the Sandy Hook school shooting. And at that time, my eyes just opened and my life kind of took a different direction. And this world of gun violence and those impacted by the ripple effect just opened to me. And over the years, I learned it was so much more than mass shootings, like Dr. McKay said, which was the thing that got me involved and gets so many of us involved. But it was unintentional shootings and suicides and community violence in the communities that tend to be ignored. And I've just found a million more reasons to stay involved. I wanted to make a career out of this work, and I've done that. I've been the executive director of Texas Gun Sense for just over a year. I was hired in the permanent position after being in the interim role right before the shooting in Uvalde. So it has been really a year of crisis response, personal trauma for me and all of us involved, and then we just finished up the legislative session. So it's been a long year, but it has solidified my lifelong commitment to this work, and I'm so glad that includes all of you.
I'm Kim Ogg. I'm the Harris County District Attorney. I'm a native Houstonian. I grew up here and have lived in many of the different neighborhoods. I've been your DA for about 6.5 years. In short, the District Attorney's Office is a reactive law enforcement agency. Law enforcement agencies and officers are called to the scene of a crime, sometimes an unintentional shooting, and the District Attorney's Office in Harris County, uniquely in the country, is contacted prior to an arrest being made. Law enforcement has the authority to arrest, but we actually approve the charges. This is an agreed upon arrangement that began in the 70s, and it gives an added layer of protection to everyone because it's another review. The role we play with healthcare providers is intimate. They are the people who we turn to, police first turn to for help for the injured. They are our witnesses as we go to prosecute. And as I muse over the problems in criminal justice, I often think it could be worse. I could be in healthcare. I told the doctors that. Or advocacy for gun safety in Texas during a legislative session. I could say that as well. So my experience as the district attorney is wholly traceable to my mother's experience when I was just a small child. She was a kidnapped victim, not at gunpoint, but at knife point. That influenced much of my career. I wouldn't say that I knew that, but when I got into law, my idea was to go into big law and get out there and try some civil cases and make some money. And instead, crime victims in the late 80s, when we were having a violence wave, really got my attention. And I saw the damage being done in our community. I saw the need for not just accountability, but sensible enforcement of the laws, and it my father was in politics, so I came from having seen the legislature in action. I felt like we needed to play a role in our own democracy, and that's why I think being in elective office is so important. And in Texas, that centers in large part in criminal law around firearm violence. And so here I am for the second year in a row, and I'm so honored to be on a panel of women who have dedicated their lives to stopping firearm violence, not just treating it, but stopping it.
I'm Irma Ugaldi. I'm a pediatric emergency medicine physician at McGovern UT Health, so Children's Memorial Hermann. Can you hear me? Okay, good. I am the Director of Pediatric Research for our section within the emergency department, and interested in firearm injury prevention as well as the epidemiology of pediatric trauma and judicious use of imaging in children who are seen in our trauma bays.
So this is obviously a really exciting group of esteemed women. I love that was pointed out in there, because it's important to empower women is what I believe as well. And I think one of the things I wanted to start off with was looking at systems, right? We need to look at how we address firearm injury prevention, especially with unintentional injury, is what are some of the systems levels approaches that have been taken? And I'll start with Sarah Beth and look at what are some of the systems that your hospital has done at looking at efforts to reduce unintentional injury within the community.
Thank you, Dr. McKay. So I will take you back a couple years. We were researching some of our data, and that's something that I think has been yet to be mentioned is the data that we have is probably not the data that we need. So having said that, when we reviewed our trauma data, we found that gunshot wounds were inching up past motor vehicle crashes, and this was in 2019. And in 2020, when we reviewed it, it passed it. It absolutely did. Dr. Lois Lee out of Boston Children's did a perspective in the New England Journal of Medicine last spring that mentioned the CDC's efforts in showing that the data had crossed the lines, that gunshot wounds were the leading cause of death versus the motor vehicle collisions. And so that got the attention of a lot of our leaders. That got the attention of my team, or our team, and our faculty members, as well as our Memorial Hermann Hospital System leadership. And so we started running numbers again, and we absolutely confirmed again that gunshot wounds was absolutely leading the cause, or leading the pack for that, say. What happened thereafter was unfortunately the Uvalde tragedy. And then there was a public commitment from our Memorial Hermann Hospital System CEO, Dr. David Callender and Dr. James McCarthy, that decided to have a public pledge to, one, increase our school-based health clinics for mental health, as well as dedicate firearm safety kits in the community with no questions asked. That led to a conversation that I had with my VP, or my vice president, Tom Flanagan, and he had said, okay, Sarah, let's get planning, let's do this. So I am proud to say that our CEO led down some funding to our injury prevention programming, and we were able to acquire 10,000 firearm safety kits, which we thought it was going to be a couple thousand. Not a big deal, but when the price, we were able to buy in bulk for 10,000. It was phenomenal. But what do we put in this kit? That was something that was really important to me as an injury prevention specialist, because it's not just about a cable lock. It needs to be more about education, especially if we're not able to answer any questions, if it's no questions asked. So we developed a fact sheet, firearm injury prevention for parents. What can they do? How can they help the situation? We included the 988 suicide and crisis hotline. That's a new established number that a lot of people in our community do not know. And then we also had a babysitter note pad, which seems strange to throw into a firearm safety kit, but it really doesn't, because on that babysitter notepad, next to, are there any allergies? What is the poison control hotline? What time is mom and dad going to be back, or the parents going to be back? Is there an unlocked gun in the home? It's a conversation tool that we can use in the home to talk to the babysitters, to the caregivers, to the grandparents, et cetera, and have that conversation. And then we gave them the tools for the cable locks. And I'm just going to jump to the punchline here. We were able to give 10,000 firearm safety kits away into the community with a lot of support from our colleagues in 94 days. It was incredible, and there is such an incredible need to get that equipment in. So I will also thank Honorable Ogg that for the efforts that the DA's office has done with firearm safety kits, as well as the boxes, lock boxes.
That's such a great transition over to DA Ogg. I'd love for you to describe some of the efforts that your office has also done in starting those conversations, because a lot of that is starting the conversation around firearm safety. And how has your office been able to raise that awareness in our community?
Well, there's two ways that we raise awareness in the community as the DA's office. We're reactive in our role structurally. We follow the police. And so the first awareness that you usually see from a prosecutor's office is someone being prosecuted for a crime. Oh, that's a crime? Oh, a child died, somebody could be charged with that crime? Now, this was not always true in prosecution. In the 80s, when I began, while it could have been pursued through manslaughter or criminally negligent homicide, generally it wasn't. In about 1994, it became a municipal ordinance to negligently allow a child to get access to a weapon. These things had an impact because they had a criminal penalty. So the first community awareness you get is penal. It's negative, and it's supposed to be a deterrent, but I would say that negligent access to firearm cases have remained much the same since we started keeping statistics on them in 1995. We had 2 in 1995. This year we've had 4. Now that's in the first 6 months. So there's obviously an increase, but think about the increase in the number of weapons. The second thing that our office does, other than prosecute to raise awareness, is to try and be in the prevention business by collaborating with NGOs and with other stakeholders, the medical, the health community, to do things that will try to interrupt the crime. Example, firearms. Many firearms get into homes and into hiding places, or the coffee table, not hiding places, because somebody stole the firearm. We find that many firearms used in crimes, including negligent access cases, are stolen firearms. So we engaged in a partnership with the police and with some of the business districts to give away gun safes for your car. They're not big gun safes for your home. They're just temporary holding boxes, so all the people who want to carry weapons but can't carry them everywhere they drive to can at least secure the gun in the car. Or they get out to go in the store and perhaps the children are left in the car. They can store the gun securely there. So it's something that we can do. We've engaged in public service ad campaigns, all collaborative, but our message is generally one of deterrence for something related to crime, where it intersects either before the negligent access and the horrible thing happens, or afterwards in the prosecution and the holding accountable of the people who made the gun unnecessarily available.
And then continuing on with some of those conversations, Dr. Ugalde, when we think about conversations with families in the hospitals, working in the emergency departments, I'm sure that you've seen your fair share of firearm tragedies as well. How is it in your line of work when you talk with families, about firearms within the homes? When are the best times to talk with families to try to aim about prevention, and what have you seen in your line of work?
So I think that, it's always really situational, right? So in the ER, first of all, during COVID, I think many ERs across the country saw a decreased number of patients. I think we can all agree to that, right? 60% decreases across the nation. Unfortunately, our actually trauma rates in Houston went up. Mm-hmm. And we've looked at this, so we actually have data to support this. And it wasn't just trauma, like overall trauma, MVCs, burns, falls, bike accidents, lots of fractures, but our firearm injury rate increased 30% from 2019 to 2020. So we're actually seeing a lot more firearm injuries now than we had before. And I mean, they crossed the gamut. 2 days ago, I was on shift and a 14-year-old boy got shot in the foot by some people he knew. They were in a car, they got out of the car, he got shot. I've seen a 1-year-old child who got shot in the foot as well, a 1-year-old child, because the gun that was on the refrigerator fell when someone pushed against it, and he's got a shattered foot now. We see children shot in the abdomen who come back over and over because now they have infections, they have problems with their G-tubes, complication after complication. So I think that, when we have an urgent thing, an urgent trauma, obviously we have to take care of that in the moment. But parents are really open and they want to hear about how to keep their children safe. We had a child who was shot in the leg because he was playing with the gun, with Dad's gun, and Dad didn't know that he knew where the gun was, and he didn't know that there were bullets in that gun, and that dad was completely traumatized. It's one of those things that you wish you could be there in the moment to just kind of stop that child, right? But you can't always be there. So I think that it really depends on the moment, and certainly when that kind of thing happens, we take a moment to obviously take care of the patient, urgently, whatever the immediate need is. But we go back and we try to, have a conversation, and we try to have a relationship, despite that you're in the emergency department. You try to have a connection, and you go back into the room, and you talk about gun locks and safety, and keeping bullets separate, ammunition separate from the guns. And you have to have these very direct conversations with parents who are very open to them, and maybe haven't had those things because they think it won't happen in their home, right? But it's tragedy after tragedy, and it really is something that's so preventable. This family, it was a mom and dad who had who had a gun to keep their home safe, but they didn't know that their teenage child would be curious enough to go and just try to play with it. So I think that it's, during those moments that you try to connect with the family and really just talk about the things that the American Academy of Pediatrics has put out, right? Lois Lee and others around the country, and really just say, just like you do about, drowning prevention. We talk about drowning prevention all the time, about helmets, and it's just incorporating that into sort of the milieu of prevention, injury prevention. People want to hear it, and people have to hear it, because sometimes lives are just so busy that they don't have a moment to sit down and really kind of go over what's really needed to keep the family safe. And then, I think that you all know that mental illness has been, we've seen an increase in mental illness. We have patients boarding in our emergency departments for hours or days, sometimes even weeks. And with that, we have to have the conversation. Are there firearms in the home? How can we keep those firearms out of the home when there is a, either an adolescent or a young adult who's suffering from mental illness, and who has depression, and who has had suicidal ideation? I mean, we are having a crisis, not just with firearm injuries, but with mental illness. And they're so integrated, right? You cannot, there's everything's so connected. And I think that overall, after the pandemic, we've really come to see how people are suffering. I think that's one of the beauties, of working in the emergency department, is that I have this window to sort of the social harms, the social situation of our country. It happens sort of day in and day out, where, I actually just had a domestic violence case 2 days ago as well, where we had to call the police, one of the parents was arrested. He actually was trying to choke the parent in the room in the emergency department. So these things are just, they happen day in and day out, and we think that it's sort of someone else's problem, but until we come together as a community and really see that this is sort of all of our problems and that we need to help each other, because if we don't help each other, this is just gonna get worse. With the data that we looked at with firearm injuries, we've seen an increase in firearm injuries. There's no doubt 30%, I said, from 2019 to 2020, and 2021 has pretty much remained constant from 2020. But when you look at the disparities in the firearm injuries, we've seen an increase of 50% of African American children from 2019 to 2020. So if we are talking about disparities, which is a big issue across the country, that's also come to light with the pandemic, we need to even the playing field, and we're not going to if violence continues to sort of propagate the way it's propagating. So we all have a responsibility. We all have to sort of not turn our eye the other way and go home and sort of try to forget about it. But I think that we need to find resources and connections, right? We need to work together with different, we have like, 3 trauma centers in the city of Houston, maybe at least. We have to work together. We have to bring our numbers together. We have to bring the data out, right, that we have. I know Bindi has worked on that through the CDC, and now finally this type of work is being funded, but we need to continue to look at that data because it's not just one cross-sectional point in time. This needs to be sort of a continuum so that we have the information and we can really try to, impact those communities most at risk.
Absolutely. And I think that when we think about things like connection, there's a lot of work that's being done in even coalition building as well. And I'd love to have Nicole talk about some of the work that she's been doing, because I think leading an advocacy organization, it can be really easy to be pegged as like purely a political-based organization. But your organization has actually made incredible strides in coalition building. And I'd love for you to describe some of the work that's been done in building those connections that we're talking about here.
Thank you. Yes, we are a nonpartisan organization, and I maintain that this issue is a nonpartisan issue. If you have one-on-one conversations with gun owners and people out in the world, regardless of their background or how they vote, most of us have common ground on preventative measures. But it doesn't often get portrayed that way, certainly not inside the Capitol building. I know we are operating in a very divisive landscape. But when I took the job as the ED of Texas Gun Sense executive director last year, one of the first things I looked at was how we could strengthen the work that we do that's not just policy focused. Policy is still incredibly important. It's one of the cornerstones of our mission. But I looked at how we could strengthen our coalition building and our community-based initiatives, because there's really not one solution to preventing gun violence and deaths and injuries. And there's not one entity who can do it, certainly not alone. And as someone who's been doing this for 10 years, people would often say, are you working together? Are you working together? And yes, many of us, our organizations have worked together, but I've really focused on strengthening those partnerships, and I am very, very proud. There's numerous people in this room who represent organizations that are members of our statewide coalition, the Texas Coalition to Prevent Gun Violence. League of Women Voters is there, Community Justice Action Fund. We have somebody here from that organization, Moms Demand Action, and I'm probably missing someone. Texas Pediatric Society, of which probably numerous people here in the audience are members. And so we added organizations to that coalition this year. We're around 20 or so now, and we really work heavily on coordinating our policy actions. And then we're going to work not only during legislative sessions together, but also year-round to support the community-based initiatives that we're all working on. That's just one coalition. I'm heavily involved in several. Another one is the Invest in Us Coalition to secure funding for community violence intervention. My co-lead Christina is here. And that's one of our priorities, is to reduce the daily gun deaths in Black and brown neighborhoods, and we do that through that group. And then lastly, I met Dr. McKay in the past year, and we had a shared mission to look at ways that we could expand temporary out-of-home firearm storage for individuals in crisis. We are operating in a state that doesn't have an extreme risk protection order, otherwise known as a red flag law, and we probably won't for a long time, is the truth of it. It's been something we've worked on for years, and we will continue to. But in light of that, but also in light of the fact that there's not just one way to save people's lives, we need people to have access and options. There's a few states doing incredible work to create maps of locations where someone could drop off their gun for a temporary period of time, voluntarily, if there's a crisis in the home. Maybe a suicidal teenager, maybe they're suicidal themselves. Who knows what it may be, it doesn't matter. And Dr. McKay has been doing a lot of research in this area, and I'm so grateful that we connected. Together, we have brought a coalition of advocates from the veterans community, from the medical community. I'm a member of it, and gun dealers as well. And gun dealers are critically important because they are going to be the places where these guns are likely going to be stored. We need them. We may not agree on everything, it doesn't matter. In this coalition, which we're calling the Target Safety Coalition, we talk only, in that group, we talk only about how we can expand access for people who are in crisis to prevent largely suicides, and I know there's a panel later. Dave Lewis is a member of our coalition and is speaking on that panel, but any kind of unintentional injury or shooting or trauma or violence. There's an intersection with policy too. We helped to file a bill that did not pass this session, but it would actually have reduced liability for gun dealers, because what Dr. McKay in her research has found is that a lot of gun dealers are concerned about their liability when they return that gun. I can't think of a more bipartisan piece of legislation than that, so we're going to keep working on it. But in that coalition, we have a singular focus, and that's to expand this access. And I find it very creative, which is something that I've been very dedicated to this year, is how can we be creative? How can we be innovative about reducing gun violence in all its forms, not just through policy, but through partnerships and through community-based initiatives? And it's something I'm thrilled about, and thanks for asking about it.
Yeah. Well, certainly, I think one of the things that we need to do in addressing firearm injury prevention is thinking outside the box and being creative and building those partnerships as well. And I know that many of us up here have really worked to see where we can build those collaborations to kind of overcome barriers. And I think there are several barriers that we have encountered as well. And so I think I'm going to open this up to everyone up here to just speak about where are some of the barriers that you've experienced in the work that you've come up with, and how have you addressed those barriers?
Anybody want to take a stab at that one?
Go ahead.
All right. All right. Sure. So I will, I mentioned a little bit about data earlier, and something that just came out last week was the CDC's MMWR, which is the mortality and morbidity weekly report, and they've actually published the information from the National Violent Death Reporting System. And within that report, it was listed, that the unintentional firearm deaths occurred 75% of the time in the home. That is such rich information. And so one of the barriers that I've overcome is finding that minute, very detailed information to help us drive injury prevention programming. Because our firearm safety kit programming is fantastic, but is it going to hit everyone that we need to prevent a suicide, to prevent a homicide, to prevent the unintentional injury? So that was why it was very important for me to overcome that barrier of what population are we going to hit, to make it a well-rounded kit. And the other thing is, the other barrier that I had was the no questions asked in the op-ed. I felt it was very important that anyone involved in our 22 outreach sessions that we had 11 in our hospitals and 11 in the community, that they were educated and trained and given the information in case they did have questions asked at that event. And that tool that I created was actually very helpful in some of these encounters that we had with the community and the public. And then lastly, how do we maintain the efforts? So one of the biggest barriers I have is funding, so I'll just leave that comment there.
So I love obstacle questions because they require solutions. And that means we've got to make our brains strategize. So being creative and thinking out of the box is fun. When it comes to firearms in Texas, the biggest obstacle is the access and the volume of firearms. Now, prosecution is supposed to be a deterrent. And so community awareness is important for a couple of reasons. One, you want to inform parents as much as possible. Guns out, bad jail. Our PSAs use children because that is more compelling, I think, to people watching. They see a child access a gun. When they see it in our PSAs, I think that moves them. But in general, deterrence is done through prosecution and through making people aware of that. However, it is also what I've seen, awareness is the way big change starts. Let me give you an example. In domestic violence. Domestic violence used to be considered a family problem. It wasn't necessarily criminal. Of course it was. Assault was always against the law. But assaulting your wife, well, you know, families have problems. It's in the home. It's a private matter. When I came to prosecution, that was fading away, but it had been the way things were forever. As victims began to come forward, usually the parents of a dead victim because the man had returned or the perpetrator had returned to the scene and finished the job, after law enforcement and after prosecution had said, family matter, we began to get aware. But we really became aware when police departments got sued and lost. And that didn't take too many lessons for government to say, you know what, we don't want to be liable. Swimming pools, another great example. Kids die in swimming pools. When I was growing up, you didn't have to have a fence around a pool. I mean, that's how we swam in our neighbor's pool all the time. Not all the time, just when they were out of town. So we saw increased regulation, right? People got in trouble, they got sued, there was increased regulation, there was more interest by government. In fact, government then had to fence their pools. Law enforcement had to make an arrest at the scene of domestic violence if any chance of violence remained. So through the law, starting with awareness, but morphing into court cases, into liability, into now, even though I didn't want to be involved and it was somebody else's problem, I'm involved. Homeowners insurance, you couldn't get insurance if you didn't have a fence around your pool. Guns can be handled the same way. Now, the fact that Congress has shielded the firearms industry from liability is, from my perspective, criminal. No one gets that kind of treatment. Why should firearms and ammunition manufacturers be different? But conceding that that is part of our divided state of the union, I think what we have to do is take what we can get right now. So we make people aware. We do prosecute, and it's a tragedy. You want to prosecute a father for leaving his gun in his closet and his 15-year-old son gets a hold of it and commits suicide? You know, I don't like those prosecutions. No one likes them. But they send a message. The message is gun, unsecured, bad, jail. And that seems to be what it takes to get bigger movement. So what I would say is don't we have to continue to think out of the box, be optimistic, continue to push for common sense gun laws like red flag laws. It's nuts that we don't have them. We will prevail. Common sense in government will prevail, but only if you're involved. only if you're involved. And by the way, you can't do it on your phone. That's what I tell my son every day. We've got to do things other than what we can do on the phone. Action things, solution things. This gets people motivated, united, and we can overcome.
Well, this is amazing. I'm going to say that looking at, in the interest of time, I'm already getting questions pouring in from the audience, so y'all are awesome. I'm going to field a couple of these questions here. How can medical school curriculums do a better job at preventing unintentional firearm injury? This is probably going to be down to Dr. Ugalde down at the end there.
Well, Sandy's sort of a leader in this. Yeah. I mean, I think that, so, I think med schools are sort of getting it, right? We need to talk more about diversity. We need to talk about more injury prevention. I mean, this starts sort of like, I always say it starts like in the home, right? So it starts in med school. That's sort of like the home for a physician. That's where you kind of are raised. That's preschool, sort of school, right? Elementary school. You need to have that in the curriculum. You need to have the time because, right, if we don't give something the time, the money, the emphasis, then it won't get done. So that's doing courses that are paid for, that we have a faculty who are actually protected for. They can't just do it as an extra thing, but they're actually having a 10% or whatever time allowance to do it. And you need to actually have it incorporated within the curriculum, just like a bioethics course, just like your anatomy course. So, I mean, this is really real. We can't always just be reactionary. I mean, I know that's sort of a different approach, but for medicine, we need to be very preventative. Prevention works. If we actually have the tools to talk to our families, to talk to our patients about how to prevent these things. And it really just takes a minute or two. Right now I'm doing something with drowning prevention where I will go, if the patient comes in for something else, I will actually give them a little packet for drowning prevention. It takes 1 to 2 minutes. I give them like 3 little main points and then they read the rest, but they've got a little bracelet, they've got a little card, and they know that now drowning kills children less than age 4. So we just need to talk about it and put it on the table, but make time and funding for it. I think that's the big deal here, because if we just say we're just sort of gonna talk about it a little bit during this, then it won't get done, and it won't get done well.
Mm-hmm. So, question from the audience is: recently, locally, there was a 3-year-old that shot their 4-year-old sibling. What can be done about these types of unintentional tragedies?
Put the gun in a safe place. We can't tell people not to own guns. We can't tell people not to use guns. None of us can. We live in a free country. But we can tell them to put it up. It was out and accessible. And the adults knew it. And so there you go. There we are at liability. We don't want to be reactive. That's our statutory position in the system. Through collaboration, I think you have both the carrot and the stick. And that seems to work toward change if we're united and on message, which is guns are bad. And guns aren't, what do we say? That's a bad message, but gun violence is bad. And it starts with access.
And I'll just add too that the report that came out last week, it was found that 47% of the unintentional injuries were done by playing with a gun. Was this 3-year-old playing with the gun? And they don't have the formative memory or brain to decipher that is harmful. So that's the other piece too, is that the accessibility.
If I could pipe in for a minute and just strengthen the message of safe gun storage, I think it was the council member was talking earlier about normalizing conversations between parents, caregivers, wherever your child may be going. I run a gun violence prevention organization, and most of the time parents say to me, "You're the only one who's ever asked." That's not great. Do you have? I don't say do you have a gun in the home? I say if you have a gun in the home, is it stored safely? Is it secured in a safe? Before my kids go places, they're getting a little older, it's getting harder, but I've always done it, and everybody should be doing it, and everyone should be getting the information on how to do it from all professionals, those of us in the room and everyone else. I will also say safe gun storage, from a policy perspective, has been a major part of our mission for many years. And you're not going to hear this anywhere else. I'm going to tell you a success that came out of the legislative session this year, because I know people feel like, gosh, we didn't get this and we didn't get that, we didn't get that. So I want you to know that we did get something. We worked to file a bill that would provide guidance for school districts to get information about safe gun storage from DPS and the Texas School Safety Center, and provide that information to their parents statewide. The bill had gun lobby opposition. It had support from doctors, parents, and others. The bill didn't make it out of committee. But we were able to successfully get that bill added as an amendment to another bill that did just pass, HB 3. Excuse me, it's a school safety bill. And so now it is in Texas law that school districts will be involved in providing safe gun storage information, very black and white basic information, this about safe gun storage and our child access prevention laws to all parents in the state of Texas. And we're going to be working this next year on how that gets implemented, making sure it does get implemented. But that is a major victory. So we can do this through education, we can do this through policy, and we can do this through collaboration.
That leads us very wonderfully into our final question for the panel, which is, what were your impressions of this most recent legislative session, and how did it go for firearm injury prevention? So I think that can go to either you or to DA Ogg as well.
Well, we were involved in the legislative session, and there just was not any real corrective action related to guns. There was a bill that would have increased a minimum sentence. It created a minimum sentence of 10 years for anybody who used a firearm in the commission of a violent crime. That failed. And I think in the face of more reasonable laws limiting the purchase of AK-47s to 21-year-olds instead of 18-year-olds, that's a grand failure. They can't buy cigarettes, they can't drink, but they can purchase a weapon of that nature. So, what we got, and it sits on the governor's desk waiting to be signed, I would ask for each and every one of you to contact the governor and express your support, was simply to try murder cases and capital murder cases first. Why does this matter in firearms cases? Because those cases are reflective of society's greatest concerns about our own safety. Murder, not unintentional deaths by firearms, intentional deaths by firearms. And yet we see these cases languish, and it damages the cases. Witnesses disappear, people pass away, evidence is lost or corrupted, and we need those cases to be tried first. It gets justice for everyone faster. If the accused is innocent, he gets there faster. If the victim's family wants justice in the court system, we get there faster. And it gets the person both out of jail or off the street, wherever they are awaiting trial, faster. So I think that our courts should reflect the priorities of our community. And when it comes to the most violent and intentional harm being inflicted on each other, we want our courts to reflect that priority in the way they set trials. So it's guidance for judges in a mandatory fashion. It says, don't try your shoplifting cases first, let's try murder first.
Mm-hmm. I will answer a couple questions in one. How I feel about how the legislative session went, and an earlier question I didn't get to comment on, which was about barriers. And one of the hardest things in this work, no matter where you're doing it or how you're doing it, when it comes to preventing gun violence and reducing gun deaths, is having the stamina to play the long game, because it is a long game. And I'm starting to look ahead to the second half of my life and thinking, gosh, I'm not going to see the things I had hoped to see on this issue. That's really hard, but to accept. But it does require small steps forward, oftentimes 2 steps back at the same time, and then figuring out how to regroup and keep going again. So I would characterize this legislative session as no different than that, and how others have been in that regard, which is that we suffered some major disappointments, not just personal disappointments, but really to the detriment of our public safety and really callous treatment of the survivors from Uvalde who came with pleading all session long with the most heartbreaking testimony I have ever heard, to pass legislation to raise the age, and even some of our smaller asks that we had, some of our more low-profile asks were not fulfilled. You really have to find a way to play the long game, and sometimes that means taking breaks, and a lot of times that means strong relationships and partnerships. So this is the time when we regroup and say, okay, we kind of take stock and go, what did we gain, and what is the work ahead? And we did gain things. Our coalition work was stronger than I have ever seen it. We did press together, we did rallies together. We shaped the narrative. We supported survivors. We lended credibility to the issue because there are so many people now voicing this, with us, gun owners. And so, we regroup and we come back next session even stronger with even more energy and more credibility and more people in our corner, and then keep looking to what we can do here in the interim to keep moving the needle on gun safety through coalitions and through community-based initiatives and education.
So I want to say thank you to our panelists. Thank you for the amazing conversation today. So, good afternoon, everyone. We're used to working lunches here in the medical community, so we're going to do a working lunch because we have such a packed agenda for you today. First of all, I do want to, again, highlight and recognize our sponsors with Memorial Hermann Hospital, UTMB Center for Violence Prevention, Baylor College of Medicine, and UT Health Houston, because without their sponsorship, this event would not be possible. So I do want to pause and recognize their sponsorship. I love looking out and seeing the sea of orange because today is Wear Orange Day for Gun Violence Prevention Day. But I also wanted to recognize that today Memorial Hermann Hospital is lighting up orange as well. And City Hall will be lighting up orange all weekend. So that's very incredible for us to be continuing to raise awareness on gun violence. So exciting work there. So for our afternoon, we are going to start off the conversation with an exciting speaker as well. Dr. Shauna White is the senior lead in school safety at West Ed and oversees the implementation of various safety projects for West Ed's Justice and Prevention Research Center. Dr. White brings a decade of experience leading research and technical assistance projects at local, state, and federal levels. Dr. White is currently the implementation lead on several grant-funded behavioral threat assessment initiatives, which involve developing resources and providing consultation to move schools beyond training into practical application and reviewing case data to assess equity and fairness in procedures and outcomes. Prior to West Ed, Dr. White served as the Associate Director of Research and Evaluation at the Texas School Safety Center, where she oversaw research related to behavioral threat assessment, school policing, and health and resilience in schools. She also led program evaluations of all center training and events, identifying key successes and opportunities for the improvement to better serve in-school communities. So without further ado, I'd like to welcome and I'm excited to have Dr. White present to us today.
Thank you for the introduction. Good afternoon, everyone. I am very grateful to be here today to speak to you all about behavioral threat assessment. When I was sort of preparing myself for this, I thought, how am I going to overlap the school-based behavioral threat assessment process within the context of all of these other topics? And it's been amazing to hear all of the, as many as overlapping themes that I've heard throughout the morning's discussions with what I'm about to share with you all today. So, yeah, it's kind of blown my mind. So, again, I'm excited to be here. I'm going to talk to you guys about school behavioral threat assessment, because it has become a more standard school violence prevention strategy over time. It is, in fact, legislatively mandated in several states, including Texas. And its intent is to identify and address concerning behaviors before they escalate into more serious behaviors, such as the use of firearms or other weapons in schools, to prevent violence within our school environments. So what we'll go over today is kind of a general sense of what behavioral threat assessment is, what it is not. BTA is the much quicker acronym that I'll use throughout the presentation for behavioral threat assessment. So we'll talk about a couple of widely used behavioral threat assessment models or sets of guidelines and the evidence that's behind those guidelines, the processes that are involved in BTA in schools, the legislation in Texas around BTA in schools, some of the key challenges that we've identified in our work back, when I was working for the Texas School Safety Center and working with districts across the state, and now with WestEd, I'm working with organizations across the United States and about 7 different states currently. And so through all of these experiences, some of the key challenges that we've identified in implementing behavioral threat assessment with fidelity in schools, and some of the ways that WestEd and my team at WestEd are trying to address some of those key challenges. So first of all, what is behavioral threat assessment? It's a fact-based, solutions-oriented violence prevention strategy. So it's an investigative process that's intended to gather factual evidence, problem solve, and develop solutions to support our students as we see these observable concerning behaviors starting to manifest. It's focused on identifying those behaviors early before they start to escalate into more concerning behaviors, and its intent is to uncover that underlying cause. What is causing this student or individual to display these types of concerning behaviors so that we can implement appropriate strategies based on what the behavior is, and develop case management plans that are aimed to adequately support our students, move them off of the pathway to violence. I will use that phrase, pathway to violence, a few times throughout the presentation, so I want to give you a sense of what I'm talking about when I say that, in case that's a new phrase to anyone in the room. So this is a series of escalating thoughts and behaviors that starts with ideation. So somebody is thinking about potentially committing an act of violence. And then that can escalate into planning. Okay, I thought about it. Now, how would I go about doing this if I'm so motivated to do that? How do I put this into action? So, actually starting to write out a plan, or draw out a map, or in some way creating real plans to commit this act of violence. That can then escalate into preparation. So we've thought about it, we've made some plans, now we're starting to secure the supplies, the resources, maybe those are weapons, but whatever types of supplies and resources the person would need to actually commit the act of violence, and then all the way up to implementation, which is actually committing the act of violence. So that's what I'm referring to when I say the pathway to violence. And we want to catch people early in that stage, so that we can step in, we can intervene appropriately and prevent them from getting to that implementation point. In some situations, disciplinary measures are going to be needed. It may be necessary for the safety of the school, depending on the severity of the threat that the school is handling. It may be the appropriate action. It may be also necessary based on the school's policies. But the ultimate goal of behavioral threat assessment is not to exclude students from the school setting. It's to identify these behaviors early enough so that we can keep them in the school setting and surround them with support so that they remain in that environment and receive the interventions that they need to address the types of behaviors that are being observed. Additionally, if there is a situation where some sort of alternative placement or suspension, expulsion is required during the period of time that the student is out of the school setting, behavioral threat assessment teams would want to be looking at, developing positive, supportive reentry plans so that they can ensure that when the student comes back from that period of time, they can successfully reintegrate them into the school environment and that the student has supports throughout that reintegration process. It's also important to point out a couple of things that behavioral threat assessment is not. Behavioral threat assessment is not profiling. It is not possible to create a profile of a potential attacker based on their individual characteristics or personality traits. Behavioral threat assessment is looking at observable, concerning behaviors, and that's what a threat assessment is initiated in response to, is those behaviors. It's also important to note that it's not intended to be predictive. Behavioral threat assessment is not predictive. It's focused on violence prevention by, again, identifying these behaviors in real time and then stepping in to try and do whatever we can to support the student and move them off the pathway to violence. In fact, many attackers do communicate their intentions prior to acting, whether that's through a verbal interaction, a conversation with someone, posting things on social media, text messages, whatever those communications look like. Oftentimes that does happen, which means that prevention is often possible if someone, if the communications are reported to the school BTA team or the school otherwise is, made aware or identifies these communications, they can step in to assist. So there are a number of different models that schools use to implement behavioral threat assessment. I'm going to talk about two that are widely used both across the U.S. As well as here in Texas. A lot of schools here in Texas do adhere to the National Threat Assessment Center guidelines, so that this is commonly referred to in the school safety field as the NTAC model or set of guidelines. The U.S. Secret Service developed the fundamental processes for behavioral threat assessment at a higher, more community level, and then later produced processes specific to implementing behavioral threat assessment within school settings. The other model that I'll talk a little bit about is the Comprehensive School Threat Assessment Guidelines, or the CSAG model. This was developed by Dr. Dewey Cornell and his team at the University of Virginia. It does in large part adhere to the guidelines put forth by NTAC, but what it also does is sets some additional parameters around some of the processes within the entire scope of behavioral threat assessment. It gives a little bit more concrete guidance on how to go about certain aspects of these processes. And I know I keep saying this BTA processes, and I promise I am going to walk you through what those are and what those look like here in a minute. But before I get to that, I do want to just give a little bit of background. There's way too much to cover in one presentation, but a little bit of the background and the research that has been done around these two different models to support them as evidence-based models. The NTAC research focuses heavily on behavioral indicators that demonstrate that an individual may be escalating on that pathway to violence toward committing an act of violence, whereas the CSTAG model the research has focused more on the outcomes. So if a school is implementing the CSTAG model of behavioral threat assessment in their school, what sorts of outcomes is that producing within the school environment? So the INTAC research, to start with, INTAC has a 25-year history of targeted violence research that demonstrates, how attackers demonstrate these observable behaviors leading up to an act of violence. So their most recent study, they looked at 173 attacks, and that was a total of, I believe, 180 attackers across the 173 attacks from 2016 through 2020. That was actually a report that was just published this year. And among those cases, what they found is that attackers displayed one or more of the following types of behaviors that I'm going to talk through here across all of these attacks. 75% of attacks, at least in part, were motivated by one of these top 3 motives for attacks. Some sort of a grievance that they had experienced, some sort of ideological bias-related or political belief system, and in some cases, psychotic symptoms. 93% of attackers experienced at least one significant life stressor within the 5 years preceding the attack. 76% displayed behavior that elicited concern in family members or others that were close to them. So again, this is behaviors that were noticeable. People close to them were observing and seeing something's going on with this person. It gives us an opportunity to step in and intervene. And then 46% of those cases, attackers exhibited a noticeable change in their behavior prior to committing the attack. Most of the attackers had a history of violence or aggression, and 64% of them had a prior criminal history. And most of them also did possess firearms, many of which were possessed illegally. Again, among these 173 cases that they analyzed, 73% of those attacks did involve firearms. 58% of attackers experienced mental health symptoms prior to, I did not advance that, prior to committing the attack. 29% were identified, either self-identified or identified by others as withdrawn, loners, antisocial. But going beyond that, they were engaging in observable, concerning, socially isolating behaviors. 28% of attackers in these cases did share final communications before their attacks, and several engaged what you would consider to be final acts, such as giving away personal belongings, canceling subscriptions, transferring ownership of a home, things that really kind of indicate the inevitable. A quarter of them subscribed to a belief system involving conspiracies or hateful ideology of some sort, and 21% displayed an unusual interest in violent topics. So again, this is not all of the behavioral indicators. These are just some that I selected that I felt were important to point out, that these are the types of things that have occurred on that escalation of the pathway to violence as someone is getting ready or preparing to commit an act of violence. And this 25-year, research history that INTAC has is the foundation for the INTAC guidelines that they've put forth. For the CSTAG model, as I mentioned, the research is focused more on outcomes. So Dr. Cornell and his team have conducted a number of research studies, experimental and quasi-experimental research studies, looking at the effectiveness of the CSTAG model on various outcomes. So among a variety of studies, and I have all of the resources for this information on a slide toward the end here, but these studies demonstrate that in schools that are implementing the CSTAG model of behavioral threat assessment with fidelity, they're seeing fewer bullying infractions. Students are more willing to seek help for bullying and for other types of threats of violence against them or against others. Schools are relying less on zero tolerance policies, so fewer short and long-term suspensions, decreased likelihood of some sort of alternative placement, and increased likelihood that the school is providing support services to the student, and this is not just a person who may be making a threat. It's, if there was an intended target of the threat, if there were witnesses that were impacted by observing something. So support services for anyone who may have been impacted by a violent or potentially violent incident. Students perceive their school climate more positively. Teachers feel safer within their schools. And then the long term, obviously the longer you're doing something, the better you get at it. So the longer that schools had been implementing the CSTAG model in their schools, they saw increased perceptions of fair discipline, decreased student aggressive behaviors, and reduced long-term suspensions. So this is really great evidence for exactly what the purpose of behavioral threat assessment is. We're seeing less violent incidents, less infractions. We're seeing less reliance on exclusionary discipline, more reliance on how do we provide supports to these students, and more perceptions of positive school climate and fairness and discipline across the board. So now the elusive processes that I keep talking about. So we'll walk through each of these and kind of what those look like. It is important to note, though, that these are the steps of behavioral threat assessment that you would conduct given that you receive information with the time to do it. If there is an imminent threat, if an incident is taking place or is likely to immediately take place, the behavioral threat assessment team does not sit down at a table and start going through this process. The school goes into immediate protective actions to contain and resolve the threat, and would follow that up with, an after-action review, looking at their response, how well did they do, what can they improve, that type of thing. But in, a scenario where we have achieved identifying concerning behaviors early enough to sit down and look at what's going on with the situation and with the student, these are the steps that we would take. So someone in the school community or external to the school community, a family member, a parent, something like that, would report information to the school, and that would be routed to the behavioral threat assessment team. Best practice around having available reporting mechanisms is that a district or a campus have multiple mechanisms or systems for students or anyone in the school community to report concerning behaviors, one of which ideally would be anonymous, like an anonymous tip line or a hotline. Because particularly when thinking about students, their in that age where they may have some fear or anxiety around reporting because they feel like they're tattling on someone. They may also fear retaliation for reporting concerning behavior. So having at least one anonymous mechanism available can serve to alleviate some of that fear and anxiety and make it more likely that they do report the information. So that then would be routed to the behavioral threat assessment team so they can begin their investigation and start to assess the situation. So some of the components of this, the idea is to collect as much factual information as possible. So that may be written information, maybe someone, in the case of a bomb threat or something, if a note was mailed in, there may be some disturbing material that was submitted as part of a homework assignment that they really feel like we need to have a conversation with the student around. There may be photographic evidence if something gets posted on social media, if there are text messages that someone takes a quick screen grab, So collecting that type of information, in addition to conducting a variety of interviews as appropriate depending on the scenario. But they would want to talk with the person of concern, the person who made the threat or is exhibiting these concerning behaviors, any witnesses who observed the behaviors. They would want to speak with teachers, coaches, friends, family members, anyone who is close to that individual that would be, potentially have valuable information to help them understand what is truly going on here. Because again, what they're trying to do is figure out what is the underlying cause of this type of concerning behavior so that we can appropriately address it. So they collect all of this information, synthesize all of this information, really try to gain a holistic picture of what's going on and put some context around the threat. And then the next step following doing that is to put a classification, sort of a severity rating of what type of a threat are we dealing with here. So there are different terminologies across the two different models that I mentioned, and so I'm not going to adhere to one model over another. I'm going to use more generic words, but it's essentially the basic classification system is you may have something that someone reports as a threat, and in investigating it, you can deem that there is actually no threat here. We don't need to be concerned about this situation. So an example may be if you have a couple of kids in a hallway. Let's say there's two high school boys in the hallway and they're talking and someone's walking by and hears one of the students say to the other, "Man, I'm gonna kill you." Something like that. That causes some fear, causes some concern, and that witness that walked by and heard it, they report it to someone in the school community. The behavioral threat assessment team speaks with the students, and it finds out that, okay, these two students are actually very close friends. This was a joke they were sharing in the hallway. There was absolutely no intent to harm on either side. So in that case, we can feel confident that there is no actual threat here. We would not go through the remainder of these steps. You would simply say it's resolved. We can close this case. Then you could also have something that would be a low-level threat, where someone does actually make a threat, but they don't pose a threat. And that's a key distinction to keep in mind is someone can make a statement, can make a threat and say something, but there's not really intent behind it that would lead you to believe that they truly pose a threat to the school community. So with that same sort of scenario, maybe the person, did actually say, "Man, I'm gonna kill you," with some passion behind it, right? And so in the investigative process, though, in speaking with that student, they were mad about something, they were upset, they were just blowing off steam, and you start to see that they're showing remorse. They regret having made the statement. They agree to apologize to the other student. And so there are behaviors here that are showing you there's no longer, or never was, true intent to harm the other person. It was just a statement that was made out of anger. However, that doesn't mean that they wouldn't benefit from some type of positive interventions and supports. So doing some conflict resolution, maybe even counseling, right, to make sure that whatever led the student to make that statement gets resolved. Then you could have a more moderate level threat. So in a moderate level threat, someone possibly does pose a threat and needs to have interventions put in place for sure. So let's say this student takes this scenario a little bit farther. Man, I'm gonna kill you. He's mad, he's upset, and then he goes to the next step and says, challenges the other student, all right, meet me back behind the gym after school, where they're gonna duke it out or whatever is gonna happen there. And so if, there's a true threat being posed here, and we need to take action and figure out how to address this before the end of the school day. And then you have a high-level threat, a serious threat. Someone poses a serious threat, they need immediate intervention. So running with this same scenario, okay, we've now got the challenge of they're gonna go out back behind the gym after school and get into some sort of a physical altercation, and then, a friend comes forward and says, I rode with this guy to school this morning. I know he had a gun in his car, or he had a knife in his car. And at that point, now we have a really potentially dangerous situation on our hands that we need to step in and address immediately. So those are generic kind of labels for how you would classify a threat, but you're looking at what's the severity, what's the likelihood, the time frame, all of those different pieces. And then based on all of that information, how do we put appropriate interventions in place? And it depends on the situation, and it depends on that threat classification, but there are a wide variety of interventions that you could put in place to support a student depending on what's going on with them. So in a lot of cases, it may just be that a student doesn't really feel like they belong. They don't feel like they're truly a part of the school environment. And so you can try to identify at least one adult that they have somewhat of a relationship with and say, hey, can you try and check in with this student when they get to school every morning? Just as quick greeting, hey, how are you doing? Have a nice day type of deal. And then can you try and also check out with them when they leave school at the end of each day. Again, just a quick, how was your day? Great, excellent, have a good night, we'll see you tomorrow. So that they start to feel like they do matter within that school environment and that they do belong there. You could do a little bit more intense version of that where you actually have scheduled adult mentoring types of sessions. You may even just be able to increase their opportunities to engage in school programs or school activities. Because really that feeling of connectedness and feeling of belonging within the school environment, that's part of your school climate, and that feeling like you matter within that environment is going to decrease the likelihood of someone initiating an act of violence. Other types of, as we sort of progress, you may need to have, counseling services, mental health or behavioral health services in place for a student. Some situations may even require a change in routine. Maybe there's a pretty severe case where we need to change the bus route that someone is on. We need to change their schedule, the classrooms that they're in throughout the day. Maybe it's even a situation where we need to have a student transferred from one campus to a different campus within the district. Some type of alteration to address that situation and retain the safety within the school environment, all the way up to, in an extreme situation, there may be hospitalization may be needed, detainment, some type of really intensive supervision may be required. So again, it runs the gamut. And you can be really creative in how you go about providing these interventions, but we need to make sure that they're appropriate and they're actually addressing the behavior, the underlying cause of the behaviors. And then, as with anything, you can't just determine the interventions and just set it and forget it, right? You've got to then monitor what's going on. Now we've led all the way up to this point. We need to set scheduled dates for when the team is going to come back together and review these cases, and that will be dependent again on the severity of the threat. It may need to be weekly, it may need to be bi-weekly, it's going to vary, but have those predefined meetings scheduled out, and you're looking to see, are the interventions that we put in place truly helping the student progress and move off of that pathway to violence. Maybe you find that some of your interventions aren't having the effect that you wanted, or not enough of the effect, or they're just not doing anything at all, right? Well, this is the time, this is why we're meeting. Let's get rid of that and find something different. Or maybe there are good things that are happening with your interventions, but you identify another area where you can support the student even further. So you add to their supports in these review meetings. So just monitoring that over time and adjusting as needed is critical. And then at some point you do want to be able to close the case, but you want to feel confident that you have resolved the situation, that the student has moved off that pathway to violence before you close it. And I know that causes some apprehension in our school behavioral threat assessment teams. It's tricky to say, yes, we feel now we've done everything we can. The student, seems to be in a good place, and we're going to close the case. But if the student truly has progressed, you don't just want a case lingering out there open. You do want to be able to close it out. So maybe within your team, you say, for this particular scenario, we're going to meet X number of times, and we want to see 3 positive, reviews that indicates the student has moved off the pathway to violence before we feel confident and we say, okay, let's close the case. If new information becomes available down the road, if a different incident takes place down the road, then you would open a new case and you would go through another threat assessment through all of these steps. But you wouldn't want to just leave a case out there open on a student if it's no longer needed. So there's quite a bit of legislation around implementing behavioral threat assessment in Texas schools. I am not going to talk about all of it today, but I've pulled out what I think are some of the key components of that legislation just to go over briefly with you guys. So in 2019, Senate Bill 11 was passed, and that was when that was where a lot of this legislation came from. So currently, legislation does require that each district in Texas establish a multidisciplinary behavioral threat assessment team. In Texas, this is housed under the Safe and Supportive School program, and to the greatest extent practicable with expertise in these various areas listed here. So the multidisciplinary aspect of the BTA team is really important to ensure that you are identifying accurately what the underlying cause of any type of concerning behavior is, and then based on that you are putting the appropriate interventions in place. So, for instance, a mental health expert may be able to recognize signs of a mental illness or of substance use that other team members might miss. A special education expert might be able to identify unmet needs within a student that other team members might miss based on their training. So it's really important that you have all of these perspectives at the table so that you don't misunderstand the behavior and then address it inappropriately. Legislation also requires district to adopt policies and procedures that are consistent with those developed by the Texas School Safety Center, requires them to complete evidence-based BTA training, which is offered for free through the Texas School Safety Center as well as regional education services, service centers. And then you've got to actually do the threat assessments. It does state you have to conduct the threat assessments. And then teams were required to report, and I believe this is still on an annual basis, certain information on their BTA team's activities to the Texas Education Agency. And this last point here is actually, and it was brought up in an earlier conversation, this is new. The last I checked, that this was sitting on the governor's desk. But House Bill 3 of this current legislative session, each district campus must establish a clear procedure for a student to report concerning behaviors so that it can be assessed by a BTA team or other appropriate personnel. So as I mentioned earlier around best practices for having that reporting mechanism, this is a really important piece of legislation that schools have these mechanisms in place. And going beyond that, it's obviously also really important that they communicate that to their students, to their staff, to their families, to their entire school community. You don't want to just have it out there, but nobody knows how to access it. The last piece of legislation, and I really just want to point this out because I want to give you guys an idea. I've been using the word concerning behavior in legislation. It's written out as harmful, threatening, or violent behavior. And this is just examples that are listed. These are specifically pulled from Texas legislation. This is not meant to be an exhaustive list, but it gives you a sense of what they're talking about. When in doubt, if you experience something that causes fear in you, then err on the side of caution and report the behavior and let the people trained in behavioral threat assessment make that determination for you. As I mentioned, through our work with school districts, there are some challenges with doing this in schools. I went through that at a high level and maybe seems oversimplified. In reality, this is a really complex set of processes. And it takes a lot of coordination to get that multidisciplinary team together. It takes a lot of time and effort to get your policies and your procedures together, to get everyone fully trained. And then beyond that, I'm sure every single one of us has gone to a training, maybe even a full day training, and you sit there and think, man, that was a great training. And then you get back home and you're like, okay, how do I do it? And so how do we, it's such a complex set of processes that it's very difficult in some situations to implement this without that dedicated technical assistance, coaching, consultation. It can be difficult to obtain buy-in and alignment among all of the key stakeholders because, again, we're talking about, there are over 1,000 districts in Texas, over 9,000 campuses in Texas, and the majority of those are rural. They may not have the key personnel required for that multidisciplinary team, and they may need to work with outside organizations, and that can provide its own challenges. Lack of a systematic process for documenting cases and analyzing data for trends over time. This is a really big challenge for districts. I've talked with districts that their process is taking notes on a piece of paper that later they can't find, or using an Excel spreadsheet to document all of their activities. So it can be really difficult to create an in-house documentation system that is effective and that also allows you to efficiently pull your data to be able to review it and analyze it over time to look for trends. Things like maybe there's a particular campus within a district where there are a lot of serious threats. We need to find out what's going on in that location so we can address it. Maybe there's a particular I'm almost out of time. Maybe there's a particular subset of the population that is undergoing a lot of threat assessments, and we either need to find out what's going on with these students, or is there some inadvertent bias in our processes, and we need to do some additional training around that component. As I mentioned, training is extremely time consuming, and so it's difficult to provide that continually. It's also intended at that advanced level to be a team training, so getting all of those people together in a room at the same time it can be difficult. It's difficult to hire and retain the staff required for that multidisciplinary team, and difficult to establish or maintain partnerships with our community-based organizations to get that intervention assistance that a lot of schools struggle with. So again, with a lot of our districts being rural, they may not have someone nearby readily available to work with them in that manner. And even in urban areas where these organizations are available, as much as they want to help, they may be at max capacity with their own caseload and may not be able to provide the adequate support that the school would need to be able to effectively implement BTA. So those are the challenges that we've identified. Our team at WestEd is aware of them. We are working to address some of those. So we're working with 8 organizations across the U.S., state agencies that serve schools, regional entities, as well as local school districts through BJA Stop School Violence grants. We do have a technology solutions partner that provides e-learning as well as for a basic BTA training, as well as a live virtual synchronous training, so the teams can stay within their building or their campus. And also provides electronic case management software so they can actually do that data analysis and review. So that's free through the life of the grant, but as others have mentioned, funding down the road once the grant is over, whether they can be able to sustain that is a different question. And WestEd's role in these projects is then really providing that dedicated technical assistance. So we are there with them from, it's a 3-year grant cycle. We're there with them from the start of the project through the end, and we do an initial overview of what their school safety initiatives are, try to identify areas where they can improve, where we can assist them in improving through resource development. So we're doing, resource development, things like model policy, procedural manuals, interview best practice guidance on when you might need a mental health evaluation or law enforcement involvement, self-assessment types of tools. We are also working with them on that case data evaluation piece. We are doing that piece for them throughout the grant, and then we'll be providing them assistance on how they can do that for themselves in terms of sustainability following the grant. These are all available, and I'm assuming this will be made available. So if you want to read up and learn more about behavioral threat assessment, all of these resources the research that I talked about on slides 6 through 8 are here. And if you have any questions or follow up for me, my contact information is also available. Should I just move over there? Sit down. Okay. Oops, I messed up the...
Oh, they'll take care of that. All right, thank you so much. I'm going to ask that our panelists for this next panel come on up, and we're going to move right into our panel discussion on school violence. As our panelists are coming up, I'm going to remind us of where we live in the greater Houston area. HISD is the largest school district in Texas and is the 8th largest school district in the United States. Up. Just keep moving. Thank you for being here. We have a total of 274 schools in the district with over 187,000 students. We are one of the most diverse cities in America, as we know, and we serve students in the district that speak over 100 different languages. And additionally, in our district, 79% of our students come from an economically disadvantaged background. Just over a year ago, we saw the 1-year anniversary of the Uvalde shooting, which was one of the top 10 deadliest mass shootings in U.S. history, with 21 killed and 17 injured. But also, I don't want us to forget about a local school shooting that we had 5 years ago was Santa Fe, where we had 10 lives lost and 13 wounded as well. So this is a reason why we wanted to bring school violence to the forefront of this symposium as well. And we have brought in an amazing panel with us today. I am not going to reintroduce Dr. White because we all already know her. So, but I'd like to introduce, as we go here, we have with us Mr. Kenneth Brantley. He is the principal of Wisdom High School here in HISD and has served in the greater Houston area as an educator for the last 15 years. His education career began in Aldine ISD as a teacher, coach, an assistant principal, and a mentor for 8 years before joining the Team HISD in 2015. He has served in the Houston ISD community for the last 7 years in various roles, including principal, program manager, and the school's office director. We also have Dr. Jamie Freeney, who is the director of the Center of the School Behavioral Health and Mental Health America of Greater Houston, and having served with Mental Health America of Greater Houston since 2019. She is a doctor of public health from the University of Texas Health Science Center at Houston School of Public Health. She is an expert in child mental health and public health education and has been a strong advocate for children. She has expertise in population health and equity and has conducted research around adverse childhood experiences and convened efforts around trauma-informed care. And Dr. Giovanni Ponce is an assistant superintendent of high schools for Houston ISD. He earned his doctoral degree from Texas A&M in public school administration and has a broad range of experience ranging from mechanical engineering to being a classroom teacher to assistant principal and principal. He has had numerous awards, including Bilingual Teacher of the Year and HISD Secondary Principal of the Year. Dr. Ponce is an immigrant from Honduras and instills a collaborative leadership to ensure students from all social, economic, and ethnic backgrounds have equal access to high-quality learning opportunities. Please welcome our esteemed panel for today. I'm going to join y'all at the table here so I don't have to be up there. So talking about this topic is a tough one, right? But I think one of the things I wanted to start off with is when we look at some data from the CDC and the Youth Behavioral Risk Survey, what we know about is nationally 9% of children will miss at least one day of school because they feel unsafe. And 44% of parents that have children from K through 12 will fear for their child's safety while at school. And I was sharing with these lovely gentlemen a little bit earlier that on the 1-year anniversary of the Uvalde shooting, I was at my own son's, my 4th grade son's 1-year, his award ceremony. And I remember sitting there thinking it's the 1-year anniversary, and my husband was like, we can't let him stay the whole day at school because it's an award ceremony and it's the Uvalde anniversary and he can't stay. It's not safe. How do we overcome this? And how do we work with our communities to reestablish this sense of safety for our schools? I'm going to open this up to the panel.
This is a question that it is actually overwhelming because now with the social media, some people, and like you were saying, some children, they just want to be mischievous or gain popularity, and in reality is damaging the community. Those days I receive probably my whole day, it should be involved instructionally, making sure that the students receive quality education, visiting schools, give them feedback for instruction. But probably lately, the last year, I have spent 60% of my day dealing with threat. What are we gonna do? A child did it. What are we gonna do? Running to some schools, and hopefully he will have the opportunity to talk about it. We received some phone calls about an intruder, an active shooter around, but in his school was a real one when the guy was inside. So we had to spend all that time, and the thing is, how are we going to gain trust from the community? How are we going to actually work with the students so they will be able to learn. We have been having social emotional learning teams that we deploy them almost every single day to the different schools, especially when we have been having a lot of media action. And so that's how we have been talking, because we cannot say, oh, it's a lie, or don't worry about it. We cannot. Every single thing that we hear, we have to take it seriously. And exactly what Dr. White was saying, we have to assess, analyze, have an investigation, and in some cases, not to totality we dismiss them, but there are some that are low, high, and middle level. So we can assess that. So we have been utilizing social emotional learning. We have counselors, we have been training teachers, but most important part, we have been talking with the teachers to build relationship with the students. That relationship will build trust and a sense of safety, security. There will be something that we are planning to do a little bit more in professional development, is building that relationship. It is really hard. When students really trust teachers, they go. And next day, we don't have that much students missing schools. When we have an announcement to say, we had to send an out call to the community that we receive a threat, I guarantee that day, probably the attendance will be at 80% and sometimes 50%. So it's not only damaging psychologically, but also academically. So that's why it's very important that we put systems in place, and we have a social emotional learning teams that come and talk with the principals, talk with the teachers, with the students, and we are trying to build that relationship.
Yeah, I agree 100%, and would also add that we often talk about school safety like it's one thing, when school safety really is this huge variety of things that schools are making their best effort to address. We're talking about physical safety and security, school culture and climate, which is tied, in closely with behavioral threat assessment, even though the name may not make you think that. We're talking about trying to meet a number of legislative and policy mandates. So in Texas, again, another huge chunk of that legislation that came out of Senate Bill 11 in 2019 had to do with emergency operations plans. And these are intended to be all hazards plans. So they're not just addressing active attacks. They do address active attacks, but they also have to have plans for severe weather, plans for a train derailment if you have railroad tracks nearby. What your response is going to be if there's a dangerous situation happening external to the school building, but in the vicinity that could potentially impact the school. What is your response to that situation? And schools have put so much effort into getting these plans in place and building so many different programs and initiatives. You can't communicate the entirety of your plans out to your school communities, right? Like giving out your entire emergency operations plan to your parents and communities would completely undermine the purpose of having the plans. It would make the school more vulnerable to attacks. But you can communicate to your families and your communities that you have a plan and that it does address all of these different types of scenarios and all of the drilling and all of the exercising that schools are doing and all of the programs, PBIS, SEL, MTSS, you name it. The schools are doing so much. Communicating that out to the families could help to restore some of that sense of safety and trust.
And so addressing school violence is something that's not new because we have been addressing this for a while. But we've been also putting a lot of burden on the schools to be coming up with all these additional plans, and a lot of this is putting the burden on the teachers. And so my question is, especially to Mr. Brantley, how are our teachers doing? How are they dealing with all of this?
So the reality is it's very difficult. Our teachers are asked to not only be the instructional leaders of their classroom, they're also asked to be counselors. They're asked to be security. They're asked to be a number of roles that many of them did not get into this profession to do, and that's a reality. And as far as how as teachers are doing it's a real situation and conversation that we have to have about even the mental health state of teachers right now. And I know it's an uncomfortable topic, but we really need to have a conversation, have outlets, social-emotional outlets. And that's been a conversation on my campus specifically, is how can we provide safe spaces for teachers to talk without the fear or burden of any sort of pressure that there's going to be any sort of retaliation in any way, but a real conversation about how they're doing. This question is not asked enough. How teachers are doing, because we are in such a high stakes environment in public ed, and there's so much focus on that, but we rarely check in on those that are the closest to our children and ask them how they're doing, because many of them are struggling. And I'm telling you because I see it every day. I have conversations with teachers every day that are struggling to meet their basic needs. And I'm not talking their physical needs, I'm talking about their psychological, socio-emotional needs. So teachers are not doing okay. No matter what they say, they're very resilient and they're pushing through because they keep their eyes on their children, just like if it were their own. But the reality is that many teachers are masking how they really feel because they focus so much and give so much to our children. So many of them need this conversation, and they need what we're doing right here. We need it more on a global scale because it's necessary.
And I'd like to add, the Center for School Behavioral Health started initiating annual needs assessments in schools for this matter. It was in response to COVID, and we wanted to understand what was happening in real time with the students and with the teachers in schools. And 2 years in a row, we have received data that provides evidence to what exactly everyone on this panel has said. We asked the districts, and this was from districts across the greater Houston area and a little bit beyond, and we asked them, what are they seeing among their student body? And they named depression, fatigue, absenteeism, increased aggression, sleeping or changes in sleeping, not being able to sleep well, and then so being sleepy during the day and just really tired and irritable. Also grief and experiences with trauma. And so we also asked them, what are you observing among your teachers, your staff, your school personnel? The exact same list: absenteeism, fatigue, aggression, anxiety, grief. So there are many, many opportunities, I think, that we have to take advantage of moving forward, especially with social emotional learning, and providing teachers and educators and counselors the space to do some self-reflection, to reflect on their own history and what drives their responses to children, what may trigger them in certain situations, because they are the ones that set the tone in that classroom and on that campus. So if we are seeing these things happen among our teachers and our students, but we're expecting teachers to set their feelings aside or set their issues aside and to support the students, then I think we're not really doing due justice to what we need to do as far as solving the problem. And there are districts, one district in particular, that recently piloted a social emotional learning program, and 80% of the time that they spent teaching was for the teachers. 20% was for the students. And so they're looking at outcomes and starting to see that teachers are very responsive to these types of programs, and counselors are very responsive. And really, they want that attention, they want that acknowledgement that, hey, you know, we're hanging on by a thread. COVID didn't just pass up teachers and go to students. It hit everyone. Natural disasters hit everyone. And we can go on and talk about other societal contributions to mental illness, but and to emotional distress, but we have to do something to better support our teachers, to keep them in education. Also better support the counselors and those providing those supplemental services that are on campus and also supporting those students.
I just would like to add that, yes, and amen to that. Has been really a big task for us to keep our teachers, but also school administrators. I have 45 comprehensive and specialty high schools in Houston ISD, and approximately 57,000 children. It has been a task the last 2 years. And something that I'm trying to, and I don't know if you see that behavior, and I'm going to name it and say it. Wisdom is one of the Lee High School, for those that used to be Lee High School. Our principals also, we need to support them. They tend to, and I have seen it, a behavior is they are very with a cell phone or very on guard, and like expecting that something's going to happen in the campus. And this is something that really we are trying to eliminate. That when we go to meetings, and I have a principals meetings, you see every single principal, they are just there physically, but the mind, mentally, they are in the campuses. And so this is something also that we need to work on, and it's for all of us, I believe, the whole community, especially those that have been doing studies and everything, how we can keep supporting that.
Yeah, I'll just briefly add, just to support everything that's been said on this panel. When I was still at the Texas School Safety Center, we did focus groups with all sorts of personnel in school districts, K-12 school districts, across the entire state of Texas, and it backs up exactly what you all are saying that you've observed. Teachers are trying to wear so many hats, and many of which they are not trained to wear. As well as administrators, you know, they're not emergency managers, they're not mental health experts, and so there's a lot placed on their shoulders, and there's, you know, we did these focus groups also during the pandemic, and so there was a lot of feeling of, I'm putting myself in danger for these children, you know, and I know it and I'm doing it, but it doesn't make it easy, you know. My 7-year-old daughter just completed 2nd grade, and between kindergarten and 2nd grade has gone through 7 different teachers. That's pretty extreme, you know, and that's hard on the kids too, you know, because they need those relationships. So, yeah, just to echo what everyone's saying.
Absolutely. I think some of the struggles that we have is it's how do you access, we know the kids are struggling, and it's how do you access kids, because when we try to see them in healthcare and we know, oh, they need therapy, where do you get them the therapy? Because when you are dealing, especially with school districts like HISD that have, you know, when you're dealing with social, you know, stressors and economic stressors for families, it's the old adage of why do people rob banks? Because that's where the money is. So why do you put services in schools? Because that's where the kids are.
Yeah.
But then you start looking at where are the resources and what do you need for schools. And certainly in after Uvalde, you know, Governor Abbott had dedicated $100 million in his response to say we're going to put some services and funding to schools. Where do you guys think that the priority should be for some of that funding? Because there's money that's there. Obviously, we think that there should be a lot more funding because these are our children, and that's going to be divvied up across the entire state. So it's to determine, you know, where that money goes. But where should we prioritize the funding for resources for children and for teachers in order to meet the needs that are here?
Well, specifically for students, for those of you that are not aware, Wisdom High School sits in the Gulfton-Sharpston area, southwest side. And if you know anything about our community, we see lots of refugee immigrant populations that are coming in from around the world seeking asylum. here in our communities. And I'll tell you, the resources must be really directed towards trauma-informed practices and supports for students and for staff. The more mental health supports in place, the better. I have, this past year, I invested out of my general budget a social-emotional counselor. Every school needs a social and emotional counselor that's not connected to academics, but literally the role and the focus is for social-emotional support. So I think in even education, we have contractors that we work with as well on campus to provide mental health support in focus groups, bringing in different mentors. So I think if we can connect to agencies that provide mentorship, direct mentorship services and supports for students, that would be great. Any type of support for staff, just appreciation. Like those that can come in, like we have local faith-based organizations, they just come in and just bring donuts just to say, hey, teachers, thank you for what you're doing. That goes a long way for fueling a tank for a teacher that's putting their all in, just for someone outside of the school entity and building to say thank you. So mentorships, mental health services, trauma-informed practices, professional development for staff, teachers, support staff, that would be most helpful regarding resource allocations.
Go ahead.
I 100% agree. I think the discussion around the school safety, and we start talking about hardening versus softening surfaces, I certainly think that the softening services, which speak to more of your social emotional learning and your mental health resources, should be prioritized. It's in the building of those relationships. It's when children feel like they belong, when they feel like there's someone that cares about them, that they're less likely to act out. They're less likely to have extreme emotional distress. And so when we actually talk about prevention, we have to think back further upstream and think about what are the contributing factors and what are these protective factors or these assets that we can pull upon, and relationships with teachers is certainly one of them. Also making sure that principals do not have to choose between hiring a teacher and hiring a mental health professional. They're two different roles that serve two different things and students in two different ways, but we know that mentally well students graduate and become productive citizens. So while we are working to educate them, we should allow the school to prioritize that learning, but we also should make sure that in order to supplement the school and to supplement those students, we're allowing schools to have resources and money to have LSSPs or psychiatrists sometimes, even at certain levels, because we have a lot of different students, immigrant population. We have a lot of different students who experience a lot of grief and a lot of loss, and we're seeing, you know, a lot of that be some of the driving factors for behaviors in schools. And so we know that, you know, death is something that's inevitable, but with COVID-19 and some of the other things, gun violence and some of these other things that have been happening, especially suicide, our young people are being exposed to death at more frequently. And so teaching them, giving them tools how to deal with that and how to cope with that, and then also helping teachers understand what that looks like so that they're no longer criminalizing students for their behavior, but they can send them and get that emotional support or to get that focus group. And we really don't have to provide the most expensive psychiatric care to every student because it's not necessary. But some of the community health workers, the navigation, the social workers, that's where you're going to find a lot of impact in helping to build the mental wellness of a campus, of the student, and the educators there.
Thank you. You said everything that I wanted to say. We need some people, but I said by yesterday, it's late, a psychology, a social worker, and a counselor, totally dedicated to the mental health. Something that I have been trying to work, and hopefully it's gonna pass, is salaries. For example, we have a lot of openings for psychologists but if you go to the school setting, you will make probably less more than going to a private sector. And so that's immediately, we won't recruit those ones only if they want. Social workers, if they go to the private sector, probably they will go a little bit above 60,000. But if they go to public education, it's 42. So that is something also that not only to probably not pay totally from the resources, but subsidize and pay the difference. So it could be a competitive salary for all of them, so we can recruit them and come to the schools.
It's almost like you're reading the minds of our audience, because I'm starting to get great questions in from the audience. So certainly, as you guys have questions, fill out your cards and they'll get shuffled up to me. But I think one of the questions that we had was, how can we change the paradigm and increase funding for education so that teachers can get paid what they deserve and make teaching more attractive? So I think that looking at how we can shift moving things forward within the legislature even.
Correct. So I can jump into that immediately. All of us here, we can email, call, talk, do social media and everything, legislators, because they are the ones who actually set what the schools will be receiving. It's not that much. We do receive schools of funds. We have 3 different ones. This is state, local, and federal funds that we receive, and grant, of course. That probably will go into local. So, but the biggest part, the 80% probably is coming from the state. So we will have to go and email our representatives. I saw that at the end of this panel will be another panel, and that will be the policymakers. They're gonna be here. So put those questions there. How can they support education? And the only way is not by talking and going during the campaign. Is actually when they have the power to make these changes. Our students need their support, and the only way, resources. We can support and everything, but we need them. And the only way that they can support is by changing how the schools are funded.
Absolutely, and when legislation, especially extremely large bills like SB 11 from 2019 are passed, what's the fiscal note associated with that legislation?
Yep.
So speaking of things like SB 11 and behavioral threat assessments, a question that came through was, how do you implement, and this can be answered to anyone, implement a behavioral threat assessment to a student who may be very reactive and not necessarily respond well to the intervention? What are the steps involved with that? So, anyone who has maybe experienced with that or dealt with a student that doesn't necessarily respond to those interventions as well.
Well, I'll go ahead and respond there first. So we see this quite frequently on our campus where for various reasons something is reported and we have to move into our protocols for our threat assessments. And so when we have a student that is not responsive to the questioning or not willing to sit down and talk with mental health supports or those that are going through the investigation, typically we will make a reach out to the parent and let them know that, hey, we're going through a protocol, we need cooperation from your student, and we'll give the parent an opportunity to have a conversation. But never can we compromise. If we're not able to complete the investigation, we can't compromise with that particular student. And so that's set up front. And so it's really important that we also, and it gets back to having a champion or an advocate on campus to support. I can't stress the relationship piece enough, because many times when we're dealing with students like that, typically there's somebody on the campus, a teacher, a support staff member, or sometimes even a peer mediator that might know that student and can have a conversation without getting into any confidential information before it gets to a point where they're not responding. So typically we try to use other outlets, but we make it clear up front. My SEL counselor makes it clear up front that we have to complete the investigation. And so we don't see too many incidents where a student is just totally unresponsive, because they know what the impact of not, following through is.
I think we've mentioned several times up here about the importance of addressing mental health and addressing the priorities of things like social emotional learning. And there have been several questions that have been, I have like the stack of questions here about addressing mental health and mental health professionals being a priority for schools. But one of the concerns that have been brought up are that mental health professionals are limited in supply. There's just not a whole lot of Dr. Freeney's out there. How do we make this a priority to increase the numbers that are even available to have in schools as well? And how do we prioritize this for schools so that they can be more available?
I think we just need to look at the data. The data is very clear. The quantitative data is telling us, when we look at the number of incidents that we're seeing more behaviors in our schools that are showing us that students don't know how to self-regulate. They don't have the skill sets needed in order to help manage a lot of the stressors and pressures that they face within a school environment. Couple that with students, particularly at my campus, who are coming from various cultures where the rules of engagement are completely different. I might be a student from Afghanistan, and I have a completely different approach to how I would resolve a conflict as opposed to another student from a different nation, let's say Ethiopia, that has a completely different way of managing that. So there's a lot of cultural awareness and proficiency that's needed in this fight as well. But I think the data, at least I can only speak for HISD and Wisdom, will tell us that it has to, we have to use the actual numbers to show that we do need more mental health service providers in school. And failure to do so will continue us on the trend data-wise when it comes to behavioral incidents, level 2, level 3, things that are causing more suspensions, expulsions, things like that, which is not what any of us want, because we want our students in school. But we've got to have the necessary frameworks in place to support them.
Yeah, I will add with that. We do have a system where we track all the infractions I receive from all the schools, the kind of infractions, schools and everything, and students. And I can tell you something that COVID-19 did was not only the academic gap, the learning loss, but the students, we had to kind of retrain them to socialize and take decision, dispute resolution. We do have all that data by school, by ethnicities, and so we have a trend and everything, and we can probably pour more resources to those schools. And I was just thinking as I was listening to Dr. White, and I actually asked her, hey, I really want you to come and talk to our principals to hear from her. But I believe that also we need some more resources and institutions like hers, because sometimes we are not the experts trying to find some solutions. We actually are the one who put the resources, but when I say resources, the problem. So we need other institutions, medical fields, to help us to solve these problems.
I also think the mental health shortage that we've experienced, that Texas has experienced for quite some time now, contributes to the lack of mental health professionals that are available to students when needed. So I think starting with recruitment and allowing more students to be exposed to this field and to school mental health will help, as well as providing pathways for tuition reimbursement or programs that allow students that go into education or into mental health to have some sort of loan forgiveness for their tuition and education. And then also making sure that we are looking at equity and recruiting those individuals that are going to mirror the students in the community that they're working with, so that there's some sort of relatability, some sort of belongingness. So making sure that we are also looking at the population demographics of where we're heading in the next 10 years and recruiting accordingly, so that we have that trust that can also be built or established as we're training the next generation of mental health providers and social workers. And I also think too is just making sure that we look at the assets of communities and understand that a person's mental wellness can be supported not only through a counselor or a psychiatrist, but there are many other assets and many other community organizations that schools can partner with, so that children have that access to outlets, to safe places to play, that they have access to socialize and to be around other positive adults and that mentorship, so that we are not only placing the responsibility of responding to this mental health issue on the school, but like Dr. Ponce said, we are looking at what the community, or maybe Dr. White said, we are looking at the community, we're looking at faith-based institutions, we're looking at community organizations and seeing how can they contribute to at least provide a continuum of care from once that student goes out of school into that out of school time. That organization, that YMCA, your Boys and Girls Clubs, those types of organizations that also support those students. So I think looking at, from a public health standpoint, we can pull on some other resources to support that as well.
If I can, I want to underscore that point Dr. Freeney made about community partnerships and strengthening those within neighborhoods, because there's a lot of resources out there, and just creating more avenues to connect our communities. That's something that I have, seen at my campus, see lots of success. We have multiple social service organizations that are coming into the campus to provide services. And these are things, and these organizations are grant funded. They're of no cost to the school. So I think just even more leveraging those opportunities, I think, is another way that we can supplement. So I just wanted to underscore that point.
Awesome. I think we're going to have one more final question. We have time for one more final question. This question is around House Bill 3, and I don't know if y'all are familiar with House Bill 3 for the audience, but it is a bill that was passed requiring a provision of an armed presence at all public and charter schools in Texas. So looking at this concept of how do we feel safer within our schools, the idea of having a firearm making you feel safer, or is it the idea of, does this school now feel safer because we have this presence within our communities? Or is this something that's going to add an additional level of stress to our teachers and to our students? And so wanted to have you guys reflect on your thoughts on this. The difference really here is hardening versus the softening of schools, and which philosophy, or is there a combination of philosophies that we should be thinking about and considering given the perspectives that we've heard today?
My perspective on school safety is that it should be a comprehensive approach, is that you don't want to turn your school into a prison. That's not by any means what I am trying to get at here, but certainly when I go to bed at night, I lock my doors. So physical campus safety and security, having locked doors, access control, vestibules, things like that, in terms of physical safety and security are important. Working from the inside out, building those relationships, developing that positive school climate, implementing programs like social emotional learning and positive behavioral interventions and supports, things like that. I mean, your school climate, if students feel like they belong, if it's an environment that is welcoming to them, that they actually want to be in, the safer your school is going to be all around. And I'd have to look specifically at that piece of legislation to see what the exact parameters are, but schools have been working and partnering with law enforcement officers for a long time. And it looks different ways. There are different structures that they do this. There, are some districts, and I believe Houston ISD has its own police department.
Correct.
So there are ISD police departments that are, employed by the school. There are school resource officers that are contracted from a local police department or county sheriff's office that come in and spend their days in the school, and they work to build relationships with the students. And, in situations like, emergencies, there are, ideally, MOUs in place with external law enforcement agencies to come to assist in the case of an emergency. So the structure of how law enforcement has been operating and partnering with schools looks different, but this is not new. But what you're saying and what I have not read, I'm not sure what the qualifications of this person holding this firearm and walking around the campus are. If it's law enforcement or former law enforcement, someone who is trained to do this, to play this role, to fill this role effectively, then that's one thing. But I would need to understand more of what the parameters are around who is this individual that is an armed person on my students, my kids. I have 2 kids. Who is this person, and what's their training and their qualifications?
For us, actually, for me, that has been a really nightmare, because it's a lot of things that we have to do to make sure that we are in compliance with the bill. But more than that is that we are providing a safe place for the children. We have several things, especially say something, and my principal, he's going to talk about it. But we have been the same problem with police officers. We do have our own department, and we have about probably 50 less officers as well, because they get paid more in another place. And so it has been a problem. So far, I can tell you that only high schools, they do have officers, some middle schools, but elementary schools, they do not. They do not. So that's really scary, especially is where the majority of the population are. And those that want to earn, I know that they will do it in any place. They know where to go. They know where to go. So this is something that we have been considering. Usually what we have is on call and patrols, and they go around the schools and everything, and we have been trying, but it still is a mega task. It's a mega task, something that is just for training. I know that everybody's familiar with Uvalde. Just because they didn't want to turn the doors down, they happened what happened. I'm not going to go to that. But what I'm going to say is a week after that, we did have a phone call, one of my schools, I will not say the name as well, that we have someone inside. And the media was reporting that they saw someone inside. And the students tweeting and everything in helicopters, and we were in the news. And I'm talking with the principal and superintendent. I'm on my way. And it was really hard because the police officers, even though they knew that there was nothing inside, they start pushing the doors down. I had to stop them and say, hey, you are destroying the doors just to prove, probably. And so I have more than 16 doors that were turned down without reason, just because they were afraid that the community will probably eat them alive because they didn't do anything. So training is very important. I think that this is one of the most important parts, probably step number one. is to train them, train everybody in the community. And when I say in the community, it's everybody. Because usually, community knows what's going on. And they know those that are a little bit different and those that are under stress. And some data that Dr. White was saying, I was sharing with him, it is true. It is true. Sometimes those students who are making threats to the school, they are repeated offenders. We know that they have been fighting, that they have been bringing guns to the schools, or trying to fight somebody else outside. And so that is something that we need to do is train. And when I say train, the whole community, all stakeholders.
Well, I think you've definitely highlighted the theme for today, which is working and collaborating with our communities in order to keep everybody safe. And with that, I'd like to thank our one final comment. You'll get the last word, Dr. Freedy. So.
Thank you. I think one piece that we're missing is that we're not engaging the students. We have to engage the students in these conversations. They want to be engaged in these conversations. Following the Uvalde shooting, we did a special with Channel 2 News where we interviewed high school students about gun safety and school safety. And they were very brilliant in their ideas for combating some of the challenges. They also spoke very seriously about not being asked ever, how do you feel about the safety measures at your school? What would you like to see? How can we make you feel comfortable? What do you need to do in the community? What do you need to see from teachers to make you feel comfortable? And they have answers. So I think as a last plug, I'd just like to say that as we're making these decisions about gun violence and about school safety and hardening measures and things of that nature, we need to engage our students. We need to engage especially middle school and high school students. They are able to articulate what it is that they see. They're able to articulate why they don't trust or why they don't respond or report things that they see that may be questionable. Number one, they don't believe that the reporting system is anonymous. And then oftentimes the second thing that I heard was there's no accountability. So we report these things and then we don't know what's done about it, or we might hear a bomb threat and I report it to the school and then it's like, oh, we assessed it, it's all good, you're gonna go to school the rest of the day. And they said that leaves us with anxiety. We want to know what was done, what was found, what did you find out? Was there a threat? Give us more information so that we can make informed decisions. So I hope that we can start to engage young people, respect young people, and invite them to the table and not only listen, but also implement, lean into what they're saying and implement some of their strategies in our plans.
Thank you so much for bringing that up.
And with that, I'm going to invite our next panel up to the table.
All right, good afternoon, everybody. So we'll be starting our suicide prevention panel. My name is Zoe Pafiz. I'm a pediatric hospitalist at McGovern Medical School at UT Health in Houston, right down the road. And I'll speak a little bit about why we're here and we're doing this particular panel on suicide prevention and what it has to do with sort of the greater topics that we were talking about. So as I'm sure everyone in this room knows, and I'm sure we've been talking about either directly or indirectly all day today, mental health, depression, and suicidality have been rising steadily over a long period of time in the U.S. And the pandemic really only accelerated a process that's been longstanding. For kids, the American Academy of Pediatrics, along with other organizations, declared a pediatric mental health emergency due to the rapid increase in poor mental health during the pandemic. I work in hospital medicine and pediatrics. I could tell you the last few years have been extreme in terms of pediatric mental health emergencies, extreme in the low ages that we're seeing, really severe kids trying to hurt themselves and trying to kill themselves, and extreme in the volume. But this can be seen in the wider population as well. Suicides have been increasing by more than 60% in recent decades. And it's been and continues to be one of the top causes of death in people from ages 10 to 44, and is the 12th leading cause of death in the US. Like I mentioned, indications suggest that the COVID pandemic accelerated all of these trends. specifically with suicides, both before and now during the pandemic. The latest data set we have from the CDC's 2020, firearms are the #1 method used for successful suicides in both men and women. Also pertinent, especially given the panel next to me, we lose a veteran to suicide roughly every 6 days in Harris County. Kids are increasing in their volume of both suicide attempts and successful suicide completions, both regionally and nationally. And finally, we know that people with neurologic disorders such as Parkinson's disease, Huntington's disease, and others are also at increased risk of suicide, and we're also learning more about how the COVID pandemic is affecting them. So with that, let me introduce our panel. First of all, it's Dr. Ned Levine, right over at the end. I'm sorry, I'll be a little out of order here. Dr. Levine is a non-resident fellow at the Baker Institute and is the director of Ned Levine and Associates, an urban research firm. He's taught for over 50 years. He served as an academic, professional, and governmental servant and has taught all over the world. He's, as someone who's not a master of geospatial analysis, he is a real master of geospatial analysis, has done research, especially for the Houston area, in a huge variety of topics. For our talk, I'll highlight that he's done work in homicides, suicides, and gunshot detection technology. And for the geeks out there, he is one of the people who came up with the initial predecessor for TxDOT's crash records information system, and actually built one of the first first versions of those in the nation. Next is Dr. Taiwo Bapitope. I hope I said your name right. Yes, Dr. Babitope is an assistant professor of pediatrics at McGovern Medical School at UT Health in Houston. She's the training director for the Child and Adolescent Psychiatry Fellowship Program. She's the executive director for the Texas Child Mental Health Consortium, and I'll tell you, she has about 8 more very significant titles that I won't get into, all related to the medical school. But importantly, she works with the Houston Child Psychiatry Access Network, and also, amongst all of that, practices as a clinical psychiatrist. Much of her focus over the past 3 years has been on the Texas Child Mental Health Care Consortium initiatives, including CPAM, which I just mentioned, psychiatry workforce expansion efforts, and pediatric psychiatry telemedicine expansion efforts. She's worked with, it seems like, anyone who will work with their advocacy groups, policymakers, testified at the state capitol, all with an effort to increase research and access to mental health resources for our most vulnerable populations. Next, I have Colonel Dave Lewis, who's right next to me. The Colonel currently serves as the director of the Veteran Services Department for Harris County, Texas, which I didn't know until it was mentioned to me. It has one of the largest, or the largest, veteran populations in the nation, where he's established and operates programs designed to improve the transition to civilian life, community education, and on veteran challenges, prevent veteran suicide and homelessness. Colonel Lewis has served with distinction in the United States Air Force for 29 years as an F-16 pilot and instructor, served with the U.S. 1st Armored Division in Operation Desert Storm, and has also served in the Pacific, European, and Southwest Asian theaters, including combat in both the air and the ground. Thank you for your service, sir. And next, I have Dr. Laura Marsh. Dr. Marsh is the executive director of the mental health care line at the Michael E. DeBakey Veteran Affairs Medical Center and a professor in the Department of Psychiatry and Neurology at the Baylor College of Medicine, where she works as a geriatric neuropsychiatrist and is also vice chair for Veterans Affairs and director of the Behavioral Neurology and Neuropsychiatry Fellowship. Dr. Marsh has led a wealth of research regarding mental health in Parkinson's patients, and works to integrate and coordinate mental health care with the health and social program within the VA and across our community, and represents the VA in multiple initiatives to reduce suicide and homelessness. And finally, I have Dr. Cedric Dark. Dr. Dark is a graduate of Morehouse College, New York University School of Medicine, and Mailman School of Public Health at Columbia University, and trained in emergency medicine at George Washington University. He is now in Texas, obviously, currently an associate professor in the Department of Emergency Medicine at Baylor College of Medicine, and has won a number of awards throughout his career, but significantly is on Elemental's list of 50 experts to trust in a pandemic. And he also serves on the board of directors for Doctors for America and Semester at Sea, and is a medical editor-in-chief for the monthly publication ACEP Now. He has appeared on NPR, CNN, MSNBC, Fox News, and the BBC, and has done policy work for the U.S. House of Representatives, the Kaiser Family Foundation, and the Joe Biden campaign. Nice to meet everybody. So let me just have a seat right here. Yeah, virtually, yeah. We actually never got a chance to meet. I apologize. I came straight from the hospital to be here and just got here, so I apologize for not getting to shake some hands before. So I'm really excited to talk to all of you guys. You guys, I'm sure I left so much out of each one of your introductions, which just goes to show how accomplished all of you guys are. So this is a great opportunity, and I appreciate you guys taking the time to do this. I was going to open with Dr. Levine. I know you've done quite a bit of research on a variety of things, but one thing that you've mentioned is that you've done research on suicide here in the Houston area, both with pediatrics and adult, both suicide and homicide, I have to say, with pediatrics and adults. And I was curious, demographically, what did you find? What patterns stood out to you, and what lessons did you learn from it?
Okay, we're still analyzing. This is a data set that Dr. Bindi Nayak, wherever she is, as I've been working with her and her team for a couple of years, and they've been going through the medical records and the medical examiner records of individuals who attempted or committed suicide, and as well as homicide. Okay, so I mean, I can talk a little bit about what we found so far.
Sure.
But what I thought is there is some interesting contrasts with national data and Harris County. We are similar and different in many ways, and also to try to contrast homicides with suicides. So if you let me have a few minutes,
Please, yeah.
I'll zip through this.
Sure.
Okay. First of all, homicides and suicides are almost polar opposites in terms of their social correlates. There is a couple of exceptions. Nationally, there are far more suicides than homicides, far more. Over the last 10 years, the ratio has been greater than 2 to 1 for much of that period. It dropped a little bit below 2 to 1 in 21 and 22. But as you mentioned, you know, the majority of a bare majority of suicides and the vast majority of homicides are committed with firearms. So even when you compare the firearm-related suicides with the firearm-related homicides, there's about 20% more nationally. In Harris County, that's not true. There are far more firearm-related homicides than suicides. And the reason is that our firearm homicide rate is much higher than the national average, whereas the firearm suicide rate is slightly below average. Okay. In other words, we have a very serious firearm homicide problem here. Okay. Now, there are distinct temporal and spatial differences, which I think are interesting. The majority of homicides occur at nighttime, the vast majority, whereas the opposite is true of suicides, about 3/4 of both. You know, there's some seasonality. We don't have a lot of seasonality. Let me just jump over that. There's a slight weekend effect for homicides. There is not for suicides. The majority of suicides took place in the individual's home, close to 3/4, whereas the opposite is true for homicides. The biggest spatial effect is that the suicide rate increases with distance from the city center. And it's not just a function of rural versus urban, that's well known, but you get a gradient. So the suburbs generally have a higher suicide rate than the central city. The far suburbs have a greater suicide rate than the near city, and so forth. And the effect cannot be completely explained. Part of it is age. Further out you go, you get a higher proportion of older people, a higher proportion of non-Hispanic white, and all those are correlates, but there's something else going on which is not completely clear at this point. We have to keep in mind, though, that even though there are these big differentials in suicide rates, the bulk of suicides occur in the urban conglomerate, which means this places a burden on health services in the city, you know. in spite of the, as I said, the lower suicide rate. Okay. Now, with Dr. Nayak's work, she obtained a sample looking from both the medical examiner records and the hospital records of 30 pediatric cases and 528 adult cases of persons who had attempted or committed suicide. This was 2000 and I believe 2018 through 2020. 91% were successful in killing themselves. So she has some who were not. Males were far more likely. It was 85% in her sample. And this is true nationally, I think. And this is perhaps the one similarity to homicide, where the majority of homicides are to males. Now, many research studies have shown that women have more suicidal thoughts than men, and that they attempt suicide more often than men. Now, we can't confirm that, but in her sample, 22% of those who did not die from the suicide attempt were women, compared to 14% who did die. So there's some evidence that women may attempt it more and succeed less often. Older persons are more likely to commit suicide. You know, nationally, the peak age is 45, 64. Mm-hmm. With our data, the percentage of persons who were 65 or older was much higher than the percentage in the Harris County population, and the percentage under 18 was much lower. In our sample, the peak suicide rate was 55 to 64, and was nearly triple the suicide rate for the entire county. We know that nationally, veterans are much more likely to commit suicide than the general population, almost double the national average. Unfortunately, the data she has, the military status was not properly recorded, and we have nothing to say on that. In terms of ethnicity, nationally, Native Americans and non-Hispanic whites have a much higher likelihood of committing suicide than other ethnic groups. In Harris County, our Native American population is very small, and the number in Vindy's sample was non-existent, so we couldn't calculate the rate. But the proportion who were non-Hispanic white who attempted or committed suicide was much, much higher. It was 62% of her sample versus 28% in Harris County. All right, now, what's interesting, two economists, Angus Deaton, who won a Nobel Prize in economics a few years back for studies of economic inequality, and his colleague Ann Case from Princeton, have shown an interesting result. They found there was one particular subpopulation in the United States that showed increased general mortality. And they've studied it between 1999 and 2015, or maybe even later. I've seen a few of their papers. This subpopulation were white, non-Hispanic, men and women, middle-aged, 45, 64, without college degrees. Okay? Now, all other ethnic groups or combinations of ethnic, age, and education showed declining mortality, as has been consistent. But with this group, you have close to 20 years of increased mortality. And they showed that much of that increased mortality was due to three, I don't know what you want to call it, maladies or conditions, okay? Drug overdoses, a big increase in drug overdoses, including opioids and alcohol, whatever. Big increase in alcohol-related liver diseases, cirrhosis, and a big increase in suicide. This group, there's a big increase in suicide. And those three conditions basically account for the increased general mortality. Now, we found, some support in our data. The majority are non-white. We find that they live further away from, the central Houston in general. We don't know the education level of them. But they live in I modeled it at the block group level, and I found that block groups which had a higher number of persons without a high school diploma had generally had more suicides. And they also found that more bars were associated with, and this surprised me. Yeah, you expect that with homicide. You get that with homicide, but we also find it for suicide. Now, these are social correlates, so we have to be careful about attributing individual data. In Bindi's sample, alcohol was found in only 7% of the individuals, and drugs in only 6%. So at least, you know, whether they live in neighborhoods with more bars or not, you know, most of these individuals were not drinking. What was perhaps most significant was in both her pediatric and adult samples, these individuals, according to the medical records, had a record. I mean, it was recorded in the medical record or in the medical examiner's record. A substantial proportion had been suspected or confirmed as having a mental illness, in particular depression, which fits what you were saying here. So it's something like, you know, 2/3 of the pediatric sample and 43% of the adult sample, this diagnosis.
Dr. Levine, I wanted to take one thing that you mentioned that really struck me and pivot and ask Dr. Babatope about this. So the geospatial distribution seems to be, as you go further out, the rate seems to go up.
Right.
Now, I know Dr. Babatope has been working with the Texas Child Mental Health Consortium. Essentially, and the reason I ask you this is I know that pediatricians, especially as you go outside of the city center, are having a higher burden with lower tools.
Yeah, I'm sure.
So, yeah, so you know, and it's not a good mix. So what's going on in y'all's end? Like this consortium, it seems like you guys are trying to address that. So I was wondering how you guys are addressing this geospatial sort of distribution and what you think about it.
Yes, thank you so much, you know, for bringing that up. So for some of you that don't know, the Texas Child Mental Health Consortium was the result of the Senate Bill 11 to sort of leverage the expertise and the capacity of health-related institutes of learning within Texas and with other nonprofit organizations. So it was a 5-step approach that we developed. The first, which is CPAN, which is the Child Psychiatry Access Network. We also came up with the initiative, which is the TCHAT, which is the Texas Child Health Access to Telemedicine Services, the Community Psychiatry Workforce Expansion, the Child and Adolescent Psychiatry Expansion Grants, and research initiatives targeting depression and trauma. Now, regarding the primary care providers in the underserved regions, the initiative, the CPAN, is supposed to provide pediatricians, family medicine providers, advanced practice providers, NPs, PAs, access to a child psychiatrist within minutes. That's what it's supposed to do. Where if they have children with behavioral health concerns, they can get access to me, any other child psychiatrist, and get a consult, advice. Not only that, also get referrals to well-vetted resources. And definitely, we've been doing this since 2020, and we've enrolled more than 8,000 providers and provided more than 11,000 consultations across the state of Texas. The goal is not only to provide consultation and the resources, it's actually also to train, build capacity in the frontline workers. Think about it. A lot of people will see the pediatrician, family medicine providers. You're not going to see a child psychiatrist. We are the unicorns. There are only 745 in the whole state of Texas, and there are more than 7 million children here. There are some counties that do not have a child psychiatrist at all. So the first thing is to provide the consultation, also provide free Project Echo mental health training on specific topics. Depending on the training expertise or experience of the provider, we know that some pediatric residency programs don't have psychiatry rotations or exposures, and family medicine as well. So this is where we organize biannual training, where we give mental health presentations on ADHD, suicidality, suicide prevention. We're actually going to have one in the next few days. I'll be chairing that. So we give them training, opportunity to discuss cases with us, and also we do outreach. We go to those communities, those counties. We have our outreach program manager here, Ms. Tiffany Jackson, who travels to those places just to talk to those providers. But that is one approach to be able to support our providers in the underserved regions. What we also do is we've decided to expand our region to enroll schools as well. We have more than 409 districts enrolled with the TCHAT services right now. That's more than 3,500 schools. After the Uvalde, we decided to utilizing the ARPA funds to be able to provide access to mental health clinicians, not only the psychiatrists, but also clinicians to give CBT and therapeutic modalities in the interim prior to establishing care to every child in Texas. So those are just two of the efforts, and we are increasing the workforce. My colleagues have mentioned in the past that, there are not a lot of mental health professionals, and you're right. WHO recommends that you have 10 child psychiatrists for every 100,000 children. Currently, there are 10,000 child psychiatrists for 73 million children under the age of 18 in the US, which means that currently there are 11 child psychiatrists for every 100,000 nationwide and 10 in the state of Texas. So we have increased our positions and our training offerings. We are actually getting funds to train more people to come into the training programs. We started at 27, now we're at 47. We've also expanded and also used ARPA initiatives to create social work fellowship programs and psychology internship programs to be able to provide access to care in those situations. And most importantly, we now provide telehealth services to LMHAs. We've partnered with 20 LMHAs and 4 other nonprofit organizations. So right now in UT Houston, we are actually seeing patients in Burke. We just signed an MOU with Tri-County. We've expanded to Spindletop, Central Plains. And, our goal is to make sure that every child in the state of Texas, every provider also in the state of Texas feels supported. At least based on the recent surveys, when we sent surveys to our providers, they noted 76% of them felt comfortable treating mental health conditions in their various places. So these are just some of the efforts that we're doing right now.
It kind of speaks to the previous panel talking about go where the people already are. So that's really exciting that you guys are at the elementary schools. Colonel Lewis, I saw you nodding with when Dr. Levine was giving his, I know there were some limitations to the military population in terms of collecting that data set, but it didn't seem like you were surprised that that being a veteran was an independent risk factor for suicidality. So kind of the same question that Dr. Babitope had, you don't seem surprised. What do you feel like you guys that can do and have been doing to meet these people where they are and try to help them to decrease suicide through lethal means?
So thank you. And I just want to acknowledge that we try to fill in the gaps where the VA can't. Only about 29% of veterans who are eligible for VA health services here in Harris County actually use the VA. So we're trying to fill in those gaps. I've reviewed every suicide in Harris County for the last 4 years. We cross-match that against the known list of veteran deaths, which helps populate that. So we know IFS doesn't always capture whether they're a veteran or not. But we do know that veterans make up 3.5% of the population of Harris County. They make up 11% of the suicides. We have lost over the last 4 years 245 veterans to suicide. So that's about 1 every 6 days. If you add the opioids, fentanyl, et cetera, it's about 1 every 5 days. We also have things that can't be classified necessarily as a suicide, but things that concern us, high-speed accidents, that sort of thing. Firearms, by our list, are involved in 72%. We saw the same national trend from 2019 to 2021 of decrease in veteran suicides. That's great progress. We saw a rapid spike in 2022. 10% increase in veteran suicide. Of significance is black veterans' suicide rate has doubled between 2021 and 2022. So talk about things that we do. I don't want to get hit by anybody's DSM-5 over here. I'm clearly not in the right panel, but I do want to say this. When we communicate with veterans about suicide, we talk about the means and the will. This is something we learned from Napoleon, by the way. Your will to take your life and the means that are available. So we can talk about your will may vary, and Dr. Craig Bryan's book, Rethinking Suicide, really brings some interesting light on impulsivity and some other things. So if your will varies, but your time to lethal means never changes, we worry about that intersection of means and will. So our goal is to be able to provide the veterans with the toolkit to figure out where they can temporarily and reliably store their lethal means. That's really important because we think if we can get them in front of a clinician, that's great, and we can have all the clinicians do the things that they do and talk safety planning and everything else. But again, Dr. Bryan's book talks about 46% by CDC numbers have a mental health component, which means more than half don't. So how do I reach the more than half that don't have that? So we believe we're rolling out a program called the Texas Two-Step. I'll probably get killed for using that term, but so be it. Texas Two-Step, secure the means, reach out for help. Okay, secure the means, reach out for help. And when we talk to the veteran about their will may vary, I like to talk about, again, a metaphorical bucket. So imagine you join the military with adverse childhood experiences already in your bucket. We send you to war a couple times, maybe 2, maybe 3 times. Maybe you accumulate military sexual trauma along the way. You come home with some moral injury, which we haven't really talked about today, but when you observe or you're the perpetrator of violence. And so your bucket is filling up. Now we come home and we give you all the transitional issues. You got to rebuild your Maslow's hierarchy. We throw in a lot of those social determinants and everything else. And you get a speeding ticket on the way home. You get into it and you're into it with your spouse when you get home, and somebody has immediate access to lethal means, and that's when we lose some of them. So how do we help them recognize and do that upstream planning? So that's really important for us for the pre-crisis piece, in both with the veteran and their close circle. So as you start to wobble, if you will, with your desire to end your life, it's time to implement your plan that we have pre-thought out. And the last thing I'll say is words matter. If you talk to a veteran about gun safety, click, right? They've been around guns their entire military career and probably most of their life. If you talk about secure means, that's important. And then finally I'll say, it's not just getting the weapon, maybe the serialized weapon out of the home creates a lot of other legal and liability issues. There's 50 ways to do this. You can do it in the house with a gun lock. You can do it with a gun safe. You can put a picture inside your gun safe. Or we say secure the action. Disassemble the gun, take a firing component, non-serialized, secure that somewhere else. Same effect. You don't have all the legal liabilities and everything else. So look forward to our campaign rolling out about how we communicate with people to be able to address those issues.
Thank you. So Dr. Marsh, I know you do a lot of work with veterans as well, and you also do a lot of work with the neurologic diseases and its component and how it interfaces with depression and potentially suicidality. My question for you is, what would you like us to know in terms of what you know, which is a lot, in terms of how these other diagnoses may affect this particular part of the population, and also maybe people who are not even diagnosed with depression, who have, say, Parkinson's disease or some other neurologic disease, and what we should know about that population and what their risks are.
Okay. Well, it's good that people want to know those things, because I think one of the first barriers we have just in psychiatry in general is that folks are afraid to talk about it, and it's very hard to deal with something if you're not talking about it. So one is recognizing it, and so in my work with Parkinson's disease, the purpose in part was to, as I mentioned, was to use these neurological disorders as models for understanding psychiatric problems in people in the general population. We know that in any of those, whether it's epilepsy, which has a markedly high rate of suicide compared to the general population, but other neurological disorders as well, you're more likely to have mood disorders, anxiety disorders, et cetera. And we know that depressive disorders are associated with higher rates of death by suicide or suicidality. What the barrier is, of course, is one, those folks are typically not in a psychiatric clinic, they're in the neurology clinic, where the neurologist isn't interested in treating that, or they're afraid to treat it, or they think if they start to ask about it, they're going to open up Pandora's box. One of the things that we do really well at VA is to integrate care and to work with anyone, everyone, to help them become more comfortable asking about suicidality, and to really normalize, you know, that when you talk about this. And I'll just give an example. I was giving a presentation to Parkinson's patient group, and they requested that I do not talk about gun locks or suicidality, because that was going to freak out people because they would think that that was something they had to deal with. And there were a number of people in the audience who had recent onset of Parkinson's. You know, so I finessed it. I got a little of my words in, but I think that the concept of being proactive, as Dave was talking about, is what's really important. And it doesn't matter whether someone has Parkinson's in many ways, or whether they have, you know, they're just a 12-year-old. You know, that the idea is that there are things that when people have a mood disorder, their thinking is not right. And they're looking at the world through mud-colored glasses, where the rest of us have you know, clear eyeglasses. And so what they're thinking about is skewed. And it's skewed to address the sense of despair and hopelessness that they feel. And that people can feel that way even if they have, you know, Parkinson's, or if they don't. So in addition to what Dave talks about of means and will, we also use the term time and distance, so that when we speak with someone, we say, you know, people with conditions like yours, it doesn't matter what the condition is, but sometimes get to the point where they feel that life isn't worth living, and or they feel that they want to give up. You know, does it ever get that bad for you? Not that you feel that way, but sometimes people in your situation have. And then you kind of keep moving on, and if they, you know, what about, have you ever gotten to the point where you feel like you actually want to think about what you might do to harm yourself? Does it ever get that bad? Again, not that you feel that way, but sometimes people do. People are more likely to tell you what's going on as opposed to, so you feel suicidal? You know, which is usually the way people ask it in an ER or whatever. You suicidal? You know, people know whether you're spending the time.
Here.
It's true. It's true. It's amazing how many people actually answer that question, and we save lives because of it. So it's good. But when you're really trying to get information out and then work with people so that they're going to be safe, you know, then you can do that. Now, so the time and distance. So when Dave says you take apart the gun, that's going to increase the time that someone has to use that lethal means. And the reason we focus so much on weapons and firearms is because, of course, you're more likely to die by suicide if you use a firearm, whereas all the other ways that someone can try to harm themselves are not as likely to be lethal. But there's that moment when someone is in that state that the longer the time is from when they first start having those thoughts to when those time that they stop having it, the longer you wait, the less the intensity is and the less likely they are to act on it. So you got to do things, whether it's dropping in on them or, you know, if someone's there, if they're on a suicide watch or something, but you want to do anything you can. You talk to people and families about making that time greater as well as that distance, and having also then things that people can do. Like Dave's giving people this idea, have I secured the means, have I reached out for help? If you're proactive, say, if I know I have a mood disorder, if I know I'm distressed, let's do all that in advance so we have a plan. And, veterans like having plans. They do their routines, but everyone else can be like that too. And that's really how we've approached our safety approaches with suicide prevention, and also, using firearm safety or firearm securing, however Dave wants to say it. What he didn't say was that since 2012, we've had, 2017, we've had a really fantastic community partnership that has involved so many community groups, schools, hospitals, social agencies, veteran agencies. We work with everyone. And we have been, and the purpose of it was something called the Mayor's Challenge to reduce suicides, or for suicide prevention in veterans, military, their families, and their caregivers. So at that point, is there anyone left in the community? I don't think so. So even though ostensibly it was to help veterans, what we've been doing in the community is really helping everyone. And I believe that that is why you may have a reduced suicide rate in your population, at least for our veterans, and even for suicides in general in Harris County relative to the population. Now, our VA covers 283 square miles, but basically southeast Texas. But what I also can tell you is that we do track all of our deaths by suicide, and the rates of veteran suicides in our VA, what we've been able to get, and every year we get better and better. We're really out there getting all the information, same information that Dave has. That number has not changed since 2010. It's been about the same. Dave said there's about 60 per year over the last 4 years, and it's been about 60 per year. What we find, though, is that when you have a person in treatment, they're less likely to die. So we know that when we look at the number of veterans in treatment, whether it's VA or someplace else, they're the ones that have a lower rate. So it's probably like, if there's 60 a year, it's like 20 to 40, and so, or even less. So I think that's something that, treatment works, people get better.
I'm sorry, you're saying 60 per year for the last X amount of years. With the does that mean the rate's going down? Presumably the population's
we see more and more patients. We've had better and better detection. So, the population's growing. So I believe, I know this is only my, this is not, I need a statistician to help us get this totally official. But what we're looking at is, we've had an overall stable rate of the number of individuals, who are veterans, who we've identified who've had death by suicide. And we've also had a relative rate of reduced suicides among the people who are engaged in treatment of the VA versus those who don't. And that's common throughout the country when you look at the veteran suicide data. Yeah. So the rates for suicide deaths in veterans is reduced and has decreased over time in the last 10 years, say, or actually since 2001, in individuals who are in treatment, whereas it's gone up in the ones who aren't in treatment. So those are really important factors. So getting people into treatment. So time, distance, treatment works, do your two-step, all these little, maxims that people can live by can actually save lives. I think I answered your question.
Yes, you did. Yeah, that was an excellent answer. And I'll say one of the things that strikes me so deeply about what you guys are saying is the deeply personal nature of suicidality, but the need to engage with the broader community and just plain old simple, get them to an expert.
Right.
So, Dr. Dark, I'm going to ask you by far the hardest question, which is knowing all of these different things, like how deeply personal this is, how important it is to get to practitioners, of which we have a huge shortage of, and how important it is to interface with what really is a complex group of complex communities and complexity within communities. How do you fix it? No. My question really is from a policy standpoint, if you get a chance to sit down with the city, the county, the state, and talk to lawmakers, what would you, as a provider, as an advocate, as someone with a lot of knowledge on this stuff, what would you want them to know, and what would you advocate for?
Yeah, I'd first need to sit with the governor.
Just start from the top.
So starting there, because And one, I'm really happy to be sitting next to a unicorn, because we don't see pediatric psychiatry in our ER. We are blessed to have a ton of, we actually have a psychiatric emergency department inside of our emergency department, and they see about 600 patients a month. 20% of which are probably suicidal, about half of which get admitted to the hospital. So we're talking probably 2 or 3 patients a day that are admitted for suicidality. That's sort of the environment where I work. The weird thing, and most of you probably don't even realize this, is that if someone walks into, not my hospital, but into any other ER in Texas and says that they're suicidal, you might think that the physician at that point in time can actually say, oh, you're suicidal? Well, you shouldn't be able to leave here until you're evaluated by a psychiatrist. How many of you think that is the case? Yeah, you're all wrong. Technically, if I do that, I'm like kidnapping someone. And I am willing and able to kidnap someone in the state of Texas if I have to, because that means I'm protecting them and maybe someone else's life. Now, a few years ago, the Texas legislature passed what we call a 4-hour emergency hold bill, which would allow us as emergency doctors to do that without having to go to a court and do all these other things. The governor vetoed that bill, even though it had passed with majorities in both the House and the Senate. And what that does is that leaves this sort of what we call a police packet sort of in the hands of law enforcement to be able to do this. But if you're at a facility where you don't have law enforcement sitting there, as we were talking about, schools don't have law enforcement sitting there all the time, you're kind of hamstrung. So that's the first thing I would do, is number one, let me do my job without making me a criminal to do my job. Number two, and again, I'm the policy person, so there's 4 easy laws that we could pass. Texas has one of them already. It's called Child Access Prevention Laws. We've talked about this all day. Young people under the age of 21 probably shouldn't have easy access to firearms. We should have minimum age restrictions, and it's one of the things that made it out of committee this year, but didn't get a House vote, didn't get a Senate vote. That's something that we know will demonstrate to save lives. Waiting periods, which kind of gets to what the Colonel was talking about. Yes. You know, if you separate, you know, the will from the means, then you will save some lives in terms of firearm suicide as well. Like, fun fact, not so fun fact, but interesting statistic. If you see somebody that has taken pills versus somebody that points a gun at their head, you're more likely to die by pointing a gun at your head by 55 times compared to somebody that has taken pills. It's like simple math that everybody in this room ought to know, so that when we talk about means restriction, we understand why it's really important to ask, as your second question, are you suicidal? To also ask, do you have firearms in the home? Because if the answer is yes, that person's at much more risk and probably needs to see a psychiatrist as opposed to someone that I could let leave the ED. And you know, the average waiting period for someone if they go to, you know, through a background check to get a firearm is less than 2 minutes. That's how long it takes to run the background check through the federal system, the computerized system, and if you pass, you get your gun like that. So if you're actively suicidal, you run up to Academy or wherever else they're selling firearms, in 2 minutes you can get a gun, walk out in the parking lot, shoot yourself in the head. It happens. It happens.
It does happen.
I won't say which day it was because it'd probably get into HIPAA a little too much, but there was a patient recently who was sitting with his wife. The cable man came over to work on their internet. She went to talk to the cable man for something. Everything seemed fine. He went out into the backyard, shot himself in the head, somehow wound up in my ER. I've only seen 2 people after a suicide attempt in my emergency department or in the ICU in over 10 years of practice because it's so fatal. This is one of those 2 patients that showed up. So that's what I would do, those laws there. The 4th one is licensing and permitting. Again, Texas seems to be committed to going the opposite direction from licensing and permitting, but those are the 4 things that I would do.
Oh, thank you. Yeah, and so I have some audience questions. I have 5 minutes generally, roundabouts, okay. So this one is a question for everyone, but Colonel Lewis, I'll give you the first shot at it. How did because this is a really great question. How did the pandemic affect veteran suicide rates in Houston and Harris County? And I'll make a caveat to that. I think we know that loneliness has gone up, isolation has gone up, families have broken down. You mentioned adverse childhood experiences, but you can still get an ACE when you're an adult. Adverse experiences are going up. So specific to the veteran community, what have you noticed how that's affected the community and how people are trying to respond to that?
So here's what we know. About 1 in 20 veterans who separates from the military tends to isolate, and we have to go find them or find somebody who's seen them. We use eyes and ears in the community to do that. During the pandemic, from 2019 we had 60 suicides, 2020 58, 2021 55. It looks like it's a great trend. 2022, we're out of the pandemic, back up to 62 again. My understanding, and there's probably a lot more expertise on this panel than me, this is a historical thing that we see, that during a pandemic, we don't see we see the isolation, but we kind of tend to pull together. Post-pandemic is when we start to see increases. So that's what we have seen specifically here. Our data is a little easier to access, I think, than the VA's, which is a couple years down the road, and by the time they process it and do everything else. So we saw the same trends that they saw, but we've seen last year a significant spike, and we hope that's an aberration and an outlier, but I'm not convinced it is.
I was just about to, you suspect it's the beginning of a trend. Dr. Babitope, are you seeing the same thing with kids, or?
Yes, and just to say this, prior to the pandemic, rates of child mental health concerns and suicidality had been rising already steadily for a decade. We definitely know that the rates of depression and anxiety have doubled, and I just have some stats here. Between March to October 2020, researchers quantified the toll emergency department mental health emergencies rose by 24% for children between 5 to 11. Also, it rose by 31% for children between 12 to 17%. Suicide attempts increased nearly 51% amongst girls ages 12 to 17, and more than 140,000 U.S. children experienced the loss of a caregiver. Children of color were disproportionately impacted. Definitely, we are seeing a rise in clinic visits. I have currently a year waiting list to see me, and every time someone cancels, I quickly tell the MA, quickly put somebody else in, get anybody that can do a telehealth visit. And it's rampant, it is. There are not a lot of mental health clinicians because they are burned out too. Some of my colleagues are burned out, they're taking time off. So we've definitely seen the impact, more anxiety. Also people, children, there's isolation. There was isolation when there was the school shut down, and now most kids are afraid to go back to school. It's just, there's a lot of school avoidance as well. So we're still seeing the impact right now, and the children are having a tough time, the parents as well. I'm a parent to 2 kids, and you know, the rise in gun violence and just mental health concerns, it's very disheartening on a level. 1 in 6 children each year will experience a mental health disorder. And I want us to destigmatize mental health disorders. 1 in 4 people you see every day has a mental health condition. As you go out, as you go grocery shopping, come to work, even physicians. So one other thing I want to stress out is in checking in connections, and also to train mental health professionals, primary care providers, that asking about how are you doing, it helps. You're going to hear a lot, and you're going to be able to provide necessary resources to them as well. And that's where I still say it stresses in that even if you can't get access immediately, Texas is now committed to providing interim care, even therapeutic services to schools, kids in schools. Just tell us which school they are. We'll find them. We'll get in contact with the counselors. So yes, we are definitely seeing a lot in our clinics.
Yeah, I think we're right at time. Dr. Dark, if you wanted to just close us out.
Yeah, just
and any closing thoughts you had, and anything optimistic you could tell us. Just
See, I don't do optimism. I'm in the ER. We don't do optimism. I just wanted to, because you mentioned, you know, you have a 1-year-long waiting time to get an appointment. The same thing what we see in the ER. We have a huge boarding crisis, as was mentioned earlier, and it is so much more exacerbated for mental health, but especially pediatric mental health, where we see kids that are stuck in ERs for days, weeks. Some people I've heard reports of in my role of ASAP now medical editor-in-chief, 200 plus days of people waiting in an ER to find a place to go where they can actually get the therapy that they need. So, sorry, it's not very optimistic.
We'll get there. That's why we're here. We'll solve this, guys.
Can I give an optimistic?
Yeah, go for it. Yeah, sure.
So one of the things that we've put a lot of effort. VA is really an expert on suicide prevention, also on violence prevention, and they have workplace violence prevention programs that are very robust. So we have in our Houston VA, we have 12 suicide prevention coordinators, and something we've added in the last couple years are these what are called community engagement and partnership coordinators. And and this really applies to what the schools are talking about too. And it begins to address this idea that every school, every site, every venue, every place has its own culture and needs to be empowered to develop what's going to work for them. And what's been so great about the CPAN is that how it's really worked to build capacity without having poor Dr. Babato be the one that provides all of the care, because that's impossible. You have to have, but if we wait until someone gets to us, it's too late. So we have to work in the community. So one is that, so we've had this technical assistance as we've worked with the Mayor's Challenge, which has now changed its name to SPARC, which is Suicide Prevention.
Resource Coordination.
Resource Coordination, right. And we are very fortunate here in Houston, Harris County, because we really work together well. And I do the same kind of relationships that I have with all these agencies in regarding the mental health issues overlap, and the same kind of behavior goes along with in the homeless program. But we can't expect our teachers or our principals to be kind of building their plane as they fly it and try to teach the kids and come up with their own ways to help people's mental health. But these technical assistants who come in, which is what the community engagement people are, they're trained in how to help you do what's good for your community or your table, whatever the issue is, to be and identify and brainstorm what's going to work for you, and then pinpoint that and help you get the resources. So I think that is something, if we're going to get policy or money, that would be something that builds the capacity and builds, whether it's in your YMCA or your church group or whatever.
That's really exciting.
You can do it.
Yeah. Thank you so much for all our panelists. We really appreciate it, and the expertise is really something. So thank you guys for taking your time.
You're the manager, but is it related to the manager's foundation?
Our clinic, yeah. That used to be the manager foundation.
All right, I'm going to bring us back to the table here. Thank you all. I am very excited that we have continued to have such incredible conversations around how we can reduce firearm injury, not only in Houston, but across the state. And we are going to be closing out our day with our final panel. I do want to give another final shout out to our sponsors for the day, with Memorial Hermann and UTMB Center for Violence Prevention, as well as UT Health Houston and Baylor College of Medicine for their gracious sponsorship for today. I believe we are working on getting a Zoom link brought up. So what we have today is our final panel is going to be our legislator panel. And we are having to make a little bit of an adjustment because we thought that the legislative session was supposed to be over. Oh, there's me. Hey! Excellent. The legislative session is supposed to be over. However, it's not quite over because special session is in place. And so we have slated on the docket today Representative Vicki Goodwin and Representative Ann Johnson. Representative Ann Johnson is going to be joining us virtually because she has been called to legislative duties. Unfortunately, Representative Jarvis Johnson had to cancel on us because of, representative duties, of course. we are in a special session. So I wanted to give you guys a few statistics to remind us all. Sine Die was just on 5/29. We thought that we would be really good about not being in session by scheduling this event on June 2nd. However, we are in a special session. It is our first special session. We're on track to beat last legislative session's special sessions because there were 3 special sessions. Hopefully we won't beat that session, but we'll see how it goes. But I'm not a legislator, but thank you and good luck to our representatives for the special sessions. So for our 88th legislative session, our legislative sessions run for 140 days every other year. And so that is when the active legislative sessions run. We had a total number of bills filed were 8,578. The number of bills that were sent to the governor were 1,353. The number of bills that failed to pass by sine die was 7,225, which gives us a passage rate of 15.8%. So our failure rate for bills is 84.2%. The take home on all that math and all those numbers is that it's really hard to pass a bill. So with that, I think things for us to remember are, we'll see how special sessions go. I'd like to first of all introduce our first speaker here today, which is Representative Vicki Goodwin. Representative Goodwin is a small business owner, a real estate broker, and a community leader. She represents House District 47 in Western and far South Travis County. She has been a strong advocate for school finance reform, including the boosting of retired teacher pay. We spent a lot of time talking about schools today and the need for investments in schools, and so she's been a strong advocate for schools. She's also been vocal about her support for strong firearm legislation, including universal background checks, 72-hour waiting periods, and extreme risk protection orders. She graduated from the University of Texas with a bachelor's in business administration and the LBJ School of Public Affairs with a master's degree. In addition to her strong family ties, she dedicates her time supporting her local community, especially with the local food bank, Meals on Wheel, and her local HOA. Representative Ann Johnson, when she joins us, do we have our link live? Okay. She should be joined. Oh, I see her there. There she is. We've got her. I just don't see her on the big board yet. Oh, there she is. There I am. Okay. Hello, so excited to see you. Representative Ann Johnson is a former chief human trafficking prosecutor, current teacher, and business owner who works as an attorney in our criminal justice system for victims of sexual exploitation and those who cannot afford a lawyer. Representative Johnson received a bachelor's degree from the University of Texas and her law degree from South Texas College of Law in Houston. She worked as a briefing attorney for the Honorable Leslie Brock Yates, then a justice on the 14th Court of Appeals following graduation. She also worked as a prosecutor with the Harris County District Attorney's Office until 2005, where she entered private practice with her father at the Johnson Law Firm. And she also represents individuals in civil, criminal, and juvenile matters. She's been elected to serve as a state representative in Texas House District 134, which is here around the Texas Medical Center, since 2020. She also serves as an adjunct professor of law with the South Texas College of Law in Houston since 2001. She's also an active member of the Texas Children's Justice Act Task Force, and she too also has strong ties to her family and also her rescue dogs. We are really excited to have them both here today and also value the joy of technology, and I think that is one of the benefits that we can say that COVID brought us, is that we all learned how to Zoom really well. And so I'd like to say thank you to our elected officials for being here today on our panel, and I'd like to have everyone help us welcome them today. I'm going to move to the chair so I can see you. Good morning. So the first thing I'd like to talk about is a little bit about the committee process, which I feel is kind of America's little best kept secret. So many folks want to advocate and call for change when there's a vote on the House floor. And usually that is a time where it's maybe a little bit too late to start making your case known about a bill that you may be concerned about or that you may be interested in. either of you let us know a little bit about your committee process and what's helpful from what you want to hear from individuals and when you want them to reach out to you about legislation. So we'll start with Representative Goodwin and then we'll go to Representative Johnson.
Sure, absolutely. By the time a bill hits the House floor, it's almost too late in the process. Obviously, people can still email or call their senators and representatives and express your position on a bill, but you really want to start early in the process. From the time session begins in January, that's when things get rolling. But even then, we don't know who our committee chair or committee members are, and so you may not know who to advocate to at that point in time. Once a committee is established, then you want to make sure your priority gets to that committee, so you start talking to your members. We work on bills even during the interim. A lot of people think that we are there just for 6 months, but a lot of that prep work and meeting with constituents and figuring out how our bill is going to pass the next session, that gets done during the interim. So we certainly are having meetings with folks. My office has worked very heavily with Texas Gun Sense and Moms Demand Action and Everytown for Gun Safety, organizations that have been doing this work for a long time, and we kind of strategize with them hand in hand to figure out which things do we think might move next session. And of course, it's very unfortunate that after the Uvalde tragedy, that brought a lot of folks into the conversation about something that they really wanted to have. The families from Uvalde really wanted to raise the age for buying assault-style weapons from 18 to 21. And so that became one of the big issues that we pushed in the Select Committee on Community Safety. I thought that with the speaker setting up this select committee, that was a signal from him that he wanted some gun safety legislation to pass. And in fact, I think it didn't get picked up in the news a whole lot, but there were 2 bills that made it out of the House that were gun safety related. One was a straw purchase bill that would have taken the same federal law and brought it to the state. So currently, if you buy a gun, you're allowed to buy a gun, but then you sell it to someone who by law can't buy a gun themselves. That's a straw purchase. It's illegal at the federal level, but we don't have ATF coming in and investigating those types of crimes as much in Texas, whereas if we had a Texas law, we could have Texas law enforcement looking into those cases. That bill made it out of the House, but the Senate amended it, and so it died. Another bill was from a Dallas police officer on Glock switches, which are used to take a regular handgun or, I don't know, maybe a long gun as well, and make it into like an automatic weapon that can rapidly fire many shots. And so he was able to bring that to the House floor. On the House floor, we, Representative Joe Moody and myself, both tried to amend it with the Raise the Age bill, which was not germane. So those amendments died. The bill still made it out of the House, but according to the representative, it lessened the number of Republicans willing to vote for it. And so when it got to the Senate, Dan Patrick just said no way. There's a lot of strategy that goes into it. Coming to committee hearings is very important. When we see a large crowd coming for an issue, then we know this is a very important issue. And of course, a lot of the gun bills do bring large crowds. I will say I've been on the committee 3 sessions now. Each session has been very different. My first session, we actually had a Democratic chairman of the committee and some willingness to have a more balanced approach. The one, I guess, sort of blessing that came out of that session is we did not pass permitless carry, which was something the Republicans wanted to do. Then the following session during COVID, when our supporters weren't as willing to come to the Capitol because we didn't have the vaccine yet at that point in time, we had a very unbalanced approach. We had many more on the other side of the aisle come, and we did end up passing permitless carry. This session, again, I thought the speaker, by setting up a select committee on community safety just to hear the gun bills, I thought that was a good thing. In the end, it turned out we really didn't get much passed with regards to gun legislation, gun safety. But I will say I feel like we moved the needle. In fact, Representative Tracy King mentioned he, in the past, had not been in favor of raising the age from 18 to 21, but because that's his community, his mind changed. We had 2 Republicans that voted for that bill in committee, which prior session, we probably wouldn't have even had those 2 voted out of committee. I also heard Representative Harless speculate that we would have had the votes to pass it out of the House had it gotten there. But I think Calendars Committee kept it from getting to that point. That was a long answer, sorry.
It's good to see you, and it's good to see my friend Representative Goodwin. I will say at the end of that comment about Calendars Committee kept it from getting there, actually Calendars Committee did not get it in time to get it to the floor. And so just as Representative Goodwin is mentioning, when is the time to start working on your legislation? And the time to start working on your legislation is now. Just as mentioned, we're probably going to be in a few special sessions, hopefully not a few, but we do anticipate more special sessions between now and your next election. Typically, we call this the interim. We are out of that constitutional obligation time of starting in January to the end of May for those 140 days where we are there, where each member can file legislation to talk about the issues that we individually care about. I know we filed legislation on mass shooters, we filed legislation on extreme risk protection orders, on raising the age, and on road rage. I am proud to tell you that our mass shooter bill did pass the Senate, and I expect that the governor will sign it. And it acknowledges that somebody who is attempting a mass shooting but does not kill anybody, but they do discharge into a crowded area is going to be held at a higher level of punishment. That's especially important when you think about Houston area and about a year ago where a gentleman took an assault weapon and fired at a number of police officers in Midtown, kidnapped and carjacked a woman. And that case will be prosecuted like they fired one shot at one police officer. This new law changes that and says that you are going to be responsible for every bullet that you fire. And it picks up the FBI definition of mass shooter of 4 or more individuals. That was important to me. And it was important to me because we found an avenue to pass some form of gun legislation. And to me, it was significant because as we laid out this bill, we had entities, just like Representative Goodwin said, there are crowds that show up. Some that in the past would say, we don't want anything to do with any gun legislation and everything is a no. And on this particular bill, some of those people broke and said, oh, actually, this makes sense. If somebody's the bad guy trying to kill a bunch of people, we're not going to take a position on that. And so I think that's part of what we're trying to do, is we're trying to change the conversation from folks that just believe Second Amendment, you can't do anything, to recognizing and having people realize, hey, maybe we shouldn't have an 18-year-old kid who's known as mass shooter be able to go in and buy an assault weapon. Maybe raising the age to 21 is the quickest and safest way to change that. And I do think Representative Sam Harless and Representative Justin Holland, the 2 Republicans on that committee that voted with this bill that got it out of committee, deserve a great deal of credit for having the courage to go against something that is perceived to be a no within the Republican Party and taking a stand on that. And so I'm grateful that they did it. Same thing with our mass shooter bill. We offered it last session, but last session it didn't make it all the way to the governor. And so also be prepared that you working on your ideas, it's not just in the interim. It's getting a representative that will pick it up, getting them to file it, getting them to get a chairman to give it a hearing, getting that hearing. And then just as Representative Goodwin experienced, it was those Uvalde families, it was those individuals that came to the Capitol and said, bring up 2744 for a vote. We recessed on the House floor late to have that committee go back and take a vote at the last minute on that bill. And that's significant because that was public pressure that forced Chairman Guillen to take that vote. The challenge was that by the time that happened, it was so late in the game that you couldn't realistically get it to the floor. But that's why we need to take that it was a win to get it out of committee. It was a win to get 2 Republicans to take that vote And that starts to change the norm, that next time, absolutely it should get voted out of committee, but it should voted out of committee with enough time to be able to bring it to the floor so that the full House can debate it. And then maybe the next time after that, it gets voted out of the House early so that it gets to the Senate early, so that the Senate has to take a vote and has to take a stand. And so again, there are no easy wins here, but there is making progress. And so while I know that there is so much that we need to do, I am optimistic that the public tide is changing and recognizing that it is absolutely necessary for us to start acknowledging and addressing gun safety legislation.
I love how you used the word changing and starting conversations, because that's actually been our theme for the whole day. Even though you weren't here today, you guys actually brought in our theme right away. Because we've been having conversations about how to talk about firearms within clinical encounters and within our communities, and even working within our legislatures about how to start those conversations, continue those conversations, and how do we keep moving that needle forward. And some of those conversations are difficult sometimes because we may engage with folks who are maybe not bringing the best information forward. And I'm gonna touch in a little bit on, I was discussing with Representative Goodwin earlier, I had the honor of sitting in on the Uvalde hearings with the Committee on Community Safety. And part of those hearings, there was a great deal of information being shared from both those of us in healthcare and in the research aspect. And then there were also, everyone seemed to be a constitutional lawyer expert there. And then there were several folks who were bringing in very blatant misinformation. And she was very astute in calling out several of those folks that were bringing in just very clear misinformation. How challenging is that for you, for both of you, when you're in that space and in that setting, you're in a hearing, you're in those committee spaces, and you're getting this information just thrown at you? Because when you testify, and for those of you in the audience and for our online audience as well, uninvited testimony is you get 2 minutes, anyone can come in and say whatever they want, right? And they can say whatever they want. And for the moms group, I mean, they were there too, and they were counteracting all the misinformation that was there. How do you, first of all, be equipped to be able to identify the misinformation in real time? And what do you need from us to help you in those moments as well?
Well, yes, it's always interesting who comes to testify. And honestly, the first time this doctor came and testified last session, I wasn't aware that he had been debunked, but that was brought to my attention. And then when he came back again this session, I thought it's possible some members on the committee may not know that his information is not valid. You know, sometimes when people speak with authority and say that I'm with this university or this school and I have this research and it all sounds great, you might be inclined to believe that. And so I did speak up and say, well, you know, your work has been debunked. How do you, and that was a bit of a tense moment because the member who invited him didn't appreciate my, you know, calling him out. So it's not easy, but we are representatives coming from all different kinds of backgrounds. We aren't all experts on any one thing. Very few of us are experts on gun policy. And so I think to not say that what you're laying out for us is not accurate would not serve us well. We need to know. And unfortunately, I think a lot of times, even members, even legislators go with gut feelings, with the anecdotal information, rather than really looking at research, which is what we ought to be doing. We should be looking at the data and the research behind it. So I felt like I had to call that out. There have been moments where sometimes that information slides by, and it just leads to poor outcomes as far as policy goes. And so, you know, I later apologized to the two members who took that poorly, and they appreciated my apology. I said I still stand behind. I think that he was giving out bad information, but I certainly didn't want to create ill feelings, and so they appreciated that, and we kind of smoothed that over. We have to, particularly in the minority party, we have to work with our counterparts in the other party, and so it doesn't help if they feel like we're antagonistic. And so it's hard because there's certainly a balancing act of making sure people are looking at the truth and the data behind it, but not making it feel like we're being antagonistic. So it's very interesting how you can work that and massage things. So it's part of being a legislator. What would you say, Representative Johnson?
Well, I would agree with Representative Goodwin that we are in the minority in the sense that she and I are Democrats. And most people right now associate common sense gun reform candidates predominantly being Democrats. But I think to a credit to many of the people in the audience, and I know the reference to Moms Demand Action, they don't care what your party affiliation is. They care whether or not you're going to be courageous enough to take a stand on common sense gun safety reforms. And I think that the movement that you've seen over the last decade since Sandy Hook, that progression of adding youthful population that are absolutely been raised in a way with mass shootings in school and being raised having to do mass shooter trainings and things that you and I, of our age, we never would have contemplated. And for them, it's perceived to be the norm that they are grown up with because the adults around them have not been able to stand up to the gun lobby. And I think they are over that. And they are ready to have leadership in government that will say, no, we shouldn't make third graders go through tourniquet training on how to heal wounds because we can't step up and have conversations around common sense gun safety reform. I think the most significant thing that happened this last session is the vote of Representative Justin Holland and Representative Sam Harless, because you have finally proven the point that in Texas, this can become a bipartisan issue and can be something that we hold people to account and that they will break from party. And I think that's significant. But those are just two members who have gotten to that point. And so there is still a lot of work to do. And chairmanships matter. So when Representative Goodwin talks about the process and what can come up, the chair of the committee determines what we hear. The chair of the committee also determines the manner in which we hear it. So if they decide that we're going to cut off testimony at midnight, and we have 2,000 people that have signed up to register to testify on something, but the first 10 panels are invited testimony from the chairman, then that's going to dictate the conversation and what happens, and often will leave citizens like yourselves that want to come up for your 2 or 3 minutes. You might wait all day and never get called. And that's why the chairman of the committee is significant. And the leadership of the body that sets the chairman is significant. And so again, I think you have a great amount of work to do in ensuring that those that are put in the positions of special committees will be willing to allow both of the concerns to be raised. Representative Goodwin and I experienced this after Uvalde. 2 committees, Youth Health and Safety and Homeland Security, were put together to evaluate Uvalde. And we both sat there all day and heard invited testimony all day. And it wasn't until we got to midnight, when probably most people stopped paying attention, that we finally heard from gun sense candidates and from doctors who worked in emergency rooms and could tell you what it's like when an AR-15 and the bullets that come from it, the manner in which the body effectively explodes, and the real risk of, if you happen to survive, the manner in which you will live with that trauma for the rest of your life. And it was extremely disappointing to me that that testimony didn't get brought up till midnight. It was extremely disappointing to me to watch some of my colleagues attack some of the gun sense safety folks that had come up with misinformation. And so it took folks like myself and Representative Goodwin to say, wait a minute, I have a follow-up question, to give them an opportunity to make sure that their data was heard. And so representation matters. And having people who are gun sense candidates who are willing to go to bat and stay there and be there through all of the hurdles that are put up to make sure that your voice is heard is absolutely significant. And that's why your engagement in this process from beginning to end matters.
And when we think about different types of representation, Representative Johnson, I was hoping that you could explain a little bit for our audience here about, because we've mentioned the Calendars Committee a couple of times. It's a little bit unique to Texas, and I'm not sure how much our, in-person and virtual audience know the role of the Calendars Committee, and I know that our work with you, especially through our work in protecting children especially, and how your role has been in the bill process and what the Calendars Committee really does. So if you could explain that for us, I think that would be awesome.
Sure. So again, when we get elected, in whoever gets elected in November, we can start filing bills in December. And so when we talk about interim work, whoever you work with is going to start putting bills through Leg Council, getting language drafted, and then we can first file in December. So our mass shooter bill, I think the year before it was something like 2633 or some big number in the 2000s. This year it was 165, and that's because it was one of the first bills that I filed. And because it was 165, it gets referred to the floor and then referred to committee early. So it's one of the first bills that I can go to the chairman of that committee and say, please call this up for a vote. And so a low bill number matters. You see those bill numbers like 1 through 30 that either the lieutenant governor or the speaker may reserve for their priorities. So you could have a bill that's in the 2000s, but it becomes a speaker priority, and all of a sudden it's bill number 19. And again, that signals this is a high number, this is a priority. And so those are two different ways that you could get something to become either early in the game or a priority. It then has to go through committee. You have to have testimony once it goes through that. It then has to go through the committee process of having all the testimony, all the records from that hearing, and then at some point it gets transferred from the committee clerk to the Calendars Committee. Once it gets transferred to the Calendars Committee, it then comes up for all of those that are on calendars to look and either say, hey, this is a good bill, we want to try to get it through. Or there are some others that say, hey, we don't like that bill and we don't want to try to get it through. And then there's some things that are allocated to what's called major state. Major state is going to come up. And again, that's somebody else making a determination of what they think is significant for the state to listen to. And so one of the issues is when people talk about calendars, and I even have members that will say, hey, when you vote today on calendars, will you look at my bill? And I'm thinking that was 2 days ago, because by the time that the committee actually meets, the calendar is out at that point. It's just publicly out, and then you have it. And so the issue that happened here in 2744, again, I think it was an amazing moment that it got voted out of committee. I think that speaks volumes about the significance of the public involvement to say we need this to be heard. But I believe that was on May 9th, if I remember correctly, and the last calendar was on May 11th. And it did not go through that committee process to actually be submitted to calendars until the House calendar was already finished, because there is a deadline day of which is the last to be able to hear House bills, and there's a deadline day for the last to be able to hear Senate bills. And that's why it's also significant that what we need is we always need a House sponsor with a bill, and we need a Senate sponsor with a bill. So just like I mentioned, I'm gonna file my bill, I'm gonna try to get it up for a committee, I'm gonna get my witnesses there to testify. The best course is if the House is doing that on this side and somebody over in the Senate is doing it on the other side. And if we both pass the same bill, we get it done and it goes to the governor. If the House passes something with amendments, like Representative Goodwin talked about earlier on another bill, and the Senate passes it, then it goes to conference committee. And then you determine which of those come out of it. Again, have a quick vote in the House and Senate, and then it goes to the governor. But the issue there is about a commitment by the elected officials, regardless of party, to say these pieces of legislation are important, and I'm going to have a horse in the House moving it, I'm going to have a horse in the Senate moving it, and that's where you start to make traction and actually get things passed, as opposed to us trying to play defense, stopping some of the bad things that we saw, especially last session.
Absolutely. I think that just really highlights how we started off this session with it's really hard to get a bill passed, Moving on, according to a recent poll that came out of the University of Texas, 76% of Texans favor raising the purchase age to 21 for firearms. However, we all know our current policies that you have to be 21 to purchase a handgun, but 18 to purchase a long gun. what happens when there's such disconnect between public opinion and policy? And what can we do to help bridge this disconnect?
Yeah, I mean, we hear in poll after poll, and just in conversations with people, I can't tell you how many people who've come up to me and said, I'm a Republican gun owner, but something has to change, right? When it comes to our kids going to school and parents not feeling safe sending their kids to school, or whatever, going to the grocery store, movie theater. So there is a disconnect, but the thing is, again, it comes down to leadership. I will say, you know, the governor, lieutenant governor, and speaker really mold the priorities of the state, because the speaker has the option to select chairman of committees. In fact, this session, I was so bold as to ask the speaker to appoint someone to chair Homeland Security and Public Safety who would do something after Uvalde to bring about some gun safety regulations. And he did not take my suggestion. Representative Guillen, formerly a Democrat, switched parties, now a Republican, he represents a huge swath of South Texas, Rio Grande Valley. And he believes, because I had many conversations with him, he really believes that his district is so strongly in favor of the Second Amendment and their right to own guns that anything he does that weakens that right is going to get him unelected. He strongly believes that. And we had many circular conversations about, but what about the kids in our schools? What about safety? I will say that Republicans often will say, well, we need more armed guards in our schools. That's the solution. You know, our view is that's not the solution. More guns is what we have now. We keep loosening our gun laws, and that's not turned the ship around, right? The trajectory we're on is more and more shootings and more deaths and tragedy. And so, really, the leadership of the state, until they decide that we have to pass some gun safety legislation, it's a very steep hill to climb. In fact, I sometimes feel like we try to pass laws in a way that keeps it under the radar, right? I don't know about your bill, Representative Johnson. I know about it, but I don't think it was something that was really highlighted. It was kind of like, let's just get this passed quietly, right? I think the Dallas police officer that was trying to pass the ban on Glock switches would have liked to have had that passed quietly, because once it becomes highlighted, it becomes a harder bill to pass. So just gets back to leadership and their choices. And either we have to change their mind or we have to do it under the radar.
Yeah, so I would agree with Representative Goodwin. If more guns made us safe, then we would be in the safest place in the world. But obviously it's not, and we heavily disagree, and it generally is on a more partisan basis. Don't forget where we are now. We're in special session. That means anything we want to do is dictated by the governor. So if the governor said, I'm going to call a special session to raise the age, right, that would mean we'd talk about raising the age. And so Representative Goodwin is absolutely right. It comes down to leadership, and the leadership that we have right now. The governor has not shown any initiative in doing anything about guns. In fact, he, to the opposite, right? You can look at the tweets that he put out about we're second behind California. I want to see us going out and getting more guns. I mean, we fundamentally disagree on what will keep people safe with regard to guns. This last session, I had a chance to spend time with a young police officer who politically disagreed with me. But as we were sitting there talking and we were talking about guns, he said, you know, I was in the military, and I mean, yeah, I was a kid when I went into the military, but they didn't just give me an assault weapon. In fact, I had to check it out. And then I had to check out my ammunition. And then before I put it back, one of my supervisors came over and made sure I did everything right. So he also found it completely illogical at the idea that some 18-year-old kid could walk in and get a gun or assault weapon that he had in the military with high supervision and training. And he thought that it was outrageous at the idea that we would support it. Even though we politically disagreed, We absolutely agree on that issue. And so I do think it is groups like yourself that are trying to find common ground to say, look, you've got to break from what you perceive as a partisan norm and actually start passing things. But Representative Goodwin is right that breaking politicians from that partisan norm means results in elections. And right now, they believe that if they have anything to do with guns, they'll lose their seat. And in some circumstances, it may be that way because of gerrymandering, where the seat is and the district is so extreme on one position that they can't reach across the aisle and have conversations that truly are bipartisan. And so I think when you talk about how do we make progress, it's hard to not think about how districts are drawn, the way in which they're gerrymandered to effectively sometimes elections are only in primaries. And in primaries, sometimes people are running to a certain extreme, if you will. And so again, it's incredibly complex. But if all of a sudden statewide, a gun sense candidate won, people would perk up and pay attention and say, oh, now it's serious. It means something. I think what you saw in a couple of Republicans that went across the aisle is just like you're experiencing. The shock and the tragedy of the number of mass shootings that we see in this state, it's getting harder and harder for people to be immune from the real touches. I mean, you have so many members that know the family members, have seen them, have seen the suffering, and that makes a difference. But God help us if we need every state representative to have that personal experience until we change something. And so it's why you're necessary, and it's why your advocacy is necessary, and pushing to get it to a point where it's 90% of Texans that will say, this is the number one issue to me. This is the thing I care about the most. And when I walk into the ballot box, this is what's carrying my commitment to participate in democracy.
Absolutely, so well said. And we do have a question from the audience that came in. We've been talking a lot about the impact of firearm violence to youth as well. And given that gun violence affects youth so significantly, and young people don't vote because they're not old enough to vote, right? What actions can we do to engage our youth to advocate in gun violence prevention on various legislation as well?
You know, I think legislators, like anybody else, really appreciate when youth come and testify, and it speaks to us, it touches us. I will say in my other committee, the Agriculture Committee, we had a high school student come and speak so eloquently about something totally different, but she was the best speaker, and everybody on the dais recognized how well she spoke, how from the heart her story was, and it really made a difference. And so I would say getting kids, youth involved in advocating for things that they believe in, whether it's through an organization like Students Demand Action. I know that Moms Demand Action has set up some of those groups within some of the schools. I actually went and spoke to one at Lake Travis High School several years ago, but I think during the pandemic that fell apart somewhat, like some organizations did. But bringing those around, having student walkouts, I think that brings a lot of attention. I know the school administrators would hate me for saying that because they don't really like the student walkout, but I know that that's happened in the Austin area. Where students pick a time and a day and they together go walk outside the school to make a point, or coming to the Capitol as a group. So there's a lot of different ways that students can get involved, and it is something that we see. The legislators see that. They see that young people are concerned about this issue, just maybe not in large enough numbers yet, but I think we're getting there.
Yeah, I know as a candidate, when people and I would talk about issues, they'd say, well, if you feel differently, get out and talk to voters. And so that was my job as a candidate. Go knock on doors, go talk to voters. That's the significance. And so I think when elected officials see engagement from people, they care about if it's the kind of engagement that will make you show up on Tuesday in November and actually vote. And so when young folks turn up at the Capitol, when young folks turn up at the offices, and when young folks turn 18 and they register to vote and go through all the hoops that we have in Texas, because we sure don't make it easy, and then show up and vote every election cycle and know who their gun sense candidates are and vote for those folks, that's when you're going to see people get scared and make a difference. My colleagues know Twitter doesn't pick elected officials, voters do. And so it's all about student engagement to get them to the polls and get them voting for the people that they know are actually gun sense candidates.
Excellent. It's so encouraging to hear that both of you guys see a shift in the climate, right? And I agree with you. There's some subtle movements in the legislature, and the needle needs to keep moving, right? What can we do as researchers and in healthcare and in public policy to help continue to keep that needle moving, especially as we move into the interim and then looking forward to the next legislative session?
I'll say, as a prosecutor, I've seen videos, I've seen dead bodies, I've seen the awful images. So having been a prosecutor, I have had the shock value of gun violence. I thought it was very telling when, after the Allen mass shooting, and there was real-time video of devastating things that people don't want to see, that all of a sudden there was talk about, let's ban people from actually showing the actual impact of gun violence. I get it. You don't want people to see that. You don't want folks in their last moments to be exposed in that way. But the information has to get out. And we have to describe to people and explain to people the suffering that people feel, the trauma, just like you talked about. The number one killer of kids is guns. I mean, these are real facts. And it's breaking through that rhetoric that people say about, oh, Second Amendment or misinformation, and saying, no, these are real facts. And we are constantly being bombarded with misinformation and disinformation politically on multiple issues. And this is one as well. The more engagement you can get with people around the real facts around gun violence, around the impact, and the way that the laws that we pass in Austin, how they have a direct correlation to either protecting you or not protecting you from those harms. And so information to me is key. And that's why I think you're so important.
And I think also building coalitions. So last year, prior to session beginning, I was approached by a pastor in my community who said, I really want to take on this issue. I personally can't continue to see the gun violence in our communities, in our state, and I need to do something personally. He said, you spoke about this issue, so you tell me what I can do. And so I gave him a number of suggestions, and he followed up on that. And he got Texas Impact, which is a large organization of pastors and reverends around the state who advocate. They added that to their agenda for the first time this session. Building those coalitions where you're bringing in as many people of different backgrounds as possible will make a difference, because somebody is going to be able to speak to the representative in their area and change a mind. You know, we listen to the people in our district, so that's the challenge. I told him, if you could find more reverends or pastors in rural areas to speak to those rural representatives who are on the other side of this issue, that would be really helpful. So it's, again, building coalitions so that we can get people talking to everybody, not just those of us already on board with gun safety.
Well, I think some of the other questions that we have coming in really come around the concept and the ideas around can safety be the key message that helps to unify and help to move the needle on gun violence, and can that be something that we can unify the messaging around, and is messaging really the vehicle that we utilize to move legislation, and how can we utilize that?
Yeah, I think so, absolutely. I think everybody can relate to sending their kid to school and feeling concerned. I think everybody can relate to when a child says, hey, there was a school safety drill today, and it just, you know, it messes with their emotions for that entire day, maybe multiple days. I think we can relate to the concern, particularly when we have just had a shooting, Allen, for example. I mean, it just seems like there's one after another to where we start forgetting those that happened just a few years ago, El Paso, Midland, Odessa. You know, I think talking about, well, if you don't agree with me on this piece of policy, how do we keep our kids and our community safe? You know, we spend a lot of time talking about mass shootings, but honestly, more people die by suicide, by gun, and a lot of veterans. So maybe we take something like that and reach out to the veteran community in particular and say, what might help? Are we seeing that people are doing this with maybe a waiting period would help, that cooling down period. I was listening to something on the radio the other day about the straw purchase issue, and again, I thought maybe in that kind of a situation, a waiting period would help, where someone can't go buy a gun impulsively and sell it for cash immediately. So maybe trying to have the conversations where you say, we don't agree on this, but did you think about this other reason? And how would you address it? And opening up that conversation. I know right after Uvalde, when we were having the joint hearing that Representative Johnson was talking about, one of the members of that joint committee is a nurse. And she and I were in the back room grabbing a bite to eat. And I asked her, don't you think, she's Republican, so I was thinking she may or may not be on board with raising the age, but I said, don't you think it makes sense to raise the age from 18 to 21 for someone to be able to purchase a semi-automatic weapon? And she said, no, I don't think it makes sense. And it was astounding to me, but I think from there you just keep the conversation going. What was her rationale? Well, how can I counter that rationale? And you just keep that conversation going. It's going to take a lot of work, but you know, those of us that believe that we're safer with fewer guns or with more regulations around our guns, we're going to keep having those conversations, and ultimately we're going to change more hearts and minds.
Agreed.
I certainly think that keeping the conversation going is where we need to be. And today has been the theme of conversations. And we want to continue conversations even beyond today, because today cannot just be about one day, one event. And we've heard a lot of conversations around school safety, suicide prevention, unintentional firearm injury prevention, and community violence, and domestic violence as well. And looking at the whole depth and breadth that we've had today, what we do all can agree on is that nobody should die by a firearm, right? And what our goal is to see how we can collaborate with our communities and with our legislation and legislators and our leaders to see how we can impact this. But there's not one single way to prevent firearm injury. And we need to all work collaboratively and collectively to reduce this, because at the end of the day, lives matter. All lives matter. And we need to make sure that we can protect our children, our community, and our state. And in closing, I'm going to give, since we're at the end of our day, I'd like to remind everyone here that if you'd like to continue to keep the conversation going, definitely write your name or email on one of the notepads, and we'll collect that at the end of the day. And I'd like to allow each of our legislators to give us their priority of what they'd like to do to see over the interim, and for their legislative priority on how we can help to reduce gun violence. So.
Oh my gosh, you know, session has just ended and I feel like we have to have that little decompression moment before we start thinking about what we do next session. But I will say my 3 key pieces of gun safety legislation were background checks, making sure everybody has to go through a background check. Basically, we have some loopholes right now that I think we're all aware of, going to a gun show, you know, private sellers, and someone that has a handgun license that then assaults somebody else, they could still go into certain gun stores and buy a gun without a background check just because they have that handgun license. That was one of the loopholes that I tried to close this session. Got that bill out of committee, but it didn't get past that point. So background checks, improving those, a waiting period. I think, you know, we used to have a waiting period that went away, but I think that it would be worthwhile to bring that back. And red flag laws. Like See, particularly in the case of the Allen shooter, there were some serious red flags. There were some very serious red flags. He was a member of a hate group. He had Nazi indications in a number of different places that should have brought some red flags, and someone should have been paying attention to that. So I think that we need to look more at what we can do around protective orders and flagging people as an imminent threat, or better law enforcement, essentially. So those are some things that I'll continue to work on. We may have to tweak some of the bills that we have. I also think we need to go back to where we had training. We have permitless carry now, where people really don't have to get any training before they can go carrying their gun down the street. I think we need to get back to where we say we really do need training. So those are some things that we'll be working on, trying to flesh out what we take forward into the next session.
I would love to see us work on the hearts and minds of the lieutenant governor and the governor. Representative Goodwin mentioned it earlier. We've actually seen some really good things pass the Texas House. I think you've seen the Texas House take some incredibly important steps on a variety of issues. For example, one is criminal justice reform issues. We've passed a significant number of pieces of legislation that would be mindful of kind of the whole system and infrastructure in public safety. And when they all get to the Senate, they go nowhere. And so I think we also here, just as one of the reps said, if we could get this to the floor of the Texas House, it would probably pass the Texas House, but it would be a non-starter in the Senate. And so there are two chambers, and there's a governor that needs to sign it. And so I think that you need to start seeing a commitment from the leadership in the Senate and the governor saying, hey, this is an issue of which we keep banging our head against the wall. We keep having mass shootings, and they keep forming committees, and they keep passing out thoughts and prayers, and we just keep having mass shootings in Texas. At some point, they're going to have to give us a different answer. And the two I would love to see, and I think you would as well, that to me are kind of no-brainers, is let's raise the age from 18 to 21 on assault weapons, and that would almost completely eliminate the issue of what you have in school shootings of a young individual that has a connection with that school that goes back. If you look at the statistics on that, most of those offenders are under the age of 21. And so it would make a big difference to say that you can't have access. But let's even take the case of Uvalde. He was known as school shooter. He was known online in that way, and his family refused to let him have access to a weapon. And so extreme risk protection orders are absolutely the way to go. And it's what Florida's done. And we seem to politically always want to compete with Florida. And so a lot of times, Representative Goodwin and I are saying, hey, can we just do what Florida's done here and pass an extreme risk protection order that says if the mother of a shooter who drove from Dallas to El Paso to slaughter a number of people because he had been inspired by hate, when she had been calling the police and saying, I need help, there's something wrong with him and he has these weapons, and law enforcement has to say, can't do a thing, we ought to be able to fix that. And extreme risk protection orders would do just that. So those are the two things I think most common sense folks would agree would make a big difference, can get done. We just need the political will from the leadership in all three phases of our legislative process to say they're in and they're ready to start acting.
Well, thank you so much, Representative Goodwin and Representative Johnson, for your time and your dedication today. And let's keep the conversation going, and let's change some hearts and minds. Thank you.